disorders, and also a national trainer in psychosocial intervention in disaster management. I'd like to welcome for the session, ma'am. I would like to hand over the session on to our chairpersons right now. Thank you.
Good morning. I don't know whether the hall being so full or empty is going to make a difference, but I'm sure we're going to have some very exciting presentations from students who've worked in or who are doing their post-graduation or working in mental health. And it's a privilege to have two other distinguished personnel on the panel for chairpersonship. And we'll thank IOTA, ACOT, and the scientific committee for giving us this opportunity without wasting time, because time is an essence from today onwards. So we'll straight away go into the presentations. I think all the participants have been apprised about the rules, so I'm not going to go through it again with you all. There's a timer that's going on, but there will be a bell at the end of the 8th minute for you to be aware of time. And competitive papers, please understand, please stick to your time, because time will also be one of the parameters for evaluation. So without further delay, I'll hand it over to my next chairperson to introduce briefly the people in the order, and they can come up and present. You can go down after your presentation. We will call you back as a group upstairs onto the stage, where you can actually introduce yourself briefly, and then we'll entertain max of 2 questions. If the scientific committee does restrict, then it'll be just 1 question per person.
Hello. Hello. Yeah. So, good morning to you all. It's a privilege coming here for the Oticon. And I thank the scientific committee for giving me this opportunity. So, without further delay, I would like to call upon the various presenters. We have first here the paper titled Determining Correlation Between Perceived Social Support and Depressive Symptoms in Lower Limb Amputation by Dr. Aishwarya Valiant from Goa. Next, we will have impact of freezing weathers on mood and stress level in the people of Kashmir, an occupational therapy perspective by Dr. Sahib Yusuf Dar. He's coming from New Delhi. Third in line would be effectiveness of occupational therapy with mindfulness training on mental health of parents of children with autism, and this will be delivered by Dr. Avasti from Chennai. Fourth in the line would be understanding the correlation of social cognition and work behavior of persons with mental illness in India, a cross-sectional study, and this would be presented by Dr. Chandelkar Shivani from Goa. Fifth in the line, we have knowledge, perception, and attitude towards occupational therapy services among healthcare professionals in India, a cross-sectional survey. And this is being presented by Dr. Pramod Dattaram Lambor from Manipal. And at last, we have impact of flipped classroom on clinical skills for undergraduate occupational therapy students, and this is being presented by Dr. E. Mona, who is an assistant professor from Chennai. So we are all looking forward to your presentation. All the very best to all the speakers. May I call upon the first one?
Yes.
Dr. Aishwarya Valia from Goa. Can you please come up and do your presentation?
Good morning, everyone. Good morning, everyone. My topic is determining correlation between perceived social support and depressive symptoms in lower limb amputation, a quantitative study. It's not happening.
So next.
I pressed so.
Next. Not true. Stop timer. Stop timer. You can on again. Hold. Start.
Determining correlation between perceived social support and depressive symptoms in lower limb amputation, a quantitative study. The amputation of a limb brings about changes in the psychological and social functioning of an individual. Such changes may reduce an individual's ability to maintain emotional well-being and promote maladaptive reactions leading to psychosocial maladjustments such as anxiety and depression. In India, awareness of psychological challenges remain low and overlooked, leaving individuals at risk of isolation and poor quality of life. Few studies have explored the correlation between perceived social support and depression in lower limb amputation, with no research conducted in the state. This brings me to the need of the study. The prevalence of psychiatric symptoms among lower limb amputation individuals ranges from 32% to 84%, including depression rates ranging from 10.4% to 63% in India. Adequacy of social support is directly related to the reported severity of psychological and physical symptoms, which acts as a buffer between stressful life events and symptoms. The purpose of my study was to determine the correlation between perceived social support and depressive symptoms in individuals with lower limb amputation. The objective of my study was to understand these two variables using multidimensional perceived social support scale and Beck's depression inventory. The methodology that I used was, the research design was quantitative cross-sectional design. Study setting, the study was conducted in tertiary hospital setting. The sample size and selection was 85 participants were recruited for the study, and data was obtained from inpatient wards using non-probability convenient sampling method. The inclusion criteria was as follows: lower limb amputated individuals with single, multiple and bilateral amputation, age 15 to 60 years of age, and should have understanding of English, Hindi and Konkani languages. Exclusion criteria was upper extremity amputations, age below 15 years and above 60 years, any other orthopedic or neurological condition, diagnosed with any other predisposed mental health disorders. The data collection and analysis was done in this sequence. Approval from the IC board was taken, selection of the study participants was done, consent was taken, and administration of MSPSS and BDS2 scales were done. Statistical analysis using SPSS program and results were obtained. This demographic table shows me that the age was on an average 53 years with standard deviation of 7. Male and female participants were 65 and 20 respectively. Levels of amputation in the participants were bilateral, transfemoral, transtibial, foot and digit amputations, respectively showing the number of participants participated in the study. This graph shows us the correlation between MSPSS and BDI2. On the x-axis, I have multidimensional scale of perceived social support, and on the y-axis, I have Beck's depression inventory. The plotted graph shows me a downward curve. A negative correlation was found between the two pre-designed measures with value of negative 0.328 using Pearson's correlational statistical method. This indicates there is an inverse relationship between perceived social support and depressive symptoms in the study population. The findings of this study reveal a negative correlation indicating that higher levels of perceived social support are associated with lower levels of depression symptoms in the study population. A study conducted by Arupendra Majumdar et al. 2010 also presents common findings, as the study showed high depression was associated with many social and economic factors. It was found in a study done by Noure Simsak et al. 2020 that individuals with post-traumatic lower limb amputation changed their emotions and behaviors after amputation. To quote this study, their body image and self-esteem were negatively affected. Their families and the society differentiated themselves, and the study also found the need for mental support to develop coping skills. This study has common findings to my current study. The correlation nature of our findings precludes that establishing causality between the two variables assesses how changes in social support influence mental health of patients. Thus, the need for occupational therapy intervention for the same is crucial. The limitations of the study were as follows. The sample size limits the ability to generalize these findings. The study relied on self-reported questionnaires and to collect the data which may have led to response bias. Use of a convenient sampling method which may not fully represent the target population. Patients were not categorized based on the severity of symptoms, that is intensity of depression, mild, moderate, severe. Potential confounding variables such as socioeconomic status or prior experiences were not controlled in this study. The scope of my study is as follows. This study explores how emotional and practical support from family, friends, and community impacts the risk of depression following lower limb amputation. It also examines the role of occupational therapy in improving psychosocial adjustment, rehabilitation, and quality of life of amputees. As one of the first in the state to investigate this correlation, the findings could guide future interventions, support programs, and inform clinical practices and social policies to enhance amputee care and well-being. To conclude, perceived social support has an impact on depressive symptoms in individuals with lower limb amputation. The study indicates that individuals with lower perceived social support were more likely to experience higher levels of depression symptoms post amputation and vice versa. These were the references that I used for this study. To acknowledge, first and foremost, I extend my sincere gratitude to the Dean of my institute for his support. I am also deeply appreciative of the IC committee of my institution for their approval and for ensuring that all necessary procedures were followed with utmost professionalism. My profound gratitude goes to my research guide whose invaluable insights have been pivotal through this process. Lastly, I would like to convey my deepest appreciation to my friends and family and my late father, whose unwavering support, patience, and motivation have been a source of strength and inspiration. Thank you.
Thanks, Aishwarya. Good job. I have two questions, clarification basically. So,
At the end of session.
We'll go to the next presenter. And then
oh, we are open for the questions now from audience.
no. I'm sorry, let me just, we'll wait for the questions to the end. So can we have the next participant, the candidate, please up on stage? We'll wait, Aishwarya, can you go down? And then we'll get you all on stage and then we can have the questions. Yes, at the end. We'll get them all on stage. Let them introduce themselves and we'll have two questions.
The next person is Dr. Sahib Yusuf Dar from New Delhi, and he's going to speak on impact of freezing weather on the mood and stress level of people in Kashmir, an occupational therapy perspective. Good luck.
Good morning, everyone. My name is Sahib Yusuf Dar, and I'm from New Delhi. Today, I'm going to present in front of you impact of freezing weathers, winter on the mood and stress level in the people of Kashmir, an occupational therapy perspective. Introduction to my presentation. The Kashmir Valley experiences prolonged and severe winters from November to March, with January being the coldest month, which is locally referred as Chilai Kalan. Extreme temperatures, heavy snowfall, and limited sunlight. These significantly impact the daily life, leading to economic disruptions, seasonal migration, and adverse psychological effects. Research indicate a strong correlation between seasonal change and mental health, with conditions such as seasonal affective disorder that become very prevalent during the winters. SAD is a subtype of major depressive disorder, and it manifests as recurrent depressive episodes that are linked to seasonal variations. Occupational therapy plays a vital role in the management of SAD by integrating biomedical and psychosocial approaches, evidence-based interventions such as cognitive behavioral therapy, mindfulness-based cognitive therapy, behavioral activation, and outdoor therapy. These are very important and utilized to enhance psychological resilience and improve overall well-being. This presentation examines the impact of Kashmir's harsh winters on mental health and highlights the role of occupational therapy in mitigating seasonal mood disorders. Now, the rationale of this study, research indicates that mental health concerns in Kashmir are often overlooked, with individuals neglecting mood impairments and elevated stress levels ultimately impacting their quality of life. Despite the psychological challenge posed by harsh winters and socio-environmental factors, awareness and access to mental health services remains limited. Additionally, studies highlight a significant lack of awareness regarding occupational therapy and its role in supporting mental health services in supporting individuals with mental health conditions. This underscores the need for targeted interventions and awareness initiatives to promote mental well-being and enhance access to occupational therapy services in the Kashmir region. The aims and objectives of this dissertation are to examine the influence of severe winter conditions on mood and stress levels and to associate the relationship between cold weather and key psychological parameters that include mood and affect. Methodology. A cross-sectional survey was conducted amongst communities in Srinagar and the weather was peak winter, that is 20th of December all the way to 31st of January 2021, and the average temperature to be noted was -3 degrees Celsius all the way to 4 degrees Celsius. It was a convenient sampling and the sample size was 97. Inclusion criteria included adults who were working and were in the age group of 35 to 50 years. Exclusion criteria: not willing to participate, who could not understand and respond to the questions, and especially who were not the native residents of Kashmir. Outcome measures that are used were perceived stress scale and seasonal pattern assessment questionnaire. Perceived stress scale that was developed by Cohen et al. And it evaluates the extent to which situations are appraised as unpredictable, uncontrollable, and overwhelming. Seasonal pattern assessment questionnaire mostly used in most of the research related to seasonal SAD. SPAQ is a self-reported tool and it evaluates change in sleep, appetite, energy levels, and social activity across different seasons. It was developed by Rosenthal et al. Then the data analysis and results. Data was compiled in a master chart using Microsoft Excel 2010, and descriptive analysis was conducted through percentage calculations and pie charts. SPAQ has 5 sections and the results are as follows. The section 1, it revealed that during extreme winters, most of the participants felt worst, ate more, tend to sleep more, socialized the least, and gained more weight. Whereas most of the participants felt their best mood in summer and spring seasons. Next section is change in quality of life. The section 2 revealed that participants felt moderate change in the sleep length, social activity, appetite, and energy levels. Additionally, most participants reported marked change in their mood during the winter season. Section 3, difficulty in coping with seasonal change. 57% of the respondents found it difficult to cope up with seasonal change. And section 4 revealed that 29% felt a weight fluctuation of 0 to 3 lbs, while 31% felt a fluctuation of 4 to 7 lbs in their weight. Fifth section, change in food preference. 58% of the respondents reported that it was difficult to cope up with the change in food preference, and they used to change their food preferences with the change in season. The perceived stress scale, that was one of other outcome measures, it revealed that 69% of the participants experienced moderate stress levels, while 23% experienced high stress levels during the winter season. Discussion. The study highlights the significant impact of freezing weathers on the mood and stress levels of residents in Srinagar, Kashmir. Stress was very prevalent, with 69% reporting moderate stress and 23% reporting high stress. This study aligns with Rohan et al. 2003, which identified negative thought patterns and reduced activity levels as key contributors to seasonal affective disorder. Then 59% of the participants experienced moderate to extreme mood change, and 38% reported low to extremely low energy levels during peak winters. These results support Etima et al. 2017, which demonstrates the influence of weather conditions on mood and life satisfaction. 57% participants found difficulty to cope with extreme winter conditions, 31% noticing minor weight fluctuations, and 5% experiencing significant change. 58% of the participants reported shifts in food preference. findings align with the Michalak et al. 2003, which emphasized the role of seasonality, negative life events, and reduced social support in mood disorders. This study had valuable insight but still had limitations. The small sample size limited the generalizability. The COVID-19 pandemic posed challenges in participant recruitment and in-person assessments. Future studies should incorporate on treatment-based studies on SAD, emphasizing rehabilitation and preventive strategies, and also should focus on specific SPAQ factors like stress, mood change, and quality of life. Conclusion. Extreme winter conditions significantly impact well-being, emphasizing the need for targeted interventions and resilience-building strategies to improve quality of life in harsh climates. These are the reference. Thank you so much.
Thanks, Dr. Saib. Next presenter is Dr. Avasti V from Chennai. And her topic is effectiveness of occupational therapies with mindfulness training on mental health of parents of children with autism. Good luck.
Thank you, sir. So, good morning, everyone. I'm Ashwati, and I'm delighted to have this opportunity to present my research on the topic of effectiveness of occupational therapy with mindfulness training on mental health of parents of children with autism. So, parenting a child with autism is often stressful compared to parenting a children with other disabilities. This is due to the unique challenges associated with autism, such as difficulties in communication, social interaction, and the repeated behavior, as well as it leads to unpredictable of the daily routines. Parents often experience a high level of stress, anxiety, and emotional exhaustion, which significantly impact their mental health and the overall well-being. Occupation therapy focuses the daily occupation and the quality of life, while mindfulness training helps the individual manage the stress, fostering by the present moment awareness and the emotional regulations. So, hereby the need of the study was, because of the higher level of stress level, it significantly impacts the mental health and their capacity to provide the effectiveness care of the children, while the intervention primarily focusing on the children and the mental health needs the parents of often neglected in both research and the practice. Occupation therapy combined with the mindfulness training offers a holistic approach to reduce the stress and enhances the emotional resilience. There is a limited evidence on the effectiveness of integrated approach. This study aims to address this gap by examining how OT with mindfulness can improve parental mental health and ultimately benefiting both the parents and their children with autism. The aim of the study is to determine the effect of occupation therapy with mindfulness training on the mental health of parents of children with autism, and the objective was a study to compare the pre and the post-stress scores of occupational therapy between the control group and within the control group. So, it was ethically approved, and the study used was a quasi-experimental study, and the total participants was around 60 participants and required to the convenient sampling method with the sampling formula, and the inclusion criteria included in the study was the children with the age of 3 to 8 and the parents with the age of 22 to 35, and no more the children 3 in the family, and the ISA score was up to 70 to 153 for the child, and excluded was no prior mindfulness based therapy, and also the history of mental illness and the current medication use, and the missing more than 2 sessions were excluded in the study. So the baseline assessment was done by the general health questionnaire and the 5-facet mindfulness questionnaire, and the randomization was up to like the experimental group receives mindfulness training and the occupational therapy, where the control group receives only the occupational therapy for 8 weeks for 45 minutes. The post intervention was assessed by the general health questionnaire and the 5-facet mindfulness training questionnaire. Later the data was analyzed and it was compared between the experimental and the control groups. So the instrument used is one is the screening tool was ISA, and it explains about the social, emotional and the communication, sensory aspect and the cognitive aspect. And for the outcome measures, we use general health questionnaire and the 5-facet main questionnaire. And the intervention was for the mindfulness training. According to the Ferroli protocol, it was introduction of the mindfulness principles and the non-judgmental acceptance, reducing the stress mindfully, identifying and distancing thoughts, mindful communication, staying present, focusing on the pleasant events, and then being effective was used. And for the occupational therapy, we used coping strategy, parent training intervention, relaxation technique, group therapy, and the social skill training was used. This image explains about the mindfulness training and also the occupational therapy. The results says that the demographic data of the mothers is primary caregivers was up to 70% in the mothers, and the nuclear family was about 65%, and the lack of sibling is by 71%. These studies aligns us with the Betsy and the Hazen-Watson, which highlights the need of intervention like mindfulness-based occupational therapy. This study says the pre-test and post-test comparison in the experimental group, and it was done by the paired p-test with a significant improvement in the mental health, and it shows these findings have improved the effectiveness and the parental well-being of the families of the children with autism, and it was supported by Ken and Bagel. This shows the pre-test and post-test scores in the control group, which it is supported by the CAMISA, and it shows the effectiveness of integrating occupational therapy with mindfulness-based intervention, which improves the coping strategies and also the child outcomes in the families affected by the autism. So this is the pre-test scores, which is not significant. So we done the post-test. The post-test shows that there is a non-significant scores among the anxiety and the severe depression, which is also aligned with the other studies by pair in the anxiety and the severe depression. So the lack of the significant depression supports the intervention of potential in clinical and the communication settings. So the limitation of the study was the lack of diversity and the limited of the parent age between 22 to 35 with the children of age 3 to 8. And the self-reported measures causes the potential biases in the general health questionnaire and the FFMQ questionnaire, which may be overrate or underrate these scores. There is a limited exploration of the child outcome, which focuses on the parental mental health. So the implication of the study, it will improve the mental health of the parents of children with autism, and also it approaches the stress, anxiety, depression while enhancing the emotional regulation and the mindfulness skills. So it concluded that the positive outcome of the combining occupational therapy with mindfulness training for improving the mental health of parents of children with autism. This study shows reduction in the stress, anxiety, depression and improvement in the mental skills, highlighting the intervention potential to supporting the caregiver well-being. So the recommendation of the studies incorporate with the objective measures which physically market to reduce the bias, and also the cultural adaptation like ensure the effectiveness and the acceptable, and explore the different genders, include both males and the female of the caregiver, and it focuses on the undeserved population like social economic status and the rural communities for the study. These are my references. And thank you.
Thank you. Just a small change in the routine that we are practicing. Can we have the first presenter, Aishwarya, on stage, please? Aishwarya needs to be at the Young Graduates Award written exam, so an exception is being made for her to get the questions that is addressed to her. 2 questions from her to her, and then she will be away for the examination.
Thank you, sir.
Any questions for Aishwarya, please? Can we have a mic being passed to the audience so that the audience can, the larger audience can understand what the question is, please?
Aishwarya, I'm not an occupational therapist. Good study. But Were all your patients only males or there were females also?
Sir, my patients were 65 were males and 20 were females.
Okay, now just the question to that.
Yes, sir.
In how many males there was depression in the spouse, the female, for cooking well and making the husbands fall so sick because they were all diabetics?
Sir, may I request you to say again?
In how many male diabetics were the female cooks? That's why the diabetes is out of control. And that is why they got amputation. How many were there?
So in this study, we have not gone into the details of reasoning of why the amputations were done. I have only considered the levels of amputation in this study, and it is out of scope, and that is a limitation. Thank you, sir.
But Aishwarya, just to supplement that question, you had put up your inclusion-exclusion criteria saying those with neurological and orthopedic reasons for amputation were not considered. Right? So
Yes,
what are the main cause for amputation in these individuals that you studied in your, took for your study? The cause for amputation. That's important.
Yes, sir. So for the amputations, I had mixed population as in traumatic and elective surgeries. So for the elective surgeries, main cause was diabetes, and as well as traumatic participants were taken into the consideration.
Look at the larger picture of diabetes. There's a vascular insufficiency and there is a neurological polyneuropathical problem. So there is a connection to neurology there also.
Understood, sir.
So,
Noted.
but in diabetes, it's mostly vascular. If there is neurology, the wounds heal because the vascular supply is there. If the vascular supply is not there, the antibiotics don't reach the wound, and that's why the wounds don't heal. So I think most of our population was vascular.
Was vascular, sure. Any other questions for Ashwini? Ashwini, just a couple of clarifications. You said perceived support.
Yes, sir.
So why did you prefix perceived before support? It's something which, if you support me, it's how I understand your support, is what support is all about. Okay, so why did you intend to have perceived support there?
Sir,
Any reason?
Yes, sir. So as a point of view, speaking from the patient's point of view, I would say that whatever my perception is, that is what I have studied here. So whatever patient's perception is, no matter the social support is good or bad, because as I am studying depression in this study, so that's why the perception is of utmost importance to be looked at. Because if I only evaluate the social support as good or fair or poor, it doesn't really talk about how the amputee is feeling, and that's why the perception is why I've considered.
Sure, thank you. Any other questions?
Sir, I'll supplement.
Please.
Whenever you have sick people in the hospital, sir, the relatives support the patient much better with a caregiver, etc., or even with the neighbors, the relatives and all that. But once the patient goes home, I'm in geriatric medicine, once the patient goes home, all this help is lost. And the support comes only from the spouse or from the child who is not working. And that is why it's very important to know the actual support than what you see in the hospital.
Yeah, and if you look at support, it's a two-way street. It's what the patient gets from the family and what the family is actually able to provide, because there's a quantum that the family can provide. So that's again something which is very, very important in your study, because the family is given just about everything. But if it's perceived by the person as limited or skewed, then there is a huge problem here, and the dimension and the cause for depression is a very tangential reason.
Yes.
The family can do nothing more. They need to go to work. Their physical presence not go. So these are things that, of course, you're going to do further research, but these are key things, and I think Sir had a very important point there, that you need to look at it from both ends.
Yes,
Thank you, Aishwarya.
Yes, sir. Thank you, sir. Thank you, everyone.
Next presenter.
Hello. Next presenter is Dr. Chandelkar, and excuse me, he's going to speak on understanding the correlation of social cognition and work behavior of persons with mental illness in India, a cross-sectional study. Dr. Chandelkar, thank you. Good luck.
Good morning, everyone. So, the topic of my study is titled as Understanding the Correlation of Social Cognition and Work Behavior of Persons with Mental Illness in India, a cross-sectional study. Social cognition plays a vital role in occupational success. It encompasses theory of mind, emotion recognition, social perception, and attributional styles. These abilities are crucial for effective workplace interaction. Schizophrenia is characterized by significant impairments in social cognition, leading to difficulties in understanding emotions, interpreting social cues, and maintaining communication. Such deficits contribute to social withdrawal, workplace challenges, and reduce employment opportunities. Impairments in theory of mind can contribute to social withdrawal, while difficulties in emotion recognition hinder relationships and workplace collaboration. Additionally, attributional biases such as self-blame and pessimism can create challenges in social interaction and workplace dynamics. Cultural factors play a significant role in shaping social cognition, making it essential to use assessment tools that account for cultural nuances. In India, such tools help ensure interventions align with local social norms. Work behavior is essential for social and professional integration. A holistic approach to intervention is necessary, integrating cognitive training, structured assessments, and targeted techniques to address social cognitive deficits effectively. This brings me to the need of study. Work plays a crucial role in an individual's identity and mental well-being. Studies have shown that unemployment rates among individuals with mental illness can be as high as 90%, despite evidence that employment significantly improves clinical outcomes such as symptom management, medication compliance, and relapse rate. There is a limited research focusing on correlation between social cognition and work behavior, especially in the context of individuals with mental illness receiving occupational therapy. Addressing this gap is essential for developing targeted interventions that enhance employability and improve mental health outcomes. The aim of my study was to explore the relationship between social cognition and work behavior among persons with mental illness in India. The objective was to understand the correlation using Socrates and work behavior assessment, to evaluate the role of theory of mind and attributional bias, and assess gender differences in social cognition and work behavior. Study design employed was cross-sectional, correlation cross-sectional study. The setting was a tertiary psychiatric hospital. 50 participants with mental illness receiving occupational therapy were included, and sampling method chosen was non-probability sampling. Instrumentation used was social cognition rating tool in Indian settings. This is a tool which is developed by Niemans, and the work behavior assessment, which is a standardized assessment for the work behavior of psychiatric patients. The inclusion criteria included patients receiving occupational therapy services in a psychiatric hospital. All participants who could comprehend in Hindi, English, and Konkani language were selected. Participants were aged between 18 to 60 years and those diagnosed with schizophrenia according to ICD-10. Exclusion criteria included dual diagnosis such as neurological disorder, developmental disability, or substance abuse, change in psychiatric medication within 30 previous days, and outpatients receiving occupational therapy. Procedure employed was institutional review board approval was taken. Participants were recruited based on inclusion and exclusion criteria, and signed consent was taken from the patient as well as the nominated representative. Administration of Socrates and work behavior assessment was done, and data collection and statistical analysis used was Spearman's correlation and Mann-Whitney U-test. Statistical analysis shows that data was entered into Microsoft Excel and analyzed using statistical software such as SPSS. Descriptive statistics summarize the demographic and clinical data, while inferential statistics, including Spearman's rank correlation coefficient and the Mann-Whitney U-test, examine the relationship between variables and gender differences. Scatter plots visualize the correlation between social cognition and work behavior. The significance level was set as p less than 0.05. Coming to the results, gender differences. Mann-Whitney U-test revealed no significant gender-based differences in social cognition or work behavior scores, indicating that both males and females exhibited comparable performance in these domains. Scatter diagram of this is a scatter diagram of the correlation between social perception and work behavior. There was no significant correlation found between social cognition components, that is emotion perception, theory of mind, and attributional styles, and work behavior, suggesting that social cognition alone may not directly influence the workplace performance. Coming to the results, externalizing bias, that is blaming others for negative outcomes, is slightly higher in females than in males compared to the personalizing bias, that is attributing personal events personally, is same between males and females. Social perception was nearly identical. Coming to the discussion, There is a complex interplay between social cognition and work behavior. Since there was no direct correlation between social cognition and work behavior, work successfully is influenced by workplace culture, supervisory support, and adaptive behaviors, as seen by in a prior research by Griffith in 1973 and Pickingham in 2014. Cultural and contextual factors in India. Collectivist values and family involvement significantly influence vocational success, as seen in a research conducted by Chakrabarti et al. In 2011. Gender neutral findings. There was no significant gender differences in social cognition and work behavior, as seen similarly in Lendermeyer et al. 2012 research and Tendon et al. 2014. Challenges the traditional gender stereotypes and supports the need for individualized, inclusive rehabilitation strategies. Broader determinants of work behavior, psychological, social, and environmental factors play a crucial role. Workplace accommodation like flexible schedules and supportive supervision enhance retention, as seen by a research in Kukla et al. 2016. Coming to the implications for occupational therapy, OT plays a crucial role in bridging social cognition and work behavior. Therapists should adopt a holistic approach addressing cognitive, social, and environmental factors. Collaboration with employers, family, and communities is essential for long-term success. Advocacy for inclusive workplace policies can empower individuals with mental illness to thrive. Coming to the limitations, the relatively small size may have reduced the statistical power, limiting the generalizability of findings. The use of non-probability sampling could have introduced selection bias, affecting the representativeness of the sample. The cross-sectional nature of the study restricts schedule inferences, as it does not account for change over time. And limited measure, the study primarily focused on social cognition and work behavior without integrating additional factors such as employer feedback or job retention rates. Context-specific bias, cultural and societal influences unique to the study's location may affect the applicability of results in different settings or populations. Future implications should focus on larger and more diverse samples and longitudinal studies. Broader determinants like resilience and workplace stigma along with cultural influences will provide deeper insights. Integrating assessment tools such as employer feedback and job satisfaction can enhance analysis. And lastly, developing holistic interventions that combine social cognition training with workplace strategies will improve real-world work performance for individuals. Coming to the conclusion, work behavior scores do not significantly differ between males and females. Theory of mind components, attributional styles, and social perception do not significantly differ between the genders. No significant correlation exists between work behavior and the social cognition. Further research is needed to explore other psychological, environmental, and occupational factors. I would like to acknowledge my gratitude extends to the director and head of department of the Institute of Psychiatry, dean of my college for the encouragement and support. Special thanks to professor of occupational therapy and in charge of occupational therapy for his insights and assistance. I sincerely thank my guide and co-author for his invaluable guidance and support. Thanks to the statistician for their expertise and assistance, and also all the doctors and staff of the psychiatry department for their cooperation. Lastly, I deeply appreciate the participants of this study for their valuable contributions. These are my references. Thank you.
Thanks, Dr. Chandelkar. Next presenter is Dr. Pramod Dattaram Lambor, and he's from Manipal. The topic is knowledge, perception, and attitude towards occupational therapy services among healthcare professionals in India, a cross-sectional study. Dr. Pramod, good luck.
Good morning, esteemed colleagues, distinguished researchers, and respected practitioners. This is a privilege to present our study, Knowledge, Perception, and Attitude Towards Occupational Therapy Services Amongst Healthcare Professionals in India, a cross-sectional survey. My name is Pramod Dattaram Lambor, and this research was conducted in collaboration with my colleague, Mrs. Shalini Quadras. Occupational therapy, an integral component of comprehensive healthcare addressing physical, cognitive, and psychosocial rehabilitation. Despite its established significance, a lack of awareness and persistent misconceptions among healthcare professionals in India impede interdisciplinary collaboration and limit patient access to these essential services. Global healthcare organizations, including WHO and WFOT, underscore the necessity of interprofessional understanding to optimize patients' outcome. This study endeavors to systematically evaluate the Indian healthcare professionals' knowledge, perception, and attitude regarding occupational therapy services. The primary aim of this research was to assess the knowledge, perception, and attitude of healthcare professionals in India regarding occupational therapy services with the specific objectives to develop and validate the occupational therapy knowledge, perception, and attitude questionnaire, that is OT KPAQ, and to assess the healthcare professionals' awareness, perception of the occupational therapy services through the validation of this instrument. Methodology. The study was employed a cross-sectional survey design and sanctioned by KMC IC1 with the following number. Data were collected from physicians and allied health professionals working across the multidisciplinary healthcare settings in India, including government and private institutions. The survey was administered via online Microsoft form between September 2022 and October 2024. The following slide shows the inclusion and exclusion criteria. A purposive sampling approach was adopted in utilizing the OT-KPAQ to evaluate knowledge, perception, and attitude towards occupational therapy services. The questionnaire was meticulously developed and through a thorough comprehensive literature review and expert validation. The final instrument comprised 26 rigorously vetted items categorized into 3 domains, that is knowledge, which was checked using binary, that is yes and no response. Perception and attitude was checked through 5-point Likert scale. An optional open-ended response section for additional qualitative insights were also given. The content validation process engaged 7 subject matter experts, achieving an 80% agreement threshold for item retention. The questionnaire was designed to ensure clarity, avoid biases, and provide a nuanced understanding of the respondents' perspectives. The content validity index for this scale was 0.84, and the internal consistency Cronbach alpha was 0.7 for all domains. Biases. To mitigate biases, the study employed rigorous validation process and anonymized the responses and excluded incomplete submissions. The final data set included 97 respondents after excluding incomplete responses from an initial recruitment pool of 110 participants. Statistical analysis. Data analysis was conducted using Jamovi software. Descriptive analysis, statistical techniques were applied to summarize demographics, variables, and data. The complete case analysis approach was employed. The majority of respondents were young professionals aged between 20 to 30 years with post-graduation qualification and less than 10 years of professional experience. This demographic trend suggests an emergent engagement of early career healthcare professionals in interdisciplinary approach. However, a relatively smaller proportion of senior professionals in the sample highlights a potential gap in lifelong learning and continuing professional education. Finding indicates that the overall half of the respondents demonstrated awareness of occupational therapy, yet a substantial proportion lacked familiarity with its scope. The principal sources of exposure were formal education and peer discussion. However, a limited integration of OT-related content in non-OT academic programs remains a pressing concern, underscoring the need for a more inclusive interdisciplinary approach in healthcare education. Encouragingly, most participants acknowledged the critical role of OT in rehabilitation, activities of daily living, education, social engagement, leisure participation, and nonetheless, some respondents exhibited a restricted view of OT scope, often perceived it solely as a rehabilitation services for physical disability. Discussion. A salient feature of our study is that incremental rise in the OT awareness amongst younger professionals. However, notable knowledge gaps still persist, particularly within the government hospital and the home care settings. A significant proportion of respondents had previously referred patient to OT services, yet a considerable subset had not, underscoring the deficiencies in interprofessional collaboration. The absence of OT integration in the core medical and allied health curricula remains a systematic limitation, and addressing this gap requires targeted interdisciplinary interventions. The sample was dominated by younger professionals. As you can see, reliance on self-reported data may introduce recall or a social discrepancy biases. A non-random sample also was one of the limitations. Specific healthcare settings we chose, such as private hospitals and academic institutions, that may also limit the scope of our study. And the survey did not access the technical knowledge of OT practices, limiting the insight into respondents' comprehensive understanding of occupational therapy. Implication for future practice: recognition of OT is increasing, as we can see, especially amongst younger healthcare professionals, but significant knowledge gap and awareness gap still persists. Comprehensive interdisciplinary education and advocacy are crucial. Further studies should address limitation of expanding sample size, including rural and government healthcare settings, and using longitudinal designs. This finding aligns with the international trends, which highlights the limited OT exposure in training, compounded in India by its evolving healthcare system and underrepresentation in allied health education. Addressing these gaps is essential for advancing OT integration and multidisciplinary care. To conclude, I would say the study reveals significant gap in knowledge and awareness amongst other healthcare professionals. Efforts to integrate OT into medical and allied health curricula alongside targeted educational and awareness campaigns is very crucial. The Government of India's initiatives to establish Allied Health Council offers a promising opportunity to standardize education, develop policies, and enhance the integration of OT within the healthcare system, advancing its role in holistic and patient-centered care. These are my references. I would like to thank one and all to patiently hearing my presentation. Thank you.
Thank you, Pramod. Next presenter is Dr. Mona from Chennai, and her topic is impact of flipped classroom on clinical skills for the undergraduate OT students. Good luck, Mona.
A very good morning to respected one and all present here. I am Mona. I am presenting my topic on impact of flipped classroom on clinical skills for undergraduate occupational therapy students. So what if learning would be more like less than a lecture and more like an experience? So as in occupational therapy, we emphasize hands-on practice. But how sure we are facing challenges that how do we ensure that the students actively engage and apply what they can, what they have learned. So this question led me to investigate this approach of flipped classroom model. Today I'm excited to share this with you all. So the outline of the session. So the introduction of this flipped classroom model is a type of blended learning, and along with the flipped classroom model, we have the flex model, la carte model. So this model encourages the students to take responsibility of their own learning and engage materials before attending the synchronous meeting. So the lecture of when we study will comprise of only 5%, and that will boost, like if at all like if we engage in a group setting, so it increases to 75% of engaged learning. So by the author of Van Uer, they suggested that the active learning approaches, including simulation and flipped classrooms, help students bridge the gap between theoretical knowledge and clinical applications. The most flipped classroom studies focused on medical and health education, but the research on its effectiveness in occupational therapy, particularly in India, remains scarce. So our focus is to find out the impact of clinical skills. So after getting the ethical approval from my institution, the study has been conducted. I have recruited 28 students from BOT third year, whom they have the clinical skills part of all the core subjects, and the written consent has been obtained from each student to get participation in the study. So my inclusion criteria was the third year students, and both female and male students have been included. Students who are regularly attending the classes irrespective of regular absentees, and who are excluded if they have experienced this flipped classroom model previously, and who are unable to participate of any other issues. So the outline of the session, I've chosen 5 topics among the clinical subjects out of randomization, and these are the 5 topics I've included. One is sensory profile 2, pediatric splinting in cerebral palsy, child development from birth to 5 years, then behavior frames of reference, and adaptive assistive devices used in pediatrics. So after including the 30 students were enrolled in that class, so I've excluded 2 for respect of the attendance, and after randomization I've segregated into control and the experimental group of which in the control group they received the traditional classroom method, and experimental is flipped classroom method. So total session of 10 sessions comprised of 5 topics, so which includes the clinical topics of traditional classroom, and there we have applied the flipped classroom method, and then the data were analyzed. So this is one of the, I have used all the learning materials to be uploaded on the LMS pattern, that is Moodle, so that all the students can get access to it to view this lecture materials. This is one of the sensory profile 2. The material was prepared by me, and I have uploaded it in this. So this is the practical session of child development from birth to 5 years. I've created the 3 stations on key fine motor, gross motor, and social developmental skills. So that this is like what they have. I've created a video on like what are the milestones achieved by a specific age, and they'll be go through the video previously, and this is a classroom engagement setting. They'll be applying those theoretical knowledge where they learned in the video, and they'll apply it here in the classroom. So this is the one of the sample video I've created for risk cock-up splint. So this is the making of splint. So by using this guide, they'll make sure that they'll apply in the splinting room. So after the data collection, so I have compared this within the group. So we have used paired sample t-test, which in the pre-test scores, the mean average score was different between control and the experimental, which has been increased from 15.36 to 18.21. And I have used independent sample tests to compare within the groups across like control and the experimental, where the post-test score showed a t-value of 3.24, and the mean significance was increased from the control from 15.36 to 18.31. So this is the same graph showing that 12 to 18. This is a graph of, I have used like student perception on flipped classroom, how they felt about this. So out of that, I have used this student perception scales of flipped classroom. So out of this, like they found that they have the material, they have to access to the materials they found difficult to it, and that was like 3.07 of mean. So this scale comprises of the materials, how the professional is creating it, and this is the intentional content. The average of 3.07, the materials they have learned before the synchronous meetings are about concepts, theories that they can access through the LMS. That was like 3.07 of mean. And this is the professional educators, like how they engage the children, students in the classroom, how far it is effective by them. So the pre-class materials, whatever been prepared, if it is a well-structured one, it is very helpful for the students to gain benefit out of it. So professional educators, lectures played a crucial role in guiding discussions and providing adequate support, consistent with highlighting the need for teacher presence despite student autonomy given by Kem et al., which relies with this study. So to conclude, this flipped classroom model enhances the student engage more in the classroom rather than a lecture. They have to prepare with the single preparation in the homework and group preparation in the classroom with engaging all the other students. So from passive listening to active learning, the flipped impact. Thank you very much for your active listening.
Thank you, Mona. So can we have the participants line up in the same order of their presentation on stage? And as they come, I just want to leave a few thoughts with the group, especially the students who are sitting upstairs and who might be just presenting here next year. This is just a general word of advice. Even in presentations, when you're talking on anything very specific, if there's a specific term, please try and bring us all onto the same page as far as the term goes. I don't want to mention the terms to influence judging, but some of you use specific terms in your, which is part of your title. Bring us all onto the same page so that we all know what that term implies as part of your research design. Yes, some of you did put up your IRB number, which is, I think, going to be made mandatory, but don't wait for it. Please see that your institution review board goes through your studies, they give you good advice, and that those numbers are up as a proof. And finally, please use time. This is for the participants and all those who are going to be present. Please use time to the fullest. Don't get perturbed about the 2 minutes. The 2 minutes is just to tell you that you're in sync. Please use the time to the fullest because you might have had more information to share or you could have gone at a much slower rate to explain things out. All right, let's go to the questions. So,
let me also make a few comments about the presentation. I think all of you all did keep up with the time. So big applaud for them. Okay, so I think all were very well rehearsed. They have done their presentation in a very apt manner and they were very confident with the presentation. That was something very wonderful to see. So now I will invite the audience first to ask their questions.
all first-time researchers.
Absolutely, yeah. They are all, this is the first for them and they did a wonderful job. Okay, can I invite the audience to come up with their questions? Maybe I think I should start off with one of mine for that matter. So I have a question for Avasti. Yeah. So you have given us a wonderful presentation on effectiveness of occupational therapy with mindfulness training on mental health of parents of children with autism. So I have a contention with the word parent because there are two in a parent, isn't it? And if I looked at your presentation, I think maximum study was on ladies, the mothers. No, the females overrepresented your population. So I think the fathers were neglected there. So rather than saying parent, it could have been the primary caretaker of the patient, isn't it? Okay, that would have been more unbiased. Okay, and if you want to really do a study on fathers, I think the whole study results also would have definitely been affected, isn't it? Okay, so that's a comment from me.
Yeah, I just got 3 important questions. What is mindfulness as part of your study? What do you mean by mindfulness?
Ashwini, come.
Okay. Mindfulness focuses on the present awareness and it focuses on the how to cope up with and how to be aware about what is the surroundings here, like that, sir.
You said lack of diversity in your demographic status.
Yes, sir.
When you have a diversity of 21 to 35 productive age among the ladies or the women, and also among children. Of course, corresponding age 3 to 8, which seems reasonable for mothers who are 22 to 35. So what did you actually mean by lack of diversity in your study population?
Okay. Here the lack of diversity, which means that like among the population can we include more than 35 age parents and also above the age 8 the child, because when we look upon more than 8 for the child, it includes the difficulties with the autism and also it causes a stress and the other level also include. So there here we measure the lack of diversities.
And yours was a cross-sectional study, right?
It was a quasi-experimental study.
But it was cross-sectional.
Yeah.
You took it, at one point you took an assessment.
Yes.
Something like, but you know, your study will definitely have a carryover effect and a sustaining effect thereafter. That's something which you can mention as part of your study, or have you actually explored that also, or kept that in mind as a future research?
Yes, sir. We have kept it for the future researches also.
Thank you, Ashwati.
Thank you, sir.
Please. There's one more question for you.
No, not for you. Thank you. Thank you. I have a question for Dr. Sahib. Thanks for your presentation, and you selected really good topic. Actually, I haven't seen anybody doing any presentation on the freezing rain and whatnot.
I come from a more colder place.
I come from the cold country. I live in Canada, and right now the weather is minus 15 or something. You know, it went to 17, minus 17. Daytime high is minus 5 nowadays. So, in your study, you mentioned about so many effects actually, diet and sleep hours and all that. And one factor was the weight loss or something, weight gain, weight
fluctuation.
loss. So did you actually measure the weight? Did you weigh them?
So it was a part of the SPAQ. There is a specific section 5 where you have a list of weight fluctuations 0 to 3, 4 to 7, 7 to 12, and 12 above, all the way to 20 lbs. So we will be measuring that if we have a transition of weight. Suppose I'm going from autumn. We have 4 seasons in Kashmir: spring, summer, autumn, and winter. So we will be measuring the transition from autumn all the way to winter, and we'll be checking that what is the weight at autumn. We have a section like a subsection in the SPAQ where you have to mention the weight at autumn and then you have to mention the weight at winter. So the participants recorded and mentioned their weights on the form itself.
Do you live in New Delhi? Yeah.
I am basically from Jammu and Kashmir and I am a native of that place.
Oh,
so during the 2021 winters, I was there and I was willing to work or conduct a research with the population, basically from my native hometown. So I was lucky enough to get a chance to conduct this research in there.
Sorry, Shahab, I'm going to stop you short there, but it was a very interesting topic. Just for lack of time, I had the scientific committee chairperson at the back. All right, so the next participant, please.
Thank you
the
so
presenter,
much.
please. Thank you, Yusuf. Who's the next after Yusuf? Chandralekha.
Any questions from the audience,
Yeah,
please?
sorry.
Yeah, he has a question. Yeah.
You have it for Yusuf or someone else? Yeah, for Pramod. Huh? Yeah, okay, Pramod, please.
Could you give the mic to him, please? Kindly hand over the mic to him, please.
Good morning, everybody. Myself, Saumil from Mumbai. I am a private practitioner. Pramod, wonderful study for understanding the knowledge and perception of occupational therapist among healthcare professionals. I had one very small question. Your study started right from 2022. It extended till 2024.
Yeah.
Don't you feel 2 years are too much to increase the variability of the study, because definitely the awareness back in 2022 would have been different. The awareness right now in 2024 or 25 would have been different. So that is where my question goes.
Yeah, actually, the thing is that there could have been a variability. However, we were limited with our the mode in which we conducted the study, that is online form we circulated and the survey was conducted. So there could have been variability, I don't deny that. However, as a part of the study, we were not giving any interventions where we were educating them about OT and then checking the, carryover or, how did they do it after that or what resources they looked after. So there could have been variability. However, we were limited with the online nature of the survey.
Thank you.
Yeah.
Thank you, Pramod. Can we have the next? I'm sorry, but again, it's...
Yeah, any more questions from the audience?
Kaushik, you sure, huh?
Yeah, I'm... No, I'm asking to...
No, just wait. We'll change the... Pramod, please, quickly.
Pramod, it's a just follow-up question to Ashish. Why it is online only, restricted to only online? Just, is it reaching 97 people over 2 years? Is that so difficult in this country? That is one. Two, just, can you, the validation, the content validation process, you said 26 out of 33 items. Can you tell me about the exclusion of 7 items as such?
Yeah. So, sir, actually, we wanted to have a pan-India sample. So that's the reason we decided to go by an online survey method. As you mentioned, that within 2 years to get a smaller numbers like 97 is less, to be honest, and I agree with that. However, we tried the way to disseminate the survey form through various platforms, reached out to many organizations. However, because of the online nature of the survey and there were not many people who responded it. I understand that we could have done more to disseminate and get the responses, and that's ongoing. We haven't closed the form yet. Another thing that you asked regarding the content validation.
Pramod, wonderful explanation, but I think you have a lot to say. Again, lack of time. Please meet Dr. Lakshman. He's also equally passionate about this. Over coffee, and we can go ahead.
Yes.
Okay.
Thank you.
Next presenter, please. Chandalkar. Ms. Chandalkar, please. Any questions? Quickly.
Yes. Good morning. Myself, Kaushik from Manipal. I have just a question I want to know. You mentioned your study title like across, it is a professionals, this is cross-sectional study and mental illness in India, right? So how the population represent? You taken from a particular zone or you represent all over India?
So I have taken it from a tertiary hospital in Goa itself.
Okay.
But then we have a diverse admissions of patients from all over India. Being the tertiary center in Goa, we have a population from all over India actually, the inpatients. So I've considered it that way.
So your result reflect that one, that is a representation is there, at least from 4 part of India.
So I've taken patients from India, as in there were patients from Maharashtra, there were patients from Karnataka as well. So it's a...
Okay.
Yes, Chandalkar, you have a free coffee with Kaushik to discuss things.
Thank
All
you,
right.
sir.
The last participant, please, Ms. Mona. Yes. Please.
Yeah, anybody for Dr. Mana?
Good morning. Myself, Dr. Meenakshi Batra. I'm a lecturer at IPH. Being engaged in teaching myself, we provide the students all kind of information through video, through practical training, and through demonstration, everything, and the written material. How is your flipped learning, flipped classroom, different from what we are already doing?
Yes, ma'am. Thank you for the question, ma'am. So basically, flipped learning is we are introducing the new topic of a lecture in the classroom. That is like the lecturer or the teacher will be there and the student will be listening monotonously when they are sitting in the classroom. But wherein in the flipped classroom, so we will be all the lecturers or over the professional educators, they will be preparing the material in different modes like videos, or else we can narrate the topic, or else we can take like how the clinical skills, based on that we can provide the PPT or the PDF, whatever the learning sources may be. We will be uploading it in maybe LMS or sharing through any of our forums of standard one. and making sure that the students is learning before the class and getting thorough with the topic once they enter the class. So with the basics or the basics of that knowledge, they will be including in the activity kind of thing, maybe whatever that is our creativity, like in a station
Excuse me,
mode.
Mona.
Yes.
Meenakshi Batra will definitely meet you
Sir,
during coffee. Please see that you meet her.
Thank you.
All right?
Fine.
So, okay, no, so I think
Thank you.
the scientific chairperson is, okay. Doctor, please.
I think Dr. Mona should get her paper published in medical education cell. I'm belonging to medicine department, to MBBS. We have already started CBME program, and in CBME program, flipped classroom is a must. So please, you've done a good
You
job.
got another admirer there.
And,
all right. So with this, we will stop because otherwise scientific committee is on us. Thank you, scientific committee, for giving us this opportunity to chair this session. Wonderful presentations from all your end. Keep up the good work. Keep up good research. Thank you.
Thank you for dignitaries for chairing this first scientific session of this OTCon 2025. Now I would like to welcome Dr. Vivek Sir, the Organizing Secretary of OTCon 2025, to felicitate our esteemed Dr. Vijay Suple Sir, Senior Occupation Therapist, Canada. Thank you, sir. Now I would like to welcome our chairperson, Dr. U. Ganapati Shankar, sir, OTCon 2025, to felicitate our esteemed Dr. Mary C. D'Souza, ma'am, Associate Professor, HOD, IPHB, Goa, with a memento. Thank you, ma'am. Thank you, sir. Now I'd like to welcome Dr. Priyanka Raikar, a member of Goa IOTA, to felicitate our esteemed Dr. Sanjeev Sir, Professor and Head of the Department of Occupational Therapy, Christian Medical College, Vellore, with a memento. Thank you, sir. Thank you, dignitaries, for your kind time for chairing this person. Good morning to one and all present here. I am Ms. Purni, Scientific Committee Member, OTCon 2025. Extend a heartfelt greeting on behalf of the Organizing Committee for the next session of our scientific event, our guest talk. It is my great privilege to invite our esteemed guest, Dr. Rahul Sidai Sir, Associate Professor, Psychiatry and Senior Research Scientist, Pravra Institute of Medical Science, Loni, Maharashtra. Sir is a trained clinical psychiatrist and an epidemiologist and has worked in the field of global mental health for last 22 years in India and other countries with a specific focus on reducing the treatment gap for mental disorder by translating evidence-based treatment in real-world setting. Sir is recipient of Indian Alliance Intermediate Fellowship in Clinical and Public Health Research, and his work involves design and evaluation of yoga-based intervention for mental disorder. His work covers major areas such as epidemiology of mental disorder with focus on social determinants, generating evidence on translating knowledges into practice, synthesizing knowledge to felicitate policies uptaken, and an effect of yoga-based intervention on mental health for women and elderly. I welcome you, sir, and I would like to hand over the stage to sir for his topic presentation.
Can I have my, yeah. Am I audible? Am I audible? Yeah. Okay. Okay, Namaste. I'm Rahul Shide. Thank you so much for that nice introduction. I was not sure how the whole thing is going. I mean, I thought it was part of some other session, but let's start. So it was so heartening to actually be part of previous presentations. I really loved presentations from Shivani, from Aishwarya, Ashwathi, and Pramod, because I was present for those 4 presentations. It was good to see young professionals getting into the business of evidence generation. So a lot of research coming out from young researchers, evidence generation. And why I'm here is to talk about evidence to practice. So one question which I wanted to ask all the presenters was, what do you think you are going to do with what you have done till now? So what's the next step? And probably the next step is evidence to practice. And this is the topic which Dr. Vajratkar, who happens to be my old friend, when he gave me an invitation to talk in this particular conference, he told me that, Rahul, why don't you speak on this particular topic on which you have worked earlier? So I thought that's a good thing, evidence to practice, but it's also a bit difficult because to pack everything which, let's say, comes under this area in 20 minutes is an extremely challenging job. So what I thought I would do is basically focus on something which Dr. Mona referred to while presenting her model. She said that less of a lecture and more of an experience. So I'm going to spend more time on my experiences, my learnings, and what kind of things I've picked up over last 1.5 decades, instead of focusing too much on sort of a very didactic way of presenting data and stuff like that. It's all in there in the papers which you see on the slide. The good news is that I just have this one slide. This is half part of it. The rest will be as part of the part of my talk. So I just have got one slide and 2 sort of additional slides which will help. I mean, they're part of the papers which are there on the screen. So I saw some of you taking photographs of slides. So your work is really cut out only to one slide. And even you can take the photograph of this particular slide right now. Though probably the only important thing is at the right hand bottom corner of this slide, which is my email ID. If you are interested in knowing more about what we do, then do write back to me at rahulshida@gmail.com. So with that particular thing, I'll basically start my talk, and I'll try to kind of focus on 5 things and what, as let us say individual researchers or researchers based in a medical college or in small institutes, what we can do in contributing to this broader agenda of evidence to practice. So in the previous session, what we saw is that we are generating a whole lot of evidence, we are doing a lot of research, we're doing many studies where we develop interventions like mindfulness or like yoga-based interventions or psychological therapies or physical therapies, occupational therapies. There are many interventions which we test in a set of population. Now the next step is we want to scale it up, we want to take it to the entire population so that people who are suffering from those problems receive care or receive kind of evidence-based interventions. How we do that is something I'll kind of go through in next maybe 15 minutes or so. So maybe just click the first thing, yeah. So I'll start with my first experience based on our work in a PRIME program. PRIME stands for Program for Improving Mental Health Care. This was a 8-year research program consortium which we implemented from 2011 to 2019. The work was done in 5 countries, South Africa, Uganda, Nepal, India, and Ethiopia. I was leading the work in India. Now the overall goal of our work in PRIME was integrating mental health services in primary care. So we all know that we have public health system and primary health care. So we wanted to integrate mental health as part of the primary care system. We started our work in 2011 in the state of Madhya Pradesh, and coincidentally this was again also led by Public Health Foundation of India where I worked, and co-led by Sangat, an internationally recognized organization, research organization based very well here in Goa. So Sangat and Public Health Foundation of India started this work in Bhopal in Madhya Pradesh, and in about 3 to 4 years of our model development and building some of our, after completing our formative research, we got our first opportunity to meet with the Principal Secretary of Madhya Pradesh government, Department of Health Services, and after a lot of efforts, we had got that opportunity to meet him. When we went to meet him, what he told was, I have got all the joint directors from 6 regions in Madhya Pradesh. I think you can explain your model in 30 minutes or so. I'll leave the room in next 5 to 7 minutes because I have other commitments. I don't know what happened at that point of time, but I thought, I was also young, I was also a bit rash. I said, so don't worry, I'll explain my model in 3 minutes. You just give me 3 minutes and I'll explain what we wish to do. And then I started explaining, what I explained to him was that we basically need 1.5 minutes of your medical officer's time who is based in primary healthcare center. For that 1.5 minutes, what he or she should do, we need about a 1 to 2 days of training. That is all that we need. He stopped me at around this time, 1.5 minutes of my presentation, or whatever I was talking to him, and he said, this sounds like a good plan, I'm on it. When do you want to start? And I said, from 2 months from now, because we have other commitments. He said, nothing doing, we are on board, you have to start 3 days from now. So that was 17th of April, 20th of April, he asked us to do something, which I'll explain in my next point. Okay, it's all there. Anyway, so my second point, no, go back. Yeah. So the first lesson which I learned was that you have to describe your stuff in a minute, in 2 minutes or so. Whatever you do has to be very crisp, has to be very succinct. People or those who are decision makers need to understand it very quickly. So the first lesson was less is more. And if you have to scale something, the intervention also in terms of how you can scale it up, it has to be as simple and as they call it, scalable. So one of the terms which, previous chairperson said that use specific terms. So scalability and sustainability are those terms. So you should be able to describe your intervention in minimal terms. It has to be simple to implement as well. So my first lesson was that less is more. So if you want to translate evidence into practice, first of all, practice the skill of translating in your evidence or what you want to do into something which is scalable, which is succinct, which is brief, which can excite people, which can give them a confidence that this is something which we can do at scale. What he asked us to do was to train medical officers, exactly what I had told him, like we want 2 days of your medical officer's time so that they can do something which they can deliver as part of mental health service strengthening in your primary health care centers. So our next task was to train medical officers in exactly 2 days. Then we went to one of the district hospitals and we started interacting with medical officers. Now medical officers happen to be from different, so they're from different specialties, and no one is, there are very few people, in fact, no one is from mental health specialty. My work was, our work was basically integrating mental health in primary care. So when we started our first training, most of the medical officers were furious on us. So the second lesson was that even though their boss gives them the order to attend sessions or training, that doesn't necessarily mean that they will be happy with the kind of programs which you design. So we got a lot of negative reception when we went to district hospitals or when we went to other hospitals for training. People were angry because this was an additional load on them. They didn't want to kind of get into mental health because it was all pagalon ka stuff, especially in Hindi, and why we want to do all this. So first 1 or 2 trainings were wasted. I couldn't do much with them. But with the third training, I thought, it was very frustrating. So I just asked them, forget what I have come here for. Let's just focus on you as individuals. And I see you being very, very irritated. At this point of time, you are very irritable. Let's talk about your irritation, your anger, your irritability. Is that a problem which you generally face? And they said, yes, of course. That's exactly the problem which we face in the OPDs, at home, in general in life. So we started talking about, so I kept my World Health Organization's mental health gap action manual and their curriculum aside, and I just started talking about their irritability. From irritability, we started talking about anger. From anger, we started talking about emotions, role of emotions in life. And from emotions, we went on to depression, anxiety, and psychosis, which we wanted to talk about. And within a day or so, we were within like those 4 hours, I was able to convince them that mental health is important not for World Health Organization or for me as a principal investigator of a program or for funding agencies, but mental health is part of your life. It is what affects you. So I would suggest that first focus on your mental health. And for a good mental health, you need to do, let's say, 1, 2, 3, 4. These are the things which you need to do. If you feel that this will help you, then maybe you can try it with your family, not patients. First try with your family. Discuss these things with your family members. If you feel that this is working, then maybe you can try with your patients. And that's how we started training medical officers in district hospitals. Every time I went to a district hospital, same experience, people used to be furious. Why me or why us? Why are you kind of bothering us? We don't want to do this. And then in about 4 or 5 hours of that interaction, they used to say, this sounds good. We know people who have been who have depression, who are anxious, who are not being able to deal with their day-to-day problems, and sometimes they also have death wish, so we have experienced that. So we would like to sort of contribute to that. This feedback went to the principal secretary, which I was referring to in my earlier point, and based on that experience, Government of Madhya Pradesh decided that they are going to actually scale up the model which we had developed, the model which Sangat and Public Health Foundation of India had developed. And the core part of that model was that we would establish something called as Mankaksh. Mankaksh is, let's say, a structure where it's just a room, but it is dedicated to mental health services. And in about 6 months or so, Government of Madhya Pradesh made it as their flagship program. They scaled up Mankaksh everywhere in the state of Madhya Pradesh. Now all district hospitals in Madhya Pradesh have a Mankaksh, and then mental health services are delivered as part of that. The lesson for me was that whenever you approach people, let's say with your program, they are not interested in your program. They are not interested in the kind of research you do. They are not interested in Lancet publications. They are not interested in any sort of data which you are trying to generate. This experience was every time I sort of do any work, this experience gets repeated. So on the bottom part of the slide, you can see another work which I'm currently engaged in. This is yoga-based intervention for antenatal depression. And this we are doing as a randomized control trial in rural Maharashtra. There also we realize that when we approach pregnant women and we start talking about depression or anxiety, they are not interested. They do have depression, they do have anxiety, but not in those same terms which we want to sort of talk to, or we want to kind of adhere to. What they are interested in, the kind of problems they face in their day-to-day lives. And the problems which they face in their day-to-day lives is household work. Who's going to do the vessels? Who's going to clean the rest of the house? Who's going to take care of other children? Who's going to cook? Those are the problems they want to face. So again, our second learning was that we definitely have to focus on felt needs of the population whom we are talking to. Even in prior sort of presentations, I did see that we could actually do a better job if we start thinking about what people want, what are their problems to start with. And although this might sound very cliche, but it is something which we miss as researchers, because as researchers or practitioners, we are focusing on things which we are trained to do or which we are mandated to do. But this was a lesson that we started asking women what were their common problems. So when we do our work based on yoga-based intervention, we don't talk about yoga now. We simply talk about how are you? What makes you happy? What makes you sad? What are things which are bothering you? And then there are some points where we pick up that this is something where probably maybe we can help. Maybe you have a depression. Maybe we can do some screening. And then post-screening, we then introduce them to yoga. And some of them, not everyone, some of them do feel that this is something which they can be part of. And that's how we sort of move into our yoga-based interventions. So two things which I've learned is that people are not interested in my research or our research in general. They are interested in their problems. We have to adjust or we have to align our research objectives or whatever we wish to do as part of their lives, as part of their day-to-day experiences. So these are the things which I wanted to sort of focus more from decision makers, from users, and from providers who are actually the most important part of this whole evidence to practice agenda. So first, government officials who are the decision makers. The second is people who are actually going to deliver your program, and the third is the users who are going to be sort of using or consuming the kind of things which you are going to throw at them. So these are the three things which I wanted to talk about. The fourth thing is now where we stand, because let's say I'm a professor of psychiatry. I'm basically a researcher working in a medical college. I have very limited resources. Even if I wish to scale a particular model for the entire state or entire country, it's not possible for me as an individual. I also learned that it was not possible for me as part of something as big as Public Health Foundation of India. Some of you may have heard about it. My colleague Suresh is from Public Health Foundation of India, who is sitting here. And Sangat, these are very renowned research organizations, globally renowned. But when you go to government offices, their reach is very limited. It is very, very limited stuff they can do as part of a non-governmental organization or as part of any organization which is beyond government. So fourth thing which I want to actually talk about over here is that who has the resources, capacity and mandate to do all these things, and it is the government. It is government and government. They are the only people who can actually do it. Look at unified payment interface. When government decided that they want to implement unified payment interface, they had that wherewithal, they had that whole thing to, of course, users had to be part of it. And when that, it was basically COVID-19 and introduction of QR codes, and suddenly the whole thing became like a scalable thing. Without that, probably it would not have happened. But when we talk about evidence to practice, we have to be very clear that who we are, as in what is our capacity, what are our resources, and who is actually going to do it. Government is not there to listen to whatever we want to say. Sometimes they listen. I mean, in our case, they listen. And they scaled up the program. It's now a flagship mental health program in the state of Madhya Pradesh. But it's not always the case. So one has to be aware of one's own capacities and resources. And that's the last part of my presentation today. What we as small researchers, or let's say as researchers working in a medical college, researchers working in non-governmental organizations, researchers in small setups, what we can do, what is there for us to contribute to this agenda. And that's the last thing, which is the dilemma which I've always faced in my life, do versus think. So I am a medical graduate. I did my post-graduation in psychiatry. And after that, my fellow medical colleagues, my batchmates from my undergraduate medical institution, or my parents or my relatives, they always ask me, so where do you practice? Where do you practice psychiatry? And when I say that I am a full-time researcher, it's such an experience to see their faces. They say, you are a full-time researcher, but why don't you practice? You know, there are so many people who are suffering from depression. There are so many people who are suffering from so many problems, substance use disorders. There are people who are committing suicide. And why are you wasting time doing research? Why are you not actually doing something which is meaningful? Why don't you just do? So that's the dilemma which, it's not a dilemma for me anymore, but that's the thing which people feel, that why I don't do things rather than just thinking or just kind of putting in data. And that reminds me of this whole Operation Cat Drop. Again, Operation Cat Drop was something which happened in 1960s, where British Royal Air Force had to drop cats in an island in Asia, in Borneo or somewhere. They had to drop these cats because what had happened was rats had increased. The population of rats had increased because cats, a lot of cats got killed because they were eating lizards. And lizards were exposed to DDT, which was sprayed by the World Health Organization for the problem of malaria. So there was malaria led to DDT spraying led to lizards having DDT, which killed the rats, which killed the cats, and then the population of rats increased. So very interestingly, what they say is that yesterday's solutions are today's problems. no, I'm not suggesting anything. I'm not trying to say that we should not be kind of doing things, but there have to be a set of people who are also thinking, who are also trying to theorizing what's happening behind that doing. And that is probably the role which I see for myself and some of the young researchers which presented their stuff in the morning session. What we can do is we can think, we can collect data, we can put it into models, we can put it into frameworks, we can comment on what's happening as an independent observers. And to do that, maybe what we can do is, and that's what Vivek had suggested me, that why don't you talk about theory of change? I'm not going to talk about theory of change, but I'm only going to give you a very high level overview of what we could do as let's say thinkers or as researchers. And what we can do is basically we can create theories, and create theories doesn't mean that you have to be a Karl Marx or you have to be some kind of an Albert Einstein to create grand theories. These are the grand theories, but then there is a whole role for small theories, or let us say something which we refer to as theory of change. Next slide, please. So, and just go on, keep clicking. Yeah, so this is theory of change. What theory of change means is that for a particular, I have 2 minutes? No, it's okay. Yeah. So what we try to do over here is that for any particular research program or a program of practice, we try to create a working hypothesis, or we try to create a small program theory, which basically has a long-term goal at its very top. So what do you want to change? For whom? In what time frame? That's what it kind of, so the process of theory of change is that all stakeholders come at the same place, let us say decision makers, users, healthcare providers, and researchers. They kind of gather, they come together, they decide on what the long-term goal they want to achieve. And to achieve that long-term goal, what are the kind of chain of events or the pre-outcomes or preconditions which need to be fulfilled so that they reach that final outcome. And this is a very, very sort of a very interesting exercise, because as we all know that whole is more than sum of the parts. Similarly, what happens is when many stakeholders come together and they get chance to sort of brainstorm, the kind of groupthink which evolves from that is much bigger than what a few set of individuals can put together. So this is kind of a template for theory of change, where you have a long-term goal, the things which precede or pre-outcomes, so as to say, and they do a backward mapping for that. And for each of the pathway, there is, on each of the pathway, you put in a verb, which is a verb thing or an action thing, which is an intervention, and the assumptions. So what will happen if you do this, or what will happen if you don't do this? What are the things which you are assuming in that particular pathway? All that goes into this particular diagram, and a description of that becomes a theory of change. This is something which is very useful tool. I'm not saying the kind of a magic wand, but a useful tool for researchers who are interested in trying to generate evidence that is scalable, sustainable, that can be converted into practice. And one of the examples is in the work which we did earlier, and for the current work also we are using theory of change. Next slide, please. Next slide. Next slide, please. Okay. So anyway, on the third slide, there is theory of change, which is part of one of those papers. And what we did over there was we finalized our long-term outcome, which was basically to improve mental health status of a population in Sihor district, because we are working in Sihor district of Madhya Pradesh. And to do that, you basically require two things to do. First of all, you had to improve the overall demand for services through increasing awareness for some of those interventions, as well as improving the motivation or attitude of individuals or community members towards receiving those services. And on the other hand, on the second half of the theory of change, what we had in mind was to establish those mankakshas or mental health clinics, where you could do a very basic level screening and then get your medical officers to start a first line of treatment, which would be supervised by senior psychiatrists who are part of the district mental health program. On the left-hand side of your slide, what you see is kind of a model which is an outcome of all that work. And on the first slide, the papers were there which describe all that model and what happens. And you can read that in detail. In interest of time, I'll not go into that. I'll basically now try to summarize things. So as researchers or people working in medical colleges, in educational institutes, our mandate, resources and capacities are limited. Government has those mandates, resources and capacities to deliver programs. But what we can do is we can theorize, we can create theories, we can have program theories which can inform what we call as mid-range theories. Consolidated framework for implementation research is one of those kind of theories. We can inform those theories, we can inform the way practice is done. And sometimes if you are lucky, the way we were, government officials may be interested in the kind of work which you are doing. And if they feel that this is something which they can translate into a scalable program, they do it. We have, I mean, at least personally, I have seen that happening. But there are many other interventions that have also been scaled across India and across world. So I think it's important for us to, first of all, accept the fact that we don't know most of the things. And one of the leading authors in this particular area, David Peters, calls this as militant ignorance. So one has to accept ignorance at a very significant level, that we don't know things, but we want to kind of create workable theories which can be tested, and then take it forward from there to inform other researchers, inform other people who are in the business of evidence generation and creating theories and modifying them, so that at some point, people who have the mandate, resources and capacity to do that would be excited to take that work forward. So thank you so much for patient listening. I know that I'm not really doing great justice to the topic, but given the 20-minute constraint I had, probably this is all that I could present today. Happy to take questions. Thank you.
Thank you, sir. Now the forum is open for your questions. One question.
Good morning, sir. First and foremost, I'm here. If you, yeah. First and foremost, I'd like to really congratulate you on talking about this topic, because still I would say, because I've been a strong advocate of mental health, so been in this field for over 20 years. So definitely, I think giving a different perspective in terms of research, like from evidence to practice, I think it's a great insight to the students. One thing in this theory of change, what I usually do in between is assumptions. I always put things as what if, because that really helps in our own mapping process, which is there, which has really been very helpful, that one. And in terms of your choosing career, people ask, I always look at it, what is meaningful to our own self rather than what is meaningful to the others. And I've always seen, when working with the community level, identifying the approach, whether it is going to be top-down or bottom-up approach, that makes a lot of difference. And because we need to really understand the community very well. And as you said, yes, felt needs is very important. I think that's really, and I think focus group discussions have really helped a lot. That's the key for any research in mental health, I will say, having been into narrative practices, and focus group really helps. So hats off to you, sir, for doing this. Any way when we can collaborate or do work together, I think that would be wonderful. Yes, thank you so much.
Thank you so much for the comment. It's actually good to get comments and also interact. Very briefly, I would like to kind of touch upon all three topics. So first of all, I'm available for a coffee, so please feel free to kind of connect, and I would love to talk about your and as well as my work. The second thing is, I think it's important for some of us, especially young researchers or young students who are getting into this field, to get excited about research. Knowledge generation is not optional. We have been seeing a lot of things are changing in the world, especially in last 1 month, which makes critically important for almost all countries to be self-reliant in terms of generating knowledge in their local context, generating solutions for their own problems. So it is important, choosing career paths, it's important that students should seriously think of research as a full-time career. Of course, the mandate for making that happen is with government, who has to fund research activities, needs to provide opportunities for researchers to do their work. The second thing is, of course, focus group discussions or workshops, or there are many other participatory methods which we also use in our work. But it's important to understand that beyond numbers, beyond just head counting, it's important that we understand people, we understand where they come from, where they wish to go. I didn't put it over here, but we also need to understand that, and some of you might have experienced as part of your own research work, is that not everyone is on board every time. So there are only few people who would be interested in the kind of work which you are doing. It is okay. There are people who we call adapters, and there are people who don't adapt anything despite whatever you do, and that's perfectly fine. So nothing is. I mean, as researchers, first of all, we want to kind of claim that expertise in a particular area we are not. So militant ignorance is important. Second is, we will not be able to change the world for everyone. It will be for only a set of people. Well, this was in response to what you said, and thank you so much.
Thank you. I do have a lot of things, probably we'll discuss over a cup of coffee. And the not so active people are actually the enablers, if you really look into. That's what I've experienced. Thank you.
Thank you, sir. I would like to extend our sincere gratitude for our insightful and enriching session on knowledge to action, evidence to practice, and eternal quest in mental health services strengthening. The depth of knowledge and practice guidance you have shared will undoubtedly inspire us, sir. Your talk not only provided us with a clear understanding of the challenges faced, but also highlighted the actionable strategies, sir. Thank you so much, sir. I would like to invite our Vice President, ma'am, of IOTA, to Dr. Pratibha Vaidya, ma'am, to felicitate our guest talk person, Dr. Rahul Siddai, sir, with a memento. Thank you, ma'am. Thank you, sir. It is my great privilege to invite our esteemed guest for the event, Dr. Samantha Shan, ma'am, WF40 President. Ma'am has worked as an occupational therapist in numerous educational, management, and practice settings. Ma'am is a regular guest lecturer at various national and international universities and frequently speaks at international conferences. Ma'am is the current president of World Federation of Occupational Therapists. She is committed to promoting and advocating for occupational therapy and person-centered care by supporting the development of profession standards and new education programs. In 2022, Samantha ma'am was awarded as a fellowship from Royal College of Occupational Therapists in recognition for her outstanding contribution to the profession. Ma'am is on the steering committee for WHO, World Rehabilitation Alliance, and is also a founding board member for the International Society of Wheelchair Professionals. Without further delay, I would like to welcome ma'am and hand over the stage to our esteemed guest to present a topic on title Occupational Therapy and Mental Health, Promoting Inclusion and Well-Being. Welcome, ma'am.
Thank you for the kind introduction, and good morning, everyone. Will this? Yeah? Oh. I will be very honest now. I am going to talk to you a little bit about some global statistics, so I'll start from a World Federation perspective. But I'll also say I am a practitioner. I still practice occupational therapy, and I've worked in the field of mental health for over 30 years now. So I'll do a little bit of the formal stuff to give you that global picture, but then I'll talk a little bit from my experience and from my heart, and a little bit of my hope for the profession as we move forward. So you get a bit of a mixture today. Okay, thank you. So let's start with some of the formal things. WFOT has a very clear stance on mental health. We have a position paper, I think the latest edition was from 2019, that talks very clearly about occupational therapists' role in mental health. And if this is something that you are advocating for, I would say look at the position statement, use it, translate it, do whatever you want. Position papers from WFOT are there to help you to advocate for us as a profession. And that. Then in 2013, we built on that position paper. 2023. We carried out a global survey on mental health. The survey was developed in English, translated into French, German and Spanish, and it was distributed through WFOT member organisations, the WFOT website, the e-newsletter and also social media. So I hope that some of you in the room actually responded to this survey. We got 1,322 respondents from over 80 countries, and I do know that some respondents were from India, so thank you if you did. Approximately 2/3 were from high-income countries, but we did get 31% respondents from low and middle-income countries. But what excited me most was that 83% of those respondents were occupational therapists actually working in mental health services. 12% were educators and 5% were researchers. So hopefully the results from the survey gave us a good idea of what occupational therapy is doing in mental health across the world. And most respondents had more than 5 years' experience working in mental health. All age groups were reported to receive occupational therapy for mental health issues. However, on average, respondents worked predominantly with adults, occasionally with older adults and with children, when we're looking at just pure mental health services. 43% of respondents worked in facilities, so inpatients or outpatient care, and 35% worked in community or home environments. Funding for occupational therapy services was most frequently from public or government institutions, with 61% of those respondents working in government organisations and 22% working in private. Other professionals involved in the provision of mental health services that occupational therapists felt they worked with most commonly were doctors, nurses, psychologists, and social workers. And occupational therapy services were predominantly provided in person, with some occasional telephone or email. And I think that's important because that's actually post-COVID as well. I think, I know around the world we moved to a lot of telehealth, a lot of and lots of occupational therapists moved to that during COVID. But this survey was done in 2023, so we'd seen a big return to in-person care. The range of interventions offered by occupational therapists was very, very varied, but did predominantly focus on occupation. So they were working as occupational therapists. In some countries, they reported that their title may have changed to mental health worker, but they were still able to follow their occupational therapy philosophy. The highest amount of interventions globally was on interpersonal interactions and relationships that people had, with a clear emphasis on social engagement, communication, and return to work. Spirituality was addressed, but not quite so much as those interpersonal relationships. But we didn't explore that full meaning of spirituality. 56% of respondents used outcome measures So only half of our respondents really were using outcome measures to evaluate the quality of their service. And as I said earlier, only 5% of the respondents were actually researchers. But what those researchers were saying, that the factors that were having the greatest negative impact on the ability to do research in mental health was availability of research funding, availability of time for research activities, and also difficulty recruiting participants. However, they did talk about positive influences as well, around motivation and interest to explore occupational therapy more in mental health. So that's the whole picture, and this data has been shared with our member organisations and will be going for publication at some point. So you've seen some of that data before it's out there in the public view. But I think it does show that we have a strong profile globally as a profession in mental health. And for me, what's really encouraging, we're keeping that core, our occupation there. But what does it actually mean? What's our future as occupational therapists in mental health? For me, I'd like to see more research in occupational therapy and mental health, but uniquely how we interact with our clients and patients, and that this really needs to be seen in our research, not just looking at the assessments or the models that we use, but actually that interaction. I think there's a creative synthesis between recovery and social inclusion, where recovery requires and allows social inclusion, and social inclusion helps promote recovery. And as occupational therapists, we're key in those relationships. We have to look at our role in enabling people to live in the communities and societies and interact day to day with the people that they need to work with. So when I think about research, I think also just to give you a clearer view is, yes, I'm from the UK and I practice in the UK, but I've also for many, many years practiced in Uganda. And when I first moved to Uganda 30 years ago, mental health and occupational therapy was actually quite new. I became very, very aware of my cultural differences, especially when we started to talk about day-to-day interactions and occupations and day-to-day mental health issues. A little bit like the previous speaker said, if we talk to people about depression, generally they're not going to start opening up to us. Yeah? Talk to them about themselves and they start to talk. Yeah? And I, as a practitioner, use narratives all of the time. I absolutely see the value in standardised assessments, and I will use standardised assessments as and when I need to. But they are not my first port of call. When I go and meet a patient, a family, a community, for the first time, I talk to them. I ask them to tell me their story. Yeah? And human beings are wonderful people. Yeah? We actually like to talk about ourselves. Yeah? And actually, if you ask somebody to tell you their story, they tell you a lot more than if you just ask them questions, when they literally become defensive or sometimes think that they have to give you the right answer. Yeah? So always, I would say, one of our really, really valuable skills as occupational therapists is that therapeutic use of self. Yeah? What are you willing to share with the people that you work with? But what stories do you want them to tell? And if you give space for people to tell stories, they will tell you the important points. They will actually tell you how that depression is affecting their life. They will actually tell you about the schizophrenia without the diagnosis. Yeah? What does it mean to live with schizophrenia? Are they actually experiencing hallucinations every day? You know, what is that meaning? Because actually as occupational therapists, The diagnosis is not the thing that is going to affect our interventions. We want to know, what do they want to return to? What do they want to be doing in their day-to-day life? And if we give people that possibility to tell their story, we will get that. So I'm a big believer in storytelling, or if I want to be more academic, in narratives. And I guess then my request to you as practitioners, educators, researchers is, yes, we have a hierarchy, I know, of research, and everybody goes to RCTs and we look at quantitative research. But where's some benefit in qualitative research? Yeah? What can we add as a profession by using our skills in storytelling, in narratives, and actually add some qualitative research? Our keynote speaker yesterday spoke about actually only a very small percentage of research gets put into practice or new ways of working. I'll say, as a practitioner, some of the most useful research to me has actually been qualitative research in mental health, because I start to understand a little bit about the experience of practitioners and people experiencing these. So if you are going to do research, ask yourself the question, who is the research for? Who is going to benefit from this research? And that's actually quite a big question, because I know some of you will be doing research for masters and PhDs, and we get into a different thing. But if we're looking at the patients and the communities we work with, what's the benefit of qualitative research? This is a very old reference, Graham Smith from 2006. But if anything I've said to you today about qualitative research or the power of stories is I would ask you to go and find Graham's thing. It's in the British Journal in July 2006. And Graham is an occupational therapist, but he is also a mental health service user. And he talks very powerfully about the power of storytelling and the use that stories have helped him in his journey, but also helped him with his relationship with his occupational therapists. And he talks about, as occupational therapists, we co-construct the client's story by asking questions. So we ask them to tell their story, but then we dig a little bit deeper. And we can co-construct that story into something meaningful, so that the individual participates through a meaningful activity to them. But the most important part of this process is then how, as occupational therapists, we not only create the space for the client, but we take that information away and help them to look towards their future. The other benefit of storytelling, or the collection of narratives and asking people, is we suddenly become culturally relevant. Yeah? So many of our standardised assessments are done in the West. So if I'm in the UK, I might use a standardised assessment. In Uganda, I use them less frequently because they are not relevant. So again, if I go back to storytelling and narratives, I'm suddenly in the cultural relevance because the client, the community, the patient is in control. Yeah? It has that perspective. It has dignity, it has kindness, and it has some compassion and humility. We need to work with our clients, especially in mental health, but across all sectors, by listening, sharing, caring, and helping them to co-create their story that is not just a story of their past, but a story of their future. If we let people tell their own stories, we create our own evidence as a profession by enabling them. And if we co-create stories, we work towards this promotion of inclusion and social recovery. The idea of building a life beyond illness, helping people to live on a day-to-day basis with the things that really matter to them. And that's really what is important in occupational therapy. So that's the reference. My plea to you is read Graham's, but my other plea to you is really think about the power of qualitative research as well, and what that really can bring to occupational therapy. Thank you.
Thank you, ma'am. Now the session is open for the question. Kindly ask your questions. Anyone?
Hi, good morning. I just want to reflect upon something. What I hear from WFOT president is something which is really very basic, which we had learned back in our college days. And I really would like to acknowledge that since we have many students sitting down over there, so just following certain basics of talking with the patient, understanding their needs, their desires, their wants is really very important before beginning any kind of an assessment and any kind of a treatment or intervention strategy. So thank you for reflecting upon this topic. I'm sure that it was an eye-opener for everyone. Thank you so much.
Thank you. Thanks. I think you're right. Our biggest strength, and we always have to remember this, our biggest strength is ourselves. And I think it's that lifelong journey when we look at lifelong learning. You know, so those of us in the audience that have had many years, we've had that years of learning who we are as occupational therapists. As students, you're maybe earlier in that journey, but you have to get comfortable with who you are as an occupational therapist, because it's you that makes the difference in that therapeutic process.
Dr. Samantha, thank you so much. I think since students are here, I think as occupational therapists, people keep emphasizing only on quantitative research. The fact that he emphasizes on importance of doing qualitative research is really good, and because when it comes to mental health, that if you could take up more of qualitative research, it is actually really good. The one reason why people are getting scared of doing qualitative research is because the lack of training. They don't know how exactly to put it, get the interviews, and how to transcribe the interviews, and probably that's the reason. I think one take-home message here would be like probably as IATA can organize something like in terms specifically to qualitative researchers. That is the reason everybody feels that I don't think I'll be able to do that. That is the reason people kind of shun away. But quantitative, you have data, you have everything set there, concept guidelines, everything is there. So they're more comfortable with that. I think that is probably the reasons why people are little. And definitely they go by the order and they feel that, if we don't do an RCT, and I think probably my paper would get, rejected, and, so everything is there. So dealing with the rejection is something we think we need to train the students and every researcher. That is very, very important, I've had many rejections. I don't mean me here, I meant the papers. But then you should not get bogged down, you should write back, revise and write back, and that's the thing. I think that's the one step I think we can move ahead in terms of qualitative research. I love qualitative research. So anytime it's like for me more than quantitative. So qualitative is amazing. When you do really put your heart and soul in it, you would just start loving it actually. So anybody needs any help with the qualitative research, I'm always there for you, especially for the youngsters out there. Thank you.
Thank you. And yes, we live in a day-to-day world, and we know that sometimes it's a little bit easier for quantitative research to get accepted. But there are lots of journals now that are moving to that social model that will accept your qualitative research, and particularly because you would come from India as well, so you would be sharing a very unique perspective. So my plea is just consider it. Yeah.
Thank you for your presentation. What I wanted to comment and compliment on is the therapeutic use of self. And I wanted to tie your presentation along with the previous presenter that therapeutic use of self is so important. And are we, as occupational therapists, looking at our own psyche and paying attention to our own selves and making sure that we are not walking in with anxiety, we are not walking it with anger and stuff like that from elsewhere, walking into a patient treatment. So that is something else that needs to be looked at.
Absolutely, and I think it really ties up with reflective practice, that as occupational therapists, we should take time to reflect on ourselves, think about where we stand and what we're taking in as an agenda. Yes, yeah, thank you for that. Yeah, thank you.
Felicitations.
I would like to extend a sincere gratitude for your insightful session, ma'am, on the topic Occupation Therapy and Mental Health, Promoting Inclusion and Well-Being. Your expertise and dedication to the field of occupation therapy are truly inspiring, ma'am. Thank you so much, ma'am. I would like to invite Dr. Shailaja Sandeep Javant, ma'am, Associate Professor, Lokmaya Tilak, Municipality General Medical Hospital and Medical College, Sion, Mumbai, to felicitate our guest talk person, Dr. Samantha Shan, ma'am, President, FO, WH40. Thank you, ma'am. Thank you. With an extensive pleasure and privilege, I would like to invite our next guest faculty talk for the day, Dr. Sebastina Anita De Sosa, ma'am, Professor, Department of Occupation Therapy, Coordinator, Center for the Studies on Healthy Aging, Manipal College of Health Profession, Manipal. Ma'am contributed as an invited expertise for the development of WHO rehabilitation package for dementia. She is also a member of World Fall Guideline Group. Ma'am has several ongoing and completed international funded researches and academic projects with South Africa, Vietnam, Sweden, Canada, and Australia. She has also considerably experienced in diverse area of practice with focus on neurorehabilitation, cognitive rehabilitation, aging, and community development. Without further delay, I would like to hand over the stage to ma'am to present her topic on fall prevention for older adults, adopting a pragmatic approach to translation research into Indian context. Welcome, ma'am.
Good afternoon, everyone. I know it's pre-lunch. Good afternoon, everyone. Thank you. Just checking. So it is a great pleasure for me to be here today. I'm grateful to IOTA for the opportunity and for a topic that is very close to my heart, that is research, and not just research, translational research. So without further ado and with the hope to stick to the timelines, I will move on. So we all know about population aging, and India is one of the countries in the LMIC group, that is the lower middle income countries, which is facing this drastic population or change in demographics, and we are actually bracing ourselves for this phenomena of population aging. And this phenomena comes with its own complications of having a large group of people who are having health issues, who are having financial issues, and to support this particular group, we are having what we call as a concept of WHO called as healthy aging. So, it will be even more important in countries like us, like ours, with limited resources, that we emphasize on the concept of healthy aging, because we do not have the luxury of social support that developed countries have. And it's important that we make our older adults resilient, independent, and have better health and wellness and well-being. Among all the problems that older adults face, falls is a very big threat to their independence, to their autonomy, and to their well-being. Falls are a leading cause of mortality and morbidity worldwide, and they are identified as a salient public health challenge. When we are saying public health, we are talking about a huge prevalence. We are talking about a huge problem. In India, there is limited research, but the prevalence ranges from 14 to 53% in India among older adults, in both in institutionalized and community dwelling adults. The prevalence is very high, and is actually higher than most other countries, which is usually around 35%. Now, as I said, falls have debilitating consequences on their quality of life. They have a lot of activity restriction, fear, and of course a lot of functional dependence, and which is why, and they are associated with high direct and indirect cost. And prevention of falls, therefore, becomes very, very important and is emphasized by all bodies, starting from WHO to every national body. So fall prevention is a very, very critical component of any public health approach towards aging. Falls have got various definitions, but this is the one that is the most commonly used. It's a very diverse definition, so I'm not going to go into it. So falls, as we know, are multifactorial. This is one of the first reports by the World Health Organization on fall prevention, and they defined falls as multifactorial, but primarily these issues: behavioral, biological, socioeconomic, and environmental. Now, because they are multifactorial, they are also very, very challenging and challenging to treat, to manage. Not just about the person himself, but also because of the context in which falls occur. So there is a lot of extensive research in fall prevention. I'm sure there are young researchers here who have talked about something or the other with falls, this kind of exercise, that kind of exercise, this kind of virtual reality, now maybe AI in fall prevention. But the issues has been that despite this high evidence, the adoption is very low. The adoption by older adults is very low. The adoption at all stakeholders is quite low. And this is a big concern. This is a big concern. So to address this, recently we had the World Fall Guidelines. And I was lucky to be a member of this particular guidelines. It's the latest guidelines in terms of fall prevention. And they've come up with a nice document about falls and how to go about it. So I am a member of this component of the World Fall Guidelines. And the key features of the guidelines are, it provides a framework for fall risk screening, assessment, and intervention. As falls are multifactorial, you have to have a multi-domain approach to addressing falls. And most importantly, the guidelines emphasize on engaging older adults' attitudes and priorities and beliefs about falls and their management for adoption. Ultimately, the older adult has to adopt it, and for that, you need to engage them. Sometimes they do the exercises, but they don't continue. So adoption, very critical to adoption is their attitude and they accepting it. And for that, you may need to modify these modifications to meet resource constraint settings like ours. And they have emphasized on being contextually relevant. In policies and practices, they have emphasized on being contextually relevant. So, we all know that OT has a great role in supporting participation, safe participation in valued and meaningful activities and occupations and environments. And these are our major primary areas of work. But the question arises, so much evidence, so many things available, but how do I do it? So these are the questions that I faced in my initial years. So my PhD was in the area of fall prevention, and when I was doing my PhD, I always had these questions. Who are we working with? Are we working only with the older adult, or are we also working with others? What am I trying to do with them? You know, what am I giving? What intervention is the best for them? Why? Why do I use this assessment measure? Why do I give this intervention? When do I give it? When do you start it? And even, for example, where? When? Where? Do I do it in the hospital? Do I do it in the home? Do I do it in the old age home? And most importantly, how? All the research is from developed countries. They have fancy equipment, they have very fancy settings, they have very fancy discharge processes. I have nothing here. How do I go about doing it? So these are the major questions that have always plagued me. And it was through that, through my PhD, that I have been steadily trying to answer these questions in the research that I take. There are many whats, there are many hows, there are many whys, there are many whens, there are many hows. And hopefully in the whole presentation I'll be touching upon these. But the major issue is to guide these things. There is very limited research in our context. If I have to use this in my clinical practice, or I have to use it in my future research, I don't have much resources. I don't have much information to be able to build something on. So that is how we have started this journey. It's been almost 25 years that I've been in this area, and in the area of aging, and specifically with respect to falls. And to support an approach that is distinct from our sister professions, I've always emphasized on a top-down or a person, environment, occupation approach, and the same with falls. So I'm going to present a person, environment, occupation approach with respect to falls. One of the common examples I give is bathing. So bathing is an occupation which we do. It depends on the person's, so the way Indians bathe is very different from the way Westerners bathe, right? You would agree with me? So bathing is a very high-risk occupation actually for elderly, especially if they are frail or if they are very old. And also it's familiar activity, so they tend to hurry up, and that can be quite risky for them. Even one fraction of not paying attention can cause them to fall. The person, how is his cognition? How is his balance? That will influence how safely he or she does bathing. What about the environment? Bathrooms are quite different from each house, and they can vary. Similarly, most of the tools have bathroom assessments which are very different from ours. We don't have that kind of bathrooms in our context. So when I used to use these scales, you know, Home First, a lovely scale, no problem with it, it doesn't address all our problems. That was the issue. How do I assess this? And as I said, occupations, we do bathing very differently from the way it is done in other countries. Right? So in this person, environment, occupation, I'm going to first talk about the environment and occupation. They go hand in hand because every occupation is done in a particular environment. So these are the various studies we have done in this particular area. I have just put a few of them as relevant to this particular topic. So this is a very early study of mine, which was published in iJot. We even got the national award for this, which is talking about the circumstances and consequences of falls in older adults. Now, why is this important? Because tomorrow if I have a patient, I need to be able to ask him questions. I don't have time. I need to be aware of which are the usual situations Indian elderly tend to fall. The literature is more about Western countries, and it's all about snow, it's all about bathtub, shower, which we don't have in our context. So we need to understand what are the usual situations in which Indian elderly tend to fall. So these are the various studies. This is one study that we have done, in which we found that the most common reason activity they were engaged in was ambulation or walking around, when they were doing bathing, like I said, and when they were doing housework, and when they were stairs or they were transferring from one level to or one place to another. They mostly fell in their house, in the bathroom, or on the road outside, in the location of falls. And most importantly, the cause of falls was mainly slips and trips, as you can see, slips and trips. So more extrinsic cause of falls than intrinsic cause of falls were common. Some of them, they also reported issues like dizziness. So these are intrinsic causes of falls, when you fall because of sickness. So then we had another study where we did bathroom hazards in Indian homes. So this was a study done in Gujarat. It was a cross-sectional study. It was published in the Asian Journal of Gerontology and Geriatrics. So this was a very nice study, and we developed our own questionnaire for it. Of course, we got it validated, and we are using it clinically when somebody has concerns mainly of the bathroom. So in this study, we have found these kind of bathrooms, which are very, very dangerous, For example, as you can see, so many things in the bathroom. It's a very common problem in Indian issues because the bathroom is second place for storage also. You agree? जो नहीं बाहर दिखाना वो bathroom के अंदर है, या bedroom के closet के अंदर है. Okay, but bathroom is dangerous. Of course, we have water problems, so we have a lot of things to store water in our bathrooms. So these are the issues we face. You can see that place where the last one, I don't know, I'm not sure it points. It doesn't point. Black. Yeah, so you can see in the corner there. So you have all the soap, the low stool, all at the entrance of the bathroom. You can imagine how slippery it might be, right? Okay, this is a very uneven entrance, a threshold, which is a very high trip hazard. And similarly, you have the Indian toilet. I don't think you can see the step very easily between the toilet area and the wash area, right? So these are the common hazards we've had, and you'll be surprised to see the prevalence. So we had classified the hazards as architectural and non-architectural. So the architectural hazards, almost 100% had inadequate door width, okay? Slippery. So if you have inadequate door width, you cannot even walk with a cane. Forget about a wheelchair. Even a cane becomes difficult. Slippery floor, 91.9%. Inappropriate bathroom size and very high door thresholds. We are very worried about water. Then there is non-architectural hazards where you have no non-skid mat. You have mats. You may have old torn nightie, bunion. Okay, fine. All that you will have, but you will not have a non-skid mat. No grab bars, quite obvious. No exhaust fan, elderly people, they get more exhausted and they need more ventilation, they need more support, but there is no exhaust fan often. Inadequate bathroom illumination, blame it on the elderly. Current pe bijli kharch nahi karna hai. You should not spend so much money on electricity, so the bathroom has got very less light, and many other issues. So these are the problems we found. Unsafe hot water use. Getting hot water from the kitchen to the bathroom, very risky because water may spill, plus they may get hurt. Cluttered pathway, again the corridor is another area where you keep your things, so that is another issue we commonly face. These are the indoor hazards in the houses. Okay, so I stay in an area which is mainly independent houses, so you will not find many flat pictures. The last one is a flat picture, it's a flat BHK. But most of the places I live are independent houses. So as you can see, so many hazards in these. These stairs are the most dangerous ones. Even I wouldn't walk on it, So, but we have all these kind of issues. A mat everywhere, poor illumination. Again, this is my area where you have these kind of hazards in and around the house. Right? So in another study, two studies in fact, we had discussed fall risk hazards outside the house. So it was about community mobility. And in these two studies, one was in the Physical and Occupational Geriatrics and one was in the Journal of Cross-Cultural Gerontology, where we talked about all these common hazards, which it's okay for you and me. We are able to manage it, but not an elderly. He will succumb to it, So too much traffic and crowd. Traffic rules not followed, that is the norm in India. Unsafe roads and paths. You saw the pictures. Steps at the entrance of public places, malls, court, church, temples. The more steps, the more beautiful. Difficult to access and use public transport. Steps have a purpose in Indian culture. There are many things you have to avoid for which steps are important. But the way the steps are done are important is what I'm trying to explain. Again, attitudes of people, concern of falls, they all had a concern of falls, and many times because of this concern, they had limited their participation outdoor. There are many other issues which are unique to the Indian context, our socio-cultural, geographic and economic context. So we have cultural influence of many other occupations such as the use of wet mops, cleaning yards and prayer area with water, oil bath. I don't know how many of you from the south, oil bath is a very, very traditional thing in the south. My father was a big follower of it, and so many aunts and so many people, they really swear by it, you know. Then cultural influences on architecture. So Vastu is a big thing. Many things of Vastu are excellent, but some things are a challenge for elderly. Bathrooms outside the house, very common in my area, not in cities, but very common in my area, where you have bathrooms outside the house. It's also related to Vastu a bit, and also because the old houses, they are adapting, so the bathroom remains out. Steps at the entrance of the house. Again, geographic diversity. India is a very diverse country, so rain, snow, and sand in certain areas. Living arrangements are different, nuclear and joint. Nuclear families, few people use the bathroom. Joint families, so many people use the bathroom, you know. So the issues become different. Soap remains when somebody else has taken bath earlier, and that could be a problem. Collective culture, no personal autonomy. Nobody takes a decision about whether I should put the grab bar or no. Uske liye bhi 10 लोगों को पूछना पड़ेगा. You know, they would ask 10 people about just putting a grab bar. Okay. Of course, limited social security and finances, and a fragmented healthcare system. So then was the issue of who also, like I said, among the questions. So we did another study where we talked about fall risk in urban and rural areas. You know, so we compared urban and rural areas. I think this was in Madhya Pradesh, indoor area that we had done this study. And we found that the fall risk prevalence was almost similar in urban and rural. However, urban older adults had higher intrinsic risk factors. They had poor balance, more health problems. They had also a lot of sedentary lifestyle, so more behavioral factors. And they also had more injuries after a fall. They appear to be more frail and a lot of activity restriction. Whereas rural older adults, they were more better off in terms of health. In terms of health, you know, I would say in terms of balance, they were better off. They were having more active lifestyle. But their risk was because of the hazards. There are a lot of hazards, both indoor and outdoor, and of course they had limited financial and healthcare resources such as checkups regular. They couldn't do all that. So this is very important because you need to know whether your client is an urban or rural area person, and where are you doing the work? Are you an urban or rural area person? So this is very important, one of the questions of who and where. Then we come to person. I'm not going to talk much about person because exercises abroad, exercises here, I don't think it matters much with the exercise. The issue is, do they adopt it? That would differ. Will they take up this exercise? How do you make sure this particular exercise program or this particular fall prevention program will be adopted by our Indian elderly? So that is an important area to be thinking about. Again, this we have done some research, whatever we can manage. So, you know, in person you have the typical issues, balance disorders, vision impairments. I'm going to emphasize on the Indian issues. So in India, we have younger patients with hip fractures. We have low, because of our issues with low mineral bone density, vitamin E deficiency, especially in post-menopausal women, poor sunlight exposure, skin pigmentation, and a diet deficient in vitamin D, especially among vegetarians. And it was found that Indians aged 50 years and older have a higher prevalence of this deficiency. Similarly, these are all Indian issues which are not so similar to the foreign countries. So when we are having a patient, we have to think about these comorbidities. When we are dealing with a patient for elderly, we have to think about these because these are unique to our scenario. And you need to evaluate risk factors. This is the most important thing, evaluating risk factors, especially intrinsic risk factors. There are several excellent tools developed in the Western countries. You know, I love my Timed Up and Go test, is one of the best ones. But there is a problem. These are not easy in busy outpatient units in our hospital. And you know that TUG requires at least 3 meters. Cane test also requires so much space. Birth balance requires 20 minutes. You don't have 20 minutes, in a busy crowded hospital. So these are the issues we used to face in our work. Another problem we had, as also highlighted by WHO, is this KAP, the knowledge, attitude, and practices. There are very few studies on this, and these are the three, one by us and two by other people in Vellore and Chandigarh. And it was found that in all studies, attitudes were very poor. Attitudes of older adults towards falls are very poor. Now, the other two studies were done earlier, and one of them was rural, so even knowledge was poor, and practices were also poor. But our study was done in an urban, semi-urban area with a little bit more educated crowd, so we got better knowledge and practices, but we still got poor attitudes towards falls and fall prevention. So these are the key things we found. In knowledge, they were not aware of multiple medicines being a problem. In fact, one elderly felt, more medicine means I'm better off. They even fought with the doctor, saying that, why have you cut my medicines? And then using bifocals while walking, they feel it is okay to use bifocals while walking. They were not aware that using the bathroom at night very often is an issue, and they didn't know what to do when they fall. They felt you should get up immediately, which is the most dangerous thing to do. Attitudes, hurrying. Indians are always in a hurry, so an elderly especially, So for some reason, I have seen my mother-in-law, phone rings, she has to run. I keep asking her, why are you running? It will ring, But no, she has to run. Climbing up chairs or tables to reach overhead. I'm sure you have many of your parents doing that. I had to stop my mom for this, Not reporting non-injurious falls, and of course, not checking their eyesight regularly. Practices, the key ones were low self-perceived risk of fall, okay? I'm sorry, there is a mixture of A and P, I'm very sorry. P is the middle one. Please excuse me, it's a mistake. P is the middle one and A is the last one. I'm very sorry. A, the attitudes, is low perceived self-risk of fall. Others may fall, but I won't fall. So this is even told in developed countries where this is a problem everywhere. It's a universal problem. My home is safe. Mobility aids are undesirable. I will hold somebody's hand, but I will not hold a mobility aid. And home modifications are unnecessary. So these are the key things we found. It's a 76 item questionnaire. So what are the gaps in the Indian context? I'm going to hurry up a bit. We don't have enough assessments for the environment. All these assessments which we have abroad are not suitable for our context. They talk about the shower, they talk about bathtub, which we don't use very often. They do not talk about, Indian bathrooms don't have a separate wet and dry area, so that's a problem. Washing vessels, in Maharashtra, many places, vessels are washed outside, and they have what we call as a mori, which is used for many, many things. So these are so many issues, and these are all risk factors. We don't have contextual, valid and reliable assessments for intrinsic risk factors that do not require much space and time. I'm talking about screenings, especially about screenings. Okay, so especially for balance and mobility and KAP, and we do not have contextual relevant, accessible, acceptable and feasible interventions which are suitable for resource constrained settings like ours, which are culturally acceptable, which are suiting us. And most importantly, whatever we have is in a small study and doesn't translate to bigger areas. So I'm just going to say how we have talked about how our research has addressed these. So we have taken both quantitative and qualitative research to address these issues, because qualitative research answers the question how very often. How, why, these questions are usually answered by qualitative research, and we use that very heavily in most of my studies are mixed method designs, and that's how we go about it. So we have developed these assessments, we also copyright them, and I'm going to emphasize in the last two. It's a marching in place test. It was published in the Asian Journal of Gerontology and Geriatrics, which is a simple tool. You can do it. It just requires one small place. It has got high sensitivity, but low specificity, which is why you have to first do it. And if a person is positive in that, you have to do higher test. Okay, so it saves time in a busy area. So out of 10 people, I cannot do TUG for 10 people. But if I do this test, I can reduce the time. So I will do TUG only for 2 or 3 people who have failed the test. And only if they fail TUG, then I will think of ahead. So I'm just trying to save time over here. The last one is a fall-related knowledge, attitudes, and practices, because we have patients, we don't have time. We make them fill the questionnaire, and when we come to know which areas they are having problems in terms of knowledge, attitude, practices, we have a booklet which we use for fall education. We hurry up what we know they know, but we emphasize on what needs to be addressed. For example, if he's not having good footwear, we emphasize on footwear in the education. But if the person is having good footwear, we don't touch much about it. So we save time again. So, and it's personalized. It is personalized to the person. Again, contextually valid assessments. We have developed assessments to evaluate the home. So the fall-related home hazard assessment is a tool that we have developed, which we use. And the first one, actually the first one is the one that we use. The first one is the one that we use now, mostly. It is adapted version of the second one. And it's a very comprehensive tool which assesses the house, indoor and outdoor, and various aspects of the house. And we have the bathroom hazard checklist for Indian context. So another issue is, how do we get this elderly to come and do the assessments? They don't come. As I said, low perceived risk. So we organize what we call, we take a public health approach, and we organize what we call as a community-based screening camps. So this is a unique approach. We did this 2 years ago. The first time we did, we had only 20 people who came. But last year when we did it, 200 people came. And more importantly, they were the same ones who are coming for the last 2-3 times. So it shows that taking this particular approach in a way to make sure they are fit. So in this camp, we offer free. So this is a camp done in collaboration with PT. Many professions of our college, PT, speech especially, and optometry. They are the 3 key pillars. And we offer comprehensive both hearing, physical, and OT kind of things. So OT does these aspects. We do functional screening. It's top down again. Functional screening. Are you having difficulty in bathing? They will say, no problem. This is very probe. We come to know we have certain issues. Then depression. Then we go down for depression screening, cognition screening, and balance and mobility. We do this marching in place because in 4 hours we have 100 people coming. We don't have time for TUG. We have to do quick tests. So we do marching in place test and some other small tests which we can do in a small area. And we also do the fall KAP. Again, fall KAP takes a little bit of time. So when they are waiting, we make them fill the form. You're getting it? When they are waiting, we make them fill the form. So they don't feel their time is lost. And this has been very well received. In fact, we're invited. And we are invited by the community people. For example, Rotary do it. And these camps require a lot of engaging with the community stakeholders. So Rotary, senior citizen organizations, they are very helpful. We do it in churches, we do it in schools because we need the place. And we are talking about 100 people coming. So it requires a lot of negotiation, but it's very good. This is what we did to make them come. And we take an approach of, we're not trying to find out whether you will fall, we are trying to find out whether you are fit. So try to come to these camps to make sure you are fit. This is a fund that we have got from ICMR, which we have developed certain things. So we have developed 3 things. We have developed the therapist-mediated education program, a mobile-based education program, and we have developed all these things by involving all stakeholders, both service users and service providers. So these are the brochures. These are all done for Indian context, Indian pictures, Indian people in the pictures. We have developed a therapist manual for this so that it is done in 2 sessions, not more than that because time is very important. And we have developed a handbook. It's a bilingual handbook which we use. I have only shown 3 pages which has exercises and plan, and all this content is the same thing which is there in the app. But the app is more visual, more personalized, and more thing. If you want to see the app, please visit our counter where we can show you the app. And the app gives tailored, context relevant and strategies, and of course supports behavior and change. But there are many things to do. There is fall prevention in diverse populations. Our program is more for urban, semi-urban areas, not so much for rural and socio-economic groups. So that's a very big area, and they are the biggest population, as you know. Our program is not fit for dementia patients or special groups such as frailty, so we can't use it. Moreover, we need to understand the influence of collective cultural adoption and adherence. So that is another concern, and we have an ongoing PhD going on understanding the involvement of family and others in fall prevention of older adults using a grounded theory approach. So that's what is going on right now. And another very important for any knowledge translation to practice is knowledge dissemination. So we had conducted a workshop on fall prevention. This is an old age home where we did the piloting. We did the practice part for the participants. I think some of them are here. It was a very nice thing for the elderly also. They were very happy when everybody came and checked their environment and them. So this is the whole cycle. Yesterday, Dr. Mary Benson talked about it. So as you can see, I have shown in my whole presentation how we went about it. Identifying the problem, adapting knowledge to the local context, assessing barriers, facilitators for knowledge use, finding out why, especially the knowledge attitude part, select, tailor and implement interventions, monitor knowledge use, evaluate outcomes, okay, which is what we are having a cluster study. It's in two taluks of Udupi district, so that's going on. It's actually over, but we are doing the assessment now. We are doing the result analysis, but we still have issues with sustainability. I don't know whether this will be sustainable, so we have to see that in long term. So the implications are, from what I take away from my whole experience of 25 years is, we need to develop assessments and interventions or adapt available resources for fall prevention in Indian for Indian context. That is an important thing, and not only falls, probably every other thing. OT researchers and practitioners need to adopt a need-based. Where are our gaps? Pragmatic, very practical. You have to understand what money you have, what resources you have, where you are, and do something which is feasible. I have no problem with virtual reality. It's not feasible in a semi-urban rural area. Okay, even elderly will not come for a virtual reality training program unless it is free. Will that be sustainable? No. Adopt a functional approach. We need to be distinct from PT. I will tell this 100 times. If you do only exercises, you're going to look like a PT. You're going to be lost in spite of all the work you're doing. So you need to adopt a top-down functional person, environment, occupation-based approach in fall prevention. Be culturally appropriate. And most importantly, everything I did was based on evidence. Either theirs, and if I'm using theirs, by theirs I mean developed countries. If I'm using theirs, I check whether I can still use it. That is why the validation processes are being used to make sure, yes, I can use it. Ask the elderly, do you think this will work? That is one way of validating. And then, of course, testing it out. So as I said, we are doing, many of these are trials. There are trials happening. Trials are possible only in PhDs or in funded projects. And it's very important that you write such grants, because without that, we can't manage it. So for future scope, like I said, is sustainability of these kind of programs or whatever program we develop. We cannot do fall prevention in only OT manner. It has to be collaborative. As I said, I work with doctors, physiotherapists, speech therapists, psychologists, whoever wants to work with us. And of course, even the community, senior citizen organizations, and most importantly, elderly themselves. You have to work with everybody. Public health approach if possible. It may need to be technology driven. Nowadays, elderly people like mobiles. That is why we developed that app. And you need to address many other populations. Again, we are very far from policy. In fact, only 2 countries have effective policies. One is UK and USA and Canada, 3 countries. Other countries don't have a specific policy on fall prevention. We need to work there. And of course, implementation in diverse settings. And again, here I would like to emphasize that we need to work together. Now, I have the privilege of being an active researcher, academician, and a clinician, but it's not possible everywhere. And that is why clinicians, academics, and researchers have to work together. We can't spin the wheel every time for a problem. And you can only save time by working together. It's taken me 25 years. I don't think we can afford each and every one of you spending 25 years. So we need to come up with a way which we can do this faster, and that's only possible by collaboration and, of course, knowledge dissemination, like I told, in platforms like this, such as IOTA conference. But more than knowledge dissemination, you need skill training. So the students need to be trained how to do it, and that requires some skill aspect of the program, such as a workshop. Lastly, it's not possible, like Mary Benson told yesterday, actually, Dr. Anabasur asked $1 million question. What is the biggest challenge? And Dr. Mary gave $1 million answer. She said, what did she say? She said it is attitude, right? Your attitude or your inflexibility, your ability to change. So that is $1 million answer. That is the issue. But I would like to add one more problem. Not problem, a solution. You need tenacity. It's not a joke running behind something for 17 to 25 years or even more. I'm not going to stop here, obviously, and we have to go on. Like even Dr. Manjusha was talking yesterday, this is years of work. You need tenacity. So even more than brilliance or intelligence, you need tenacity and an infinite capacity for rejection if you are to succeed. I have had many failures. I have published, yes and no, but for every paper to publish takes 2-3 years, especially if you're going for a Q1 or Q2 journal. You got to take that failure in your stride and you have to move on and try to improve yourself. Without that, you cannot go for translation to knowledge generation to knowledge practice or policy. Thank you.
Thank you, ma'am. Now the forum is open for the questions. I kindly request the delegates to ask one question, and if you want to discuss furthermore, you can discuss with the resource person. They will be available during the break time. Thank you.
Thank you very much. It was a nice presentation. I work with the community occupational therapy in Canada. And just to add on to that, we get the referral for fall prevention. And in my normal typical day of work, like I would see maybe 6-7 clients, out of that 3 would have the history of falls. And it's all recorded because the system is so organized there back home, right? If somebody falls at home, they would call 911, go to the hospital. So it gets recorded somewhere, as opposed to India. I can give you an example. My brother-in-law, who was living in Bandara, a small district town, he had a fall when he was walking and outside. And he was a professor, so people knew him, so they got him up, took him to the medical doctor, and he said, oh, nothing is wrong with you. This was a fall in Canada. They would go to the emergency. They would get examined thoroughly. And then he is discharged home, actually. So there is a record keeping. Some families also keep the records of falls. And like you said, an OT job is, so my job is to sort of do the assessment, like a thorough assessment, and discuss with client. We teach them, provide some modalities or provide some equipments to reduce the risk of fall. And I did a lot of reading on real fall, actually, so it's a very favorite topic for me also. If you go to the library and type fall prevention in older adults, you will get 40,000 references. That is how it is researched by a lot of people. But each fall is different, and each faller is different. So there is no tailored solution, like there is no solution. So you have to, as an OT, you have to do really good assessment and then come to some conclusion or recommendations. And another thing I would like to add, some people, like you said about attitude. So it's like some people take 2 or 3 falls before they accept OT recommendation, because they just kind of in their mind, it's nothing. It's normal thing for them. But if you're falling, that's not normal aging. Fall is not normal aging. So if you're falling, there's something wrong with you. So cognitive retraining, we call it, do things differently, but live independently. And in Western world, developed countries, people live alone actually in a home, right? And the spouse is the service provider. She is also 80 years old. Patient is 82 years old. So it becomes like OT job is really challenging in a way to teach both of them, or maybe train both of you not to fall. But anyway, I just wanted to add some information to that actually. Thank you very much.
Thank you so much, sir, for validating what I have been talking about, and to also know that it's not so different in Canada than India. But yes, the support system that they have is excellent, and we don't have that.
Yeah.
Attitudes are probably the same everywhere.
Yeah. Thank you. Thank you.
I just have a suggestion to the Occupational Therapy Union of India, sorry. We have a 2007 legislation called the Geriatric Act, the right to a senior citizen. I've gone through that whole act because I'm in geriatric medicine. The last page mentions about home for the aged. And I don't think, to the best of my knowledge, there is any aged home, at least in Goa, I have not moved out of Goa, that has got the infrastructure for fall prevention.
Yes.
I still think that the All India Occupational Therapy Association should write a letter to the government stating that if any home for the aged, because they make a lot of money, the home for the aged, if any aged home has to establish itself and get a license from the Social Security Department or Social Welfare Department, there should be an occupational therapist on board to certify that that home is safe from fall. That's all, ma'am. I think you all should fight for this. It has to come back. The government does not know the role of occupational therapists today. And it's time that they come to know. And it should be implemented in the Act. That's all, ma'am.
Thank you so much, sir. I agree with you. You also know that old age homes is a big business, which is not coming under government scrutiny very well. It's a very complicated area. Yes. I actually spoke about this to the president of the National Older Adults Association. She had come to Manipal and she actually said that we know, but they know about abuse, they also know about neglect, but they don't do it because otherwise where will they go? So yes, I know. 55, I know.
17 years we have lost, ma'am.
Actually, I agree with you.
17 years, my colleague here gets fracture neck femurs due to fall. It's time we do something. I don't know. That means we are sleeping.
Exactly. And it's not just old age homes. What about the court? What about the churches? What about the temples?
Correct.
What about the parks?
All other places, accessibility is made for disability people. But the aged homes, zero, ma'am.
Yes,
zero.
I agree. I agree. Thank you so much, sir. We can see how we can do that.
You can interact during lunch.
Oh, yeah, I'm done.
Thank you, ma'am. Thank you, delegates. I would like to extend our gratitude for your insightful session on falls prevention for older adults, adopting a pragmatic approach to translation research in the Indian context. Ma'am, your expertise and dedication to this area of research are evident in every aspect of your talk, ma'am. The importance of fall prevention cannot be overstated, and your work in the paving the way for future advancement in improving the quality of life for older adults. Thank you so much, ma'am. I would now like to invite Honorable Dr. Jyotika Bijlani, ma'am, Dean Accord, to felicitate our speaker, Dr. Sebastina Anita D'Souza, ma'am, with a memento and certificate. Thank you, ma'am. Thank you, ma'am.
I have to inform all the members of Accord that we have a GB meeting scheduled at actually 12, but now because Dr. Bajpai is also in the panel discussion, so we'll have a GB Accord after this panel discussion. So it will be somewhere around 12:45 or 1. Thank you.
Good afternoon, everyone. Now we are moving to the next session, scientific event, panel discussion on the topic, translating research into policies, challenges and strategies to overcome. I would like to welcome all the panelists onto the dais. Dr. Samantha Shan, ma'am, President, WFOT. Welcome, ma'am. Dr. Pankaj Bajpai, sir, Honorable President, All Indian Occupational Therapy Association. Welcome, sir. Dr. Suresh Munusamy, sir, Dean and Professor, School of Digital Health Sciences and Technologies, Malla Reddy Vidyapeeth, Hyderabad. Welcome, sir. Dr. Dagazish Kadodkar, sir, Professor and HOD, Department of Community Medicine, Goa Medical College, Goa. Welcome, sir. I would like to welcome our moderator for the panel discussion, Dr. Anbarasu, sir, a renowned and respected occupational therapist and an executive council member of All Indian Occupational Therapy Association. Sir has been demonstrated an exceptional leadership and expertise in this field. With great pleasure, I would like to hand over the stage to our esteemed moderator for the panel discussion, Dr. Anbarasu, sir.
A very warm good afternoon to one and all who have gathered here. It is my immense pleasure to welcome to this panel discussion. Our theme today is translating research into policy from occupational therapy perspective. Why is this topic so important today? Because the reality is no policy can exist without research. Similarly, no research holds a true value unless it is translated into policy. More than that, the greater importance of policy making is to empower the society, communities, and individuals through healthcare professionals, including occupational therapy. In this context, where do we stand today? And what is our current position? More than 100 years of occupational therapy worldwide, over 50 years of occupational therapy in India, but still a crucial question remains, where is the visibility of our OT? Have we really achieved the success of visibility in India? The another thing is, have we been really recognized by the government of India? The answer remains unclear and uncertain too. And the second important thing is, even after a century, we are still fighting, advocating, and struggling for the normal national level recognitions. Especially, I emphasize a formal recognition at the national healthcare policy in India. And of course, disability acts in India too. And third important thing is, when we look at other nations, including UK and USA, they have achieved far better policy integration than India. So that is the important thing here. These three important critical factors raises a serious question for all of us. Are we not really capable enough? That is the point. Second thing is, don't we have the right potential? Of course, we do have the knowledge, we have the practice, and of course, we have the research also. But why does our occupational therapy research has not been gained the dominant influence on policy makers in India? That is a next important question mark. So this is what I feel, research policy gap that cannot be ignored today. And let me, before we begin our panel discussion, let me put forward few examples in front of your eyes. In India at present we have RPWD Act 2016, of course, is a landmark legislation for disability rights in India, but it fails to mention our occupational therapy. Second important thing is the Mental Health Care Act 2017. This is a progressive step towards mental health rights. But the point is that this act completely overlooks our occupational therapy, really undigestible. Though we have extraordinary role in mental health rehabilitation and community reintegrations. And another important thing is The small happiest thing is the National Health Policy 2017 Act. This one recognized, not officially recognized, not officially included, but the point is that supported and encouraged to explore this role of OT for the futuristic things. So, how many of these policies and disability acts in India officially included our occupational therapy? The answer is ZERO 0. This clearly indicates that somewhere we are losing our ground. Where is the gap? Why does it exist? And more importantly, how do we bridge this gap? There is a point here. That is a core discussion point here. We have gathered here to explore the challenges and strategies through our world-class leaders as a panelist today. And I'm really honored to introduce our panelists to you. Our first panelist, Dr. Samantha Shaw, the president of the WFOT, with a distinguished career in occupational therapy. The ma'am has been at the forefront of advocating for the role of occupational therapy in global health policy. We are honored to have her insights on today's topic. I welcome you, ma'am. Next, we have Dr. Pankaj Bajpai, the president of the All India Occupational Therapy Associations. Our president, sir, has been a driving force in advancing occupational therapy in India with a strong focus on professional development and policy advocacy. We look forward to hearing his perspective on the challenges and strategies in translating research into policy. I welcome you, sir. Our third panelist, Dr. Suresh Munusamy, Dean and Professor at the School of Digital Health Sciences and Technologies in Hyderabad. A visionary in the field of digital health, Dr. Munusamy's work explores the intersection of technology, healthcare, and policy. We are really excited to hear his insights on how digital health research can drive the policy change. I welcome you, sir. Finally, we are joined by Dr. Jagdish Kakokar, Professor and Head of the Department of Community Medicine at Goa Medical College. With extensive experience in public health and community medicine, Dr. Kakokar has been a champion of evidence-based policy implementations, particularly underserved and rural areas. We are privileged to have his expertise on today's panel. I welcome you, sir. So let us begin our panel discussions now. The first, we begin with our WFOT President, Dr. Shan. Ma'am, dear ma'am, first of all, we would like to appreciate our WFOT for advocating our occupational therapy at the global standard. Thank you very much, ma'am. So our first concern is, as President of WFOT, how do you see the occupational therapy research influencing global health policies, and what are the challenges you have faced in the process?
Thank you. Thank you for the question. Yes, I think probably just to give a little bit of context before so people can understand that. So WFOT, the World Federation of Occupational Therapists, is in official collaboration with the World Health Organization. And we've had that official collaborative relationship since 1959. Now, we are only one of 8 health professions to have had such a long-standing relationship there. So we should be proud of that as occupational therapists and recognise that is not a given. That relationship is assessed every year by the Executive Board of WHO. What that means is that as occupational therapists, we get a seat at high-level meetings. So when policy is being discussed on a global level, WFOT has a presence, is able to input there. So how does that work? Is we get global action plans. So the Global Action Plan on Disability, the Global Action Plan on Healthy Aging, the Global Plan on Disability. There's a Global Plan, an Action Plan on Rehabilitation due next year. And what we can do is get occupational therapy mentioned at that high level action plan. And what then should happen is region-wise, is that should follow down. So that's working from that top level at WFOT. You then have your associations in countries, so the All India Occupational Therapy Association, who should be taking some of that forward and does do that as well. But then it comes down to you as well. And I think what we have to recognise is whilst occupational therapy is a very diverse profession, and we know that we can work in many, many areas, our health policies, WHO, the member state is the Ministry of Health. Okay? So whilst we might see that occupational therapy can fit into lots and lots of different agendas, and we can, the priorities of the Ministry of Health in any country, India included, will come from those relationships with WHO. So we need to be more strategic as occupational therapists, and we need to align our research with WHO priorities, because it's the WHO priorities that our ministries of health listen to. So my biggest question back to all researchers is, why are you doing the research? Are you doing the research for your own career? And that's fine. But if you want your research to really influence, you have to be looking at what's influencing your government. Okay? Because their influences are coming from elsewhere, not from here.
Yes. Thank you, ma'am. Your sound is really extraordinary. So ma'am pointed, the very important thing is doing research is not important. The how, what type of impactful research are you doing? So based on the impactful research, you can affect or impact or influence our policy makers or Ministry of India. Thank you, ma'am. Thank you for your answer. And next, I would like to ask questions from our IOTA Honorable President, sir. So we know that you have extraordinary experience in the government sector, and of course, you are a former director in NILD. So during that period, so what are the challenges you have faced? And really, we want to know, as an occupational therapy, so how to influence our policymakers in India. At the same time, what are the expectations from our policymakers in India? Because you are working in extraordinary government sector. Real expectations.
Yeah. So first of all, what Ms. Samantha said, that part is important. Research for those areas which are more related to the heart of Indian government, vision of Honorable Prime Minister, then only it can be, you can, those research outcome will can give only due consideration from the ministry. This is one. Second, there are many things are going on in various colleges, various researches are going on which are in line with that also. Those, through those researches, unless they are coming to the ground level, they are basically useless. But suppose in some college, some work is going on, like in some colleges, work is going on the mental health. Some colleges, work is going on related to driving assessment and having some collaboration with the RTO and getting the license to the persons with disability who are eligible for that, who are cleared through the assessment. But that database is not there. Suppose if some college this work is going on, this is only localized to that college. It is not being spread to the other. Yes. Means such type of training, if it is given, or it is some selected area, selected pockets, or OTs, occupational therapists from different states or different districts even in that state, if they are trained for that, then the matter can go beyond that city. and then that can be taken by the others also as a model, you can say. So that training database. So first is research of related area, which are more close to the heart of the government. Then the outcome which is being used by the professionals should have a broad database gradually. Broadly it should be means more of the occupational therapists should be skilled and trained in that particular field. And then comes the part of approaching the government also. Lobbying from the government side, that lobbying is also required. Like nowadays you can see that at various institutes, occupational therapists are being selected as a director. That condition was not there earlier. Like in NILD, Kolkata, the occupational therapist is director. There is a few composite rehabilitation center, regional centers are there, where occupational therapist is director. So they are in the position to implement the policy. As you asked in my institute during my functioning, at least in our institutes which are under Ministry of Social Justice and Empowerment, there we get little bit free hands. We are given more chances. They are little flexible, and we are given more chances to do that. So we didn't face much of the any barrier in that way. So second is lobbying. Third, approaching them and continuously pursuing. When the question comes continuously pursuing, because matter is related to the health, and health is related to the state, not to the center directly. So our state branches must be very strong also. Their numbers must be more, because in India, numbers give some due value everywhere, starting from parliament to everywhere.
Yes.
So those numbers are required at the branch level. Then the branches should also be spreaded in different states and different cities also. They should work. So lot of work is to be required for that. Suppose if some letter goes to the ministry or to state or a central, they always think, like you said about the Mental Health Act, like you said RPWD Act. If suppose they include occupational therapy, something I'm telling from the side of government, thought of the government also. Suppose they include the occupational therapy as a board member for certification of mental health case, for example. Can we guarantee that every district will have an occupational therapist to include in that? So what will happen to those districts? Same thing happens in the locomotor disability area too. So this always remains a gap there. So fulfill that gap, we need trained persons, and trained persons in most of the areas. Like there is a cluster in, say, in Bombay or Mumbai. So this can be done in Mumbai. This can be done in Nagpur. This can be done in Delhi. But talk about other places. So how many occupational therapists or trained occupational therapists for that particular job are available in different districts of different states? That is a big question.
Yes, sir.
So that is why whenever, like many times you say or you get the news that a particular post has been remain vacant or has gone to some other professional. Why so? I have taken many interviews where only one candidate was there as an occupational therapist. And that post because of not found suitable category, because for one we cannot select. So that is why it gone under NFS. And if it remains NFS for many years, 2 years currently, so it is lapsed. Yes. It is a government policy. So number is required, number one. Trained persons are required, number two. And to cover vast area is required, number three. And today also one presentation was there and some comments from one doctor was also there. I think sir has said regarding old age home. So that part can be taken from the government side because government is already instructing to government hospitals to apply certain norms. Same way that can be approached for the government because government can instruct them because OTs are not required there. They may be a consultant or that policy can come from the government and they can include that. But unless we provide then somebody said about the position paper, that is also required. What is the definite, like earlier there was no recognition of occupational therapy in government level. Now National Commission has come. In the National Commission, the definition of occupational therapy has come. So in that way we can only proceed. So basically we need a big database, trained person in different districts level, then we can say.
Yes, sir. Yes, sir. Yes, sir. Thank you, sir.
Thank you very much.
Do you mean like, so I don't doubt our Indian occupational therapists' abilities, capacities, for nothing. So they have absolute knowledge in our OT. Do you feel weak advocacy is a major issue? Because at the initial beginning point of your discussion, so you acknowledged all similar to the weak advocacies. And moreover, it is not spread to the more number of government people, so we couldn't be able to influence them directly. And another important thing is lack of skills. We can do research, but do we really or publish our research or communicating appropriately to the community and society? Therefore, we can bring it to government attention. So you feel like it's a lack of skills in research.
One point actually I forgot to include, along with yours, I will reply to that also. Inclusion of those persons who can be utilized for lobbying in our different programs, different training programs or different, say, workshops or different conferences. That is also one part. Like sir is here. So definitely something is going on in his mind and he is also replying, he is also thinking. Our presentation he is saying. So something goes into the mind. Same way other persons should also be there. So that is the main issue. And as far as advocacy is concerned, advocacy, who can advocate? Who thinks that a power is behind that advocate? So if one feels that power is not there, then advocacy definitely will be poor. If some says that, okay, what I am saying, I have many thousand persons are there saying the same thing, then that is considered.
Yes.
So that is why I am telling every time strengthening of the branches.
Yes, sir. Yes, sir. Sure. Thank
you,
you,
sir.
very much. Thank you. Thank you for your valuable insight, sir. Next, we will proceed to Dr. Munusamy, Suresh Munusamy, sir. Sir, dear sir, you have worked on multiple government-funded health initiatives. What are the key expectations of policymakers when considering the inclusion of occupational therapy, healthcare frameworks, and in addition to that, how can the OT community strategically advocate for the stronger recognitions in India, sir?
Well, thank you for the question. And during your introduction, it almost felt like a little bit of a rant. I'll try to kind of perhaps like see things slightly differently. Let's put it from an individual perspective. All of us have about 24 hours in a day. And broadly speaking, at least on paper, we have to work about 8 hours. Some people say 10 hours, 15 hours. Let's leave that. 8 hours we work. And then you are also looking at 7-8 hours of sleep. And rest of all what we do is the remaining 8 hours. So this 8 hours is the occupation time. And essentially, 1/3 of all the time that we spend in adulthood is spent doing some kind of a work. And yet, we are actually perhaps like looking for a place under the sun where all of us contribute to 1/3 of the time, and most of the disease conditions or perhaps like our life trajectory is decided by what we do in these 8 hours. The challenge here is we seem to be working in a very reactive mode. Okay? We are not doing things proactively. As in, let's take two scenarios here. You are doing some work 8 hours for 30 years, and post 30 years or even during 30 years, your life is decided by what this is actually doing. So when a patient actually comes to you, most cases he does not come directly. He comes through a very circular process and then actually ends up with you. And a lot of people, in some cases, don't have access to occupational therapists, don't know occupational therapists, and in most direct cases, usually ends up with a RMP who is a know-all person, or perhaps a general practitioner like me, again a know-all person, they do everything. So the actual pathway of this person coming to you is fairly very slim. Okay, at least that's my opinion. What is not actually happening here is the role of occupational therapists on the preventive side. Okay. Let's take perhaps the new profession that has actually come up in the last few years, 10-minute deliveries. Okay. It was not there 5 years before at all. Now suddenly there are so many people going around in two-wheelers delivering whatever we want in 10 minutes, and there are so many issues with it. A lot of documentation actually happens. I mean, their route is tracked, their orders are tracked. What is actually not tracked is their health status, their mental health status, their physical status. None of it is actually tracked. But there is an opportunity there, potentially. So here you have a new occupation that is literally emerging right in front of your eyes. Potentially there is a platform to track because everybody carries a mobile phone. Yet I haven't actually seen any occupational therapists focusing on it and then coming out with active guidelines and then say this is how things should actually be done. Now, what is already happening for the last 10 years, 20 years, 30 years, people are always reluctant to change. That's the way life is actually. At least when new occupations are actually emerging, again, post-COVID, there is a new type of occupation called as work from home, or a setting called as work from home. Again, it has its lot of challenges. And then there are a lot of newer other occupations also that are actually coming up. Proactively, what we need to at least try to do is come out with a series of recommendations or perhaps steps that can possibly be included and say this is the best way to do certain things. Now, and this is where at least this digital platform helps you to monitor you continuously. You are getting all these data points, but broadly, a lot of people don't know what to do with this.
Yes,
Okay?
sir.
If somebody actually stands for 8 hours throughout his life, what is the effect on his health? And that's a reality because, again, you have, in the last 5 years, a lot of these e-commerce warehouses where not even a single camera is allowed inside. It's black box, actually. And people have to literally not just stand, but walk for 30 kilometers, 50 kilometers. If you just keep tracking that, they are actually doing it. No word about it. So these are newer emerging areas where it is possible to continuously track, but also it is possible to give very granular interventions also. You know, there are watches, wearable devices that basically tell you after every hour stand up. But if you reverse the pathway, after maybe 20 minutes, it can also tell you please sit down.
Yes.
I haven't actually seen that application so far. So this is where you can proactively come out with certain things and then say, okay, this is good for a certain occupation. Now, from the government's perspective, if you look at our policy document versus maybe a policy document from UK or USA, one basic thing you will notice is our policy document is like a directive. Do this, do that. Don't do this, don't do that. And it's usually 2 pages or maybe like 10 pages. Other side of it, policy documents runs into thousands of pages, extremely detailed. It details the setting, it details the person, it details each and every activity, it gives you 10 examples, and then say this is how things should be. Now, details are actually missing in our policy document. And this is actually...
So you emphasize the documentations.
Details. As they say, God is in the details, devil is in the details. Details are actually missing. We talk at a very high level. Details are unfortunately missing in the policy documents. And this is what, unfortunately, on the government side also, when we start talking, a lot of the discussion is at a very high level. There's very little details. We need to precisely tell, okay, this is how things should be done. Nobody is going to refuse it. The problem is details are actually missing, and that has to come from, obviously, a lot of research. But research in a proactive way, research that actually means something to the people, not necessarily for a publication, but research that actually leads to better practice, research that is targeted at the personal, but at a very detailed way. I haven't actually seen a policy document
I accept one point.
for healthy, for smart cities. There's no policy document for Swachh Bharat. Lot of things are directives that are issued by bureaucrats, politicians, also by academicians, and then say, let's do this. Details need to be there, and that needs to be issue that I keep seeing repeatedly.
Yes, yes, I accept, I accept. So, sir highlighted occupational therapist should adapt proactive approach, not reactive approach. That is the first point. Second, sir, acknowledge that details are very important thing. So in this forum, I would like to recollect one important thing, what happened, one detail missing in our OT. So earlier RPWD Act, it acknowledged our occupational therapist as a certified person, which means occupational therapist can certify for learning disability conditions. But unfortunately, what happened in 2024, I think, the point is that the detail missing. Because of that, no occupational therapist took responsibility for establishing assessment scale for occupational therapy. And another important thing is, and no one established the evidence and facts. As an occupational therapist, we have excellent role in learning disability. Why the problem? Detail is missing. Why the detail is missing? This is what the reactive approach. So we should adopt a proactive approach. Therefore, we can enhance and transcend our OT professions. Thank you, sir. Valuable pointing up. Thank you very much. Now, we would like to move to Dr. Jagdish Kakogar. Sorry, sir. Sorry for the wrong pronunciation. Jagdish Kakogar. So, dear sir, so community medicine often deals with population level health challenges. So what are the biggest barriers you have faced in translating community research into actionable policies, especially underserved areas?
Thank you very much.
Yes, thank you.
First of all, I thank you all for inviting me here.
Thank you, sir.
It's been 10 years that I've been heading this department.
Yes, sir.
And almost same amount of time, this occupational therapy was set up as a allied health science at the Goa Medical College. Rather new in Goa, since more than 10 years. We work as community medicine and public health persons at the rural level, at the ground level. We conduct various cancer detection campaigns, non-communicable disease campaigns. I just came from a mega camp in the morning to detect these NCDs. Let me be very frank, and I hope everybody who is in the audience taking it in the right spirit, what I'm saying. One cannot stand up and say, I'm important and take me on board and listen to me for a policy.
Yes, true, sir, true.
If I stand here, probably it's because the local faculty realized that my department has been doing outstanding in research. Together we have published about 150 research papers in indexed medical journals in the last 10 years. No other department of the medical college has done that. Now, I see a lot of proposals. I see a lot of papers in your field of occupational therapy. I'm not at all taking the credit away of those people who are doing good work. I'm restricting myself to Goa and India. I'm not speaking about the West. The first thing is, these youngsters who are in the audience, if you ask them, what is the purpose why you are doing the research? Do you start doing research once a conference is announced? And once the conference is announced, the students are told by their faculty, look, you got to present some poster, look, you got to present some paper. And then you will come to our ethics committee. I happen to be in our college ethics committee and pressurize us to hold a meeting, expeditiously give you ethical committee approval. And then we sit in the ethics committee and look at the approval. This is typical, I'm telling you. I'm requesting you to improve upon this quality, otherwise you're not going to generate sound evidence. If you want to be heard, if you want to be noticed, and if you want to figure in some policy making, your quality of research has to improve. And for that, the faculty and students have to apply their minds that you can't rush into doing research once a conference is being announced. You can't do research like that within 3 months. Yesterday, I finished a meeting. I have seen about 10 proposals from the particular discipline. Sample size, 10. Method of sampling, convenient sampling, purposive sampling. How was the sample size determined? No answer. Conflict of interest? None. Self-funded. What is the research question? Now we come back to that. And then how are the objectives framed? What is the method? What my suggestion is, let's say I don't know, I'm not here as an expert.
Yes, yes.
I believe I'm a lifelong learner. I still learn from my postgraduates when they present in the PG class, which I hold thrice a week. I sit as a neutral person, open to learning. I don't consider myself as a person who knows everything. Your faculty, your postgraduates, the simple thing that they can do is conduct a simple assessment in your respective medical colleges or institutions. Which are the departments in the college who are interested in research? What are the difficulties that they face? Let's say in orthopedics. What are their difficulties as far as handicaps? See, there's no doubt about it that WHO and international agencies have priorities of research. But when you will relate and teamwork with them, when you do the kind of research which relates to them.
Yes, absolutely, sir, absolutely.
Supposing the professor of ophthalmology tells me that ophthalmic services in Goa are excellent, but they're not so good in the rural areas. I organized camps with the former dean of the college who was an ophthalmologist in 28 areas where there is no ophthalmologist. So when you go to areas where there is no ophthalmologist, you understand the problems of ophthalmic care at primary level are different. It's easy to say something in medical college. Go to the ground, go to the field. All I'm trying to say is, like one thing which is nicely done by National Medical Commission for MD, MS students is, every student in postgraduate in medicine must enroll for the basic course of biomedical research of the ICMR NIE, Chennai.
Yes.
You go to the Swayam portal, it is available. What stops you from making this rule? Okay, you are not happy with BCPR, you have some course yourself. But don't do it in bits and pieces. Because if you are trying to publish papers in predatory journals, if you are publishing papers by paying large amounts of money within a month's time, within 2 months' time, what is the quality we are looking at? Are we looking at a Scopus journal? Are we looking at PubMed? Are we looking at Web of Science? No. We are looking at some Google Scholar. We are looking at some people. I have heard people say, I've got 200 papers in Google Scholar. How many have you got? So I told him, I've got 106 papers, sir. But I didn't check whether they're in Google Scholar. But I checked if they were in Scopus, PubMed or Embase. And that doesn't happen within 3 months. You have to think properly. First of all, the faculty themselves, then the postgraduates, maybe later on the undergraduates, have to understand that they must know the basics of research. BCBR course is one such course you can do sitting at home at your own pace within a period of 6 months' time, hardly 5,000 rupees. And you can do it at your own speed and then revise. Why don't you share with your faculty and PGs which are the online courses, what is Zotero, what is Mendeley's Reference Manager, what is programming in R, or what is something which is cheaper in developing countries like ours. We can't have, student can't afford SPSS or Epidata, it costs money, right?
Yes, sir, sure.
All institutions, even ours, doesn't have a SPSS which is licensed. So why not teach them programming in R? Why not teach something which they can do freely? Why not send them to the institutions where we can, like I'm not good in qualitative research, but my colleague in St. John's, Bangalore is Bobby Joseph, sir. So I send my own postgraduates to Bobby Joseph, sir, to learn about qualitative research. I am a fellow who is 25 years older in this field. I don't know much about this Bandless Reference Manager or Zotero. Let me call some faculty who will teach them there. We have to start with the ABC first. Without ourselves being capable and competent, we can't start jumping and say, give us importance.
Yes, sir.
And second thing, most important is working together works. This has always been my slogan. None of us are less important or more important. We have to prove our work by doing service. Once upon a time, my department of preventive social medicine was something unwanted. In fact, we had one postgraduate seat in my department, and every alternate year the seat used to be vacant. Nobody wanted it. Last 10 years, I've increased my seats to 7. So there are 21 PGs in my department. Yesterday, my 21st seat is also filled. And people are coming from Punjab, Kerala, and Tamil Nadu to Goa, which means that word of mouth from postgraduates has spread, that they are getting to learn something. No amount of posters and social media messages can attract good people to you. What attracts people to you is your quality of work, quality of training, your exposure. So my request to you is, let the students be told well in advance.
Yes.
This is the timeline. This is when you're going to appear for exams. Well before this, finish your thesis. Well before this, work on a paper, poster, and not at the nth hour once the conference is announced. I'm sorry I took your time, but I felt that this is important to improve quality. Thank you.
Thank you, sir. Thank you, sir. Dear professionals, our Dr. Kakurkar strongly pointing us behind research with why, not for namesake. Don't start the research. First start with the why. What is the reason? The how best your research going to support your society, community. And more importantly, occupational therapist. In every textbook, OT textbook, we are studying like meaningful occupation, meaningful occupation. So this is what our Dr. Kakurkar pointing that we must do meaningful research. That is the ultimate thing. And another important thing he pointed out, in his experience, he found that our faculty also should take responsibility for the best research. Therefore, they can help and support the students also. Thank you, sir. Thank you for your extraordinary eye-opening message to this forum, sir. Thank you. Now, I come back to our Honorable Madam, WFOT President. Madam, how does our WFOT translate our OT research into global policies, especially how to advocate to the policy makers? Can you suggest any strategies for Indian context? Because in India, we have a multi-language, multi-cultures. So how occupational therapists, Indian occupational therapists can advocate with policymakers? How do you approach actually, your approach and your attitude?
Thank you. I think really just to reiterate, and I think all four of us have said it in some different way, is that you really need to think about why you are doing the research and make sure that there is strong validity in the research. Because WFOT or a government or any policymaker cannot use a sample size of 10 or a study that happened in 6 or 7 weeks. It's just not going to happen, okay? And that's just the stark reality, okay? And I think it also goes back to what Sir was saying, is about like, we have to be realistic of where we are as a profession. And whilst we can advocate at policy level, we have to be able, if we're going to advocate for something, we have to be able to deliver the goods. Okay? So if we were going to advocate for, let's take the example that's come this morning of occupational therapists in older people's homes, we have to be confident that we can put occupational therapists in older people's homes across all of India. Okay? Because otherwise the policymakers are not going to listen. Okay? So there's the research aspect of why and what occupational therapy can offer, but as an education basis and as students, practitioners, and where we position ourselves, can we also then fulfill that promise across whatever scope? And I think then it comes back to sort of like what you're saying is what do we do at a WFOT level? It's about building that capacity. It's about building workforce. Because to affect at policy level, you have to have the workforce to do that. Okay? And again, this is very hard as a profession because, you know, there are lots of opportunities. There are lots of places where occupational therapists can work. But maybe, and we have to be more strategic. And that is probably where the leadership of the All India Occupational Therapists Association can take that lead with all of you as its members. But what are the 5 strategic opportunities coming forward in the next 10 years? Where can we as a profession here in India make the most difference? Yeah? Because if we have then strategic priorities, that then influences the research and it can help with teams, like you say, is like where do we go to find multidisciplinary teams to make quality research or occupation-based research? And we then look at the priorities of workforce development that then affects the education of students and fieldwork and where we position ourselves then within that diversity. And I think right now there is a huge opportunity for occupational therapy. One of the big global health agendas at the moment, and it's the first time in a 75-year history of the World Health Organization, there is a resolution on the table about strengthening rehabilitation in health systems. Now, I feel very strongly there is no rehabilitation without occupational therapists. Okay? But we have to position ourselves so governments see our value. Okay? In the next 6 months, WHO is going to be putting out the indicators that our governments, our ministries of health, are going to have to report back on to say that they are investing in rehabilitation. Our ministries of health in 2023 unanimously signed a resolution to say that they would invest in rehabilitation. They don't know how to do it. We have to show them and tell them how to do it. And this is about being proactive. Yeah? It's taken 75 years for the World Health Organization to recognize rehabilitation properly. But recognition is that first step. We have an opportunity to be proactive and do quality, valid research, long-term research that will make a difference and show the value of occupational therapy. And that's where I think you need to go.
Thank you, ma'am. Thank you. So, dear professional, ma'am pointed very clearly that at present we have extraordinary opportunities than any other professionals. It is completely a big opening for us. But are we ready to utilize the opportunity? And we must strengthen with our workforce. That is the ma'am concerns now. Thank you, ma'am. Thank you for your insightful words to us. So next thing to our Honorable President, sir. Said, yes, sir. So we know very well because we are very closely observing you. You are very dynamic and young mindset person. So this is the first IOTA conference you are leading now. And after you take the position from the IOTA, and another important thing is yesterday we have received Dr. Yagna chairperson from NCAP. So after this, the commissions, the National Commission for Allied Healthcare Professionals, so what kind of plan and strategies you have for our Indian occupational therapists? Therefore, we can advocate in better way, and therefore you can influence our policymakers in India. So what kind of plan and strategies you have, and what are the major advice for our Indian occupational therapists, sir?
With reference to the yesterday's presentation, one thing which was required, and I am advocating that to first our professionals to get enrolled. That enrollment is going on. So which is that is why I asked about the number. I told about the number, because with the number only, policy will be made by the government. Say example, if our numbers are less, very less, say, very less, if I assume, it can be merged with the other profession.
Yes, sir.
Then there will be difficulty. Then we will have to fight for that. Because number gives us some power.
Yes, sir. Absolutely, sir.
Then when the numbers are there, when our position is there, then you can suggest we can collaborate with them, as I discussed with her also. Can we have certain courses, programs, which can be accredited by the National Commission or the State Council at their level? But although it is a long-term goal, it cannot be going to be, because it is still in a nascent stage, and it is gradually developing. She is also feeling lots of problems. She is also concerned about the number. That is why she told yesterday in the presentation. So enrollment is the first, what you can say, is a compulsion for us to get something done in the National Commission level. And after that, our collaboration linking with the Commission and the Council level, so that professional issues can be placed to them, so that whenever they design some policy, because then policy decision will come in the hand of councils. So then they take the decision including us also. At many places, in many councils, although those councils are not still very active, but at least nomination of occupational therapist has happened already. So that is again a change in the policy.
Yes, yes.
So that advocacy is always required, but I always feel that advocacy comes through number only, otherwise nothing. Research is important, definitely. Proactive, those researches which can put on the ground and can help the occupational therapist to develop a skill. And those skills should be broad-based, having good data support. So this much is my future vision, you can say, for a short term and a long term. Thank you.
Thank you, sir. Dear professional, our Honorable IOTA President strongly suggested that there is no value for words, only numbers. So how best we quantify ourselves, we can transform ourselves and transform our occupational therapy professions. Thank you, sir. Thank you for your great words. And finally, Dr. Suresh, sir, please give us your final thoughts to our occupational therapist.
Well, only one thought, which is, please talk solutions. Okay. Everybody talks about problems. Research is not documenting problems nor highlighting problems, but rather coming out with solutions that, unfortunately, our people should be able to actually implement. And this is the reason why a lot of government guys really don't bother listening, because we are not talking solutions here. We want to kind of integrate policy into the practice, but look at all the big companies. E-commerce doesn't have a policy. There's no policy. There's no policy for Uber. There's no policy for Swiggy. There's no policy for Amazon. Yet they are running billions of dollars of business because they are actually creating value to people that governments don't want to step in, because if you stop Uber and Swiggy today, people will probably complain. There's no written document there, and yet they are actually running. I'm not suggesting that let's do whatever we want to do without a policy backing. But the idea is you need to
No,
create...
no, you are rightly pointing. So first you create the value,
Yes.
then next things will come.
Yes. Policy is usually not proactive. Rules are never proactive. Innovation is proactive. What I also don't see is, I sit on a lot of these startup evaluation committees. I haven't actually seen a person from an occupational therapy background coming out with a solution and say, this is the idea that I actually have. Any of the students here have startup companies? Can you raise your hand? Are you a student, sir? Okay. Well, we are all lifelong students. Okay. Maybe by proxy. So, you see, I mean, take account 100 people, one.
Yes.
And that's not actually a fair way to even, look at our future.
Yes.
So, please talk solutions. And my view is always, if you identify a problem, you are not a smart person. And that's what we all think. Talking about problems for like hours together makes us look smart, but we are not. The real smartness is actually addressing an issue and then coming out with a solution. And that's where the real smartness are. And we talk about a lot of things that are not at all relevant to our population, at least as a priority. Of course, everything is relevant to our population, but there are a lot of things that are priority. If you even look at our hospitals, you go there, any district hospital, morning 7 o'clock to 10 o'clock, 1,000 people show up, in fact, more than them. There's no registration system anywhere on the planet which can actually register 1,000 people in an hour. And yet we have the ABDM. So this is what happens when you are actually importing Western solutions onto our population without even a simple thought on how you are actually going to implement those things. We are talking about falls. A person who has fallen actually will go to an orthopedician, but an occupational therapist should perhaps be before where he has actually fallen. There we don't see anybody. So these are some of the areas where occupational therapists should come out with solutions because they are the knowledge experts, they are the subject matter experts. And then start implementing them and create value to people and make a business out of it. Nobody is stopping. So
Yes,
my final thoughts or perhaps like only thought is please talk about solutions, not about problems. Everybody has problems.
Absolutely, sir. Absolutely. So our occupational therapists definitely take it as a biggest thing from this forum, especially from your words. And finally, Dr. Jagdish Kakoga, so please share your final thoughts to our Indian occupational therapists.
Sir, I have one suggestion.
Yes.
I was only focusing on research because I was told that's the theme for the panel discussion. One simple suggestion I'll give you.
Yes, sir. Sure, sir.
Supposing the faculty or the student or the team is considering a research for a child health problem, why don't you take a pediatrician on board?
Yes, sir. Yes.
In every department of pediatrics, there's always a faculty who is a good researcher.
So you were talking about multidisciplinary, interdisciplinary
Not
aspects.
to such extent, sir. In our own college, now we have Dr. Edwin here.
Yes, sir.
He has vast knowledge about geriatrics.
Yes, sir.
If you are doing something about falls in elderly, why don't you take Edwin sir's medical inputs? Supposing you're talking about prevention of unintentional injuries, why don't you take orthopedics together? If you're talking about doing something for rehabilitation of head injuries, take the neurosurgeon on board. What I'm trying to say is,
It's a team.
each one of us think differently.
Yes, sir. Sure.
When I started this cancer detection abhiyan in Goa, we got a 3 crore van through CSR, and we started doing cancer detection in the villages. We were doing the traditional way, the mammography and pap smears and all that. One person came from BITS Pilani. BITS Pilani is there in Goa also. He said, let me apply artificial intelligence. You give me the images. We'll try to give you a quicker diagnostic, and compare the use of AI along with your regular testing and detection methods. The brains of engineers work differently. They have the solutions finding in mind.
Sir.
What I'm trying to say to you is, the faculty should not think that you know all. We should be humble enough to accept that I don't know everything.
Yes, sir. Definitely, sir.
Now, there could be scales which are from the Western world. There were some scales which are presented by the earlier speaker. Are many of these skills applicable in our setting? Can you apply them as they are? No. Many of those questions, now supposing you apply a detailed scale, we don't have a OPD like I've been to America where a patient is seen by a doctor for several minutes, maybe an hour or two. For an hour and two, if you start in a general OPD in the medical college, OPD will run 24 hours. 1,500 patients are coming every day. It's not like in the West where there are a few dozen people visiting with a consultation. Right? So we have to be practical, no? You can't apply a scale which takes administration of 1 hour in a matter of 10 minutes or 5 minutes. People will start screaming. Today morning, the camp I had gone for, I went prepared for 200 patients. The arrangements were for 200. Suddenly, so 500 people have turned up because facilities are being offered free of cost. Point is, if you have all those related people, and the faculty in every department knows, in each institution or college, who is good in research or in the practical knowledge, that will help you to arrive at solutions faster, which are more meaningful.
Yes, sir, yes.
Right? And most important, what I'm trying to say is, yes, you look at WHO and international strategies and core areas for research, but also ask the people in your college or in institution, what are their felt needs? Whether your own medical college, like ours, is accessible to the handicapped persons? Is the geriatrics ward accessible to the handicapped persons? Is there a lift? You see, I went to see one patient the other day. I was just wondering from,
Yes,
we advise and we, tell other people so much. Are we having our own house full of glasses, before throwing stone at others? So we have to see that our own hospital, our own settings are friendly for those people who are handicapped or, disabled in variety of ways. And involve the concerned discipline. That's what I feel is a simple practical solution I'm giving you to take those concerned specialists on board.
Yes.
You may arrive at a solution faster.
Yes, absolutely.
Thank you.
Thank you, sir. Thank you, sir. Dear professional, our doctor advised very strongly. Occupational, you are not alone in the rehabilitation program. We must seek and take expert advice from other doctors also. That inclusion and collaborations is very essential today. And as we come to a close of this insightful panel discussion, it is very evident that bridging the gap between research and policy integration requires the persistent efforts, collaboration, and advocacy, and of course, our quality of research too. And today's discussions has highlighted key challenges and potential solutions, and absolutely reinforcing the urgency to drive policy changes for occupational therapy in India. So our take-home message is, so education, strong education is very important, strong advocacy is very important, and the quality of research. In the morning, you pointed out, ma'am said, the quality of research is very essential. And another aspect, ma'am instructed that the quantity of research is essential. And another aspect, our Honorable IOTA President pointed that a number is very essential. So a lot of things are essential. So only the single aspect we can't focus. So I hope our occupational therapist, we will march in best bright futures in India through our IOTA Association, of course, from our WFOT support. Thank you for your valuable presence here, ma'am. And once again, thank you very much, one and all, for joining with us. Thank you very much.
Thank you, dignitaries, and thank you, sir, for a thought-provoking panel discussion. So we can have one of the questions to the dignitaries.
Hello.
One question.
Can I say something? Yeah. I don't have a question. I would like to share an incident here with regards to whatever we have discussed here. I'm Yogita, I'm from Mumbai. I had the privilege of attending a conference in June 2024, which was organized by a physiotherapy community, and WHO faculty was invited for the conference. As Madam mentioned that WFOT is in official collaboration with World Health Organization. So we had Dr. Alexandra Roche, who is a key member of WHO rehabilitation initiative, and Madam was invited as they were working on a key program where they were here to collect information to form a guideline and policy taking perspectives of making packages for intervention to be included and managed from financial perspective. What was interesting about the conference was that it was organized by led by one single physiotherapist, and out of 150 physiotherapists, there were only 3 occupational therapists who attended the conference. Coming to Bajpai sir's number importance, 3 occupational therapists were invited as faculty guests, and I was the only one who went proactively, as sir mentioned. So I do agree with whatever we have discussed here, that we have to be proactive. Rather, I would say we have to be really aggressive, because at the end of the conference, we were given an opportunity to form a part of the team. They will be considering to work in detail at WHO level. Unfortunately, as an occupational therapist, we all missed that opportunity because there were only 3 in number as compared to physiotherapists who were more than 120 in number. Yeah, thank you.
Thank you. If I could just respond quickly. With those package of interventions, I will say very strongly that occupational therapists were involved in the development of all those package of interventions. Every single one of them, occupational therapists were involved. But you're right, numbers are important, and we should share our research within our profession, but we should be sharing our research outside of the profession as well. But for that to happen, it needs to be good quality research. Thank you.
Yeah, if I can introduce myself, I'm Sanjeev Padankati and I head Occupational Therapy at CMC Vellore. To both the panelists who are non-OTs, wonderful. I think you both hit the nail on the head. One talked about the barriers in a medical care setup, and where are we being hidden or are we hiding as occupational therapists? Thank you, Dr. Jagdish. The second thing is to do with what Dr. Suresh said. Don't talk about problems. Look at the positive things. So in that context, since we have a lot of professors from the Medical College of Goa, I need to give you a bird's eye view of what happens in this country. Now, an institution like mine, we started the MOT with a difference. They go through the E1, E2, and E3 workshops. The one which you talked about, ICMR, then they have how to write a manuscript and a manuscript completion. Most of the presentations that you see on are first-timers presenting the project dissertations. So it's not a 3 months or a 6 months program. It's actually a 1.5 year program that they're presenting. But of course, lacunae do exist, and it only makes them better researchers. But even in terms of the topic, I think there's a huge leap between translation research into a policy, at least for occupational therapy. Let me be a matter of fact here. I think we need to translate into clinical research, clinical practice, and that practice would give us a lot more visibility. So the president is there. The presidents have been very proactive. And I think IOTA also needs to restructure itself as a thalamus for all these relays from various sectors. Now, D'Souza is doing fantastic research in geriatrics. IOTA needs to liaise with her and get that on board and then create the visibility. Somebody else might be doing it in hemophilia. It's high time that we don't restrict ourselves. This is to all of us, not just to the president. We don't restrict ourselves to just curriculum development. We should, I think there was a food for thought from both the non-OTs and of course others here, that we need to start looking at other venues of creating the visibility of us as professional expertise. With that, I'll stop. Thank you.
Thank you, delegates. So we will move on to the felicitation.
I'll just add one more statement. You see, most of the children will not understand research, the students in schools and colleges. Why don't you all have a web series or a movie series or a YouTube series where you are showing your success stories? Well, have got so many success stories. Some of your students are very good at making concerts or acts. Have a 1 hour or half an hour movie series and project your success stories. We will all recognize you.
Sir, all the students are already on OTTs only, but except they're not watching healthcare activities.
Thank you, delegates and dignitaries. We can discuss with the dignitaries during the break.
One question, please. Two things were, I'm Dr. Sumit Shinde, I'm a private professional and having multiple centers across these things. It's about two things were discussed over here. One is OT at a policy level, and second is research translating into policy. Two things were discussed over here. What problem is happening is we want to promote OT in government, OT in government. Why we are promoting OT in government? Rather than promoting OT in government, why we are not discussing solution to the disability in the society? We are not providing solution, we are providing solution to the disability, but we are not promoting solution to the disability, and we are not showcasing it in the society or in the government. We are just promoting the word OT. The profession doesn't become bigger. Work becomes bigger. I think this is where few people are. We are not promoting disability and solution to the disability. If we are promoting solution to disability, then Purple Fest, AOTA was supposed to be a part of Purple Fest, showcasing its work at a mass level in the Purple Fest. Just happened 2 days or last week. Second thing, research into a policy. Research gets into implementation. Implementation gets into a change. Change brings money, finances, and then it becomes a policy. We are just doing researches just to promote our resume. 95% and 5% we are, yes, they are solution oriented, but solution oriented goes to NGOs. NGOs gets money. They get, the money is eaten, and then that never becomes policy. Somewhere this needs to be stopped at multiple level. And what is your opinion, all of you? Thank you.
I think, you've got some really valid points. I think we have to, I think part of the issue is not an issue as in a challenge, is the description of what the panel was about today, and we were looking at research and policy, so maybe some of the answers are more focused on that because that's what the panel is about. But what you do raise is a very valid point, is that this is not easy. Policy and all of that is not easy because it is multi-sectorial. So research is one stream of how you may influence policy. But there are lots and lots of different streams of how that influence together. What needs to happen, though, is that you have some avenue of bringing those streams together as a profession. So whether it's conference where you're sharing those practices and building up your networks, conference isn't about coming here for 3 days. Conference is actually about developing the networks that you take away and do further research and further work with. And then you start to build the networks together and pull all of those avenues together. Yeah.
I'm just going to steal this opportunity because I'm from Goa. So I want to speak about Goa. I'm the first private practitioner in Goa. Okay. Hello. Yes. So I do agree to Dr. Samantha Han, who advocated research, because eventually when we stand at a world platform, being the Commonwealth Association Joint Secretary internationally, heading 56 countries, I definitely feel that research is the backbone and the numbers are very, very essential. But I also agree with Dr. Jagdish and Dr. Suresh saying that, when I started my foundation in Goa, I needed to struggle and work with different avenues. Out of the OT context, out of the OT faculty, I worked with Disability Rights Association of Goa, Hemophilia Society. I worked with the State Commissioner of Disability. I worked in the Purple Fest. All those gives you accessibility, understanding different things. I've even mentored with Goa Institute of Management for the MBA students for, making the banks with ATMs being accessible for even with the persons with disability. So I think what they're channelizing and helping us to give a different insights and mindset that we have to go outside the box and meet the right people at the right time to advocate as well. Because
dear ma'am, kindly put your question directly.
I'm not asking for any question. I'm just thankful. Thank you so much.
Okay. Thank you, ma'am.
Thank you, delegates, and thank you, dignitaries. So we will move on to the fellow station. So I would like to request Dr. Professor R.K. Sharma Sir, Dean, Santosh University, Ghaziabad, to felicitate our Honorable President, WFOT, Dr. Samantha Shan, ma'am. Thank you, sir. Thank you, ma'am. I would like to request Dr. Vijay Suple, sir, Senior Occupation Therapist, Canada, to felicitate our Honorable President, All Indian Occupation Therapy Association, Dr. Pankaj Bajpai, sir. Thank you, sir. Thank you, sir. I would like to request Dr. Sujata Michelle, ma'am, Director and Professor, KMCH College of Occupation Therapy, Coimbatore, to felicitate our Dr. Suresh Munuswamy, sir, Dean and Professor of School of Digital Health Sciences, Malla Reddy, Vishwapita, Hyderabad. Thank you, ma'am. Thank you, sir. I would like to request Dr. Sophia Azad, ma'am, Professor, HOD of Occupation Therapy School and Center of GMCH, Nagpur, to felicitate our respected Dr. Jagdish Kadutkar, sir, Professor and HOD, Department of Community Medicine, GMC, Goa. Thank you, ma'am. Thank you, sir. I would like to request Dr. Anurupa Senapati, ma'am, Assistant Professor, HOD, SV Nirtar, Odisha, to felicitate our moderator for the session, Dr. Anbarasu, sir, EC member of IOTA. Thank you, sir. Thank you, ma'am. Thank you, sir.
Hello. All members of ACCOT, please proceed further to meeting room for general body meeting of ACCOT. Thank you.
HOD, Department of Geriatric Medicine, GMC Goa. Sir has gained widespread recognition during COVID-19 pandemic for his unwavering dedication and leadership. He worked continuously for 98 days at the ESI hospital without returning home, a testament to his commitment to patient care. I welcome you, sir. Next, I would like to welcome Chairperson Dr. Sujata Misal Ma'am, Director and Professor, KMCH College of Occupational Therapy, Coimbatore. Ma'am has earned her MSc in OT and PGDR OT from All India Institute of Physical Medicine and Rehabilitation and BOT from National Institute of Rehabilitation Training and Research, Odisha. Ma'am has served as a member of the editorial board for the IJOT, contributing her expertise in pediatrics, hand rehabilitation, and ergonomics. I welcome you, ma'am. Next, I would like to invite Chairperson Dr. Anurupa Senapati, ma'am, Assistant Professor, Head of the Department, SP Nirtar, Odisha. Ma'am has graduated from SP Nirtar with degree in Bachelor's of Occupational Therapy. Currently, ma'am is a co-opted executive member of AIOTA. Her remarkable expertise and dedication in the field of occupational therapy have greatly inspired many. I welcome you, ma'am. Now, I would like to hand over the mic to the chair.
Hello. Good afternoon, everybody. We are starting the session on advancing occupational therapy strategies for optimizing functional and psychological well-being in the elderly. Geriatrics has been my favorite passion subject, and without any more delay, we will introduce the speakers and call the speakers. And you can introduce Vivek. Yeah, I'll call Vivek. Our first speaker will be Dr. Vivek Vajratkar. He is the pillar of our occupational therapy department in Goa Medical College. So without wasting time, Dr. Vivek.
Searching for his, I think his PPTs.
Very hardworking. Donating some 3 or 4 PPs on the for years. Geriatric PPs we are starting next year. He and this other one, both of them. Both of them. They are married to GMC first. So we are doing a
Okay, good afternoon. My topic of presentation in assessing the effectiveness of health promotion model on elderly population in Goa, India. The worldwide aging has become an urgent issue. Researchers predict that the number of people aged more than 65 years in the global population will increase 1 billion by 2030, which means 1:8 of the population will be elderly. To economize on the future government healthcare expenditure, investigation of the population, lifestyle, and the health habits would be reasonable. Furthermore, as the health of the older people is known to determine, effort must be made to promote the active and the healthy aging. Lifestyle choices play an important role in determining the health and vitality of the older adults. The responsibility of the occupational therapist to help the people shape their lifestyles, though those health enhancing occupation. So need of the study is the habitual pattern of the health promoting behaviors such as routine exercises, healthy diet, leisure participation, spiritual growth, interpersonal relationship, stress management, and health responsibility has been recognized as the core of the healthy lifestyle. An ample body of literature in occupational therapy and the other discipline has also identified lifestyle as a modifier factor and has integrated into the framework of successful aging to promote the health and prevent or delay the deteriorating effects of the chronic illness among the older adults. Therefore, occupational therapists working with the older adults in the community settings should evaluate and monitor factors associated with the lifestyle choices as the first line of defense for reducing the risk of chronic diseases or disabling condition in elderly population. Limited or no study have been found to effect of the health promotion model on the elderly population, not only in the Indian context, but even there is short of literature in the Western context. So this was my research question. What is the effectiveness of the health promotion model on the elderly population? Aim of the study to evaluate the effectiveness of the health promotion model in the elderly population and to determine whether the health promotion and the intervention is effective in changing the healthy lifestyles determinants among the elderly population as assessed on the health profile. The hypothesis, we have seen that health promotion model is not effective for a null hypothesis and the alternative hypothesis is effective for the elderly population. So methodology, it was a quasi-experimental study design was used for this study. Study setting, Goa is the advanced stage of the epidemiological and the demographic transition in the country with some of the best healthcare indicators and the rising population of the older people. The 2001 census reported 8.3% of the total population was aged over 60 years. The study was carried out in the Tertiary Healthcare Center Hospital and the Medical College, Goa Medical College. As per the medical records of the GMC suggests that more than 57 older adults, more than 60 years, were registered in the 1 year period when we conducted this study in that year. Recruitment was done through the database, so the above and informed consent, and then there should not be experiencing any unfortunate event during the past month, significant hearing and the visual impairment, no cognitive disorders or any neurological disorders, the patient not suffering from the psychiatric disorder and the participation in the other research studies. With the approval from the ethical committee, the screening for the, and then the confirming the difficulty, the problem with the health profile, then we did the pre and then provide the intervention and then the post assessment.
This is the intervention which is available online, and it has a 7 component: the exercise, diet, social and productive activities, leisure, activities of daily living, stress management of the spiritual participation, and other health promotion and the risk behaviors. And there is a questionnaire also you can use, and the intervention also based on these 7 items. So we have decided intervention 6 sessions fortnightly over a period of 3 months. So primary outcome was a health enhancement lifestyle profile. It can be used, as I said, both for the intervention as well for the assessment. Primary outcome, proportion of the change in the score of the health profile. The analysis to determine whether the health promotion model intervention is effective in changing the healthy lifestyle determines among the elderly population as assessed on the health profile. So result, the data analysis, 31 in each group were analyzed with the 95% power using the paired t-test with the 0.52 sided significance level. So, with these are the results. So what we have seen is that within the group and between the group analysis, it is revealed that the results of the paired t-test indicated that there is a significant medium difference in the pre-test and the post-test health total scores of the experimental group, with the medium effect size as compared to the result of the test. There is a non-significant, very small difference in the pre-test and the post-test. Between the group analysis, it is revealed that the difference is not big enough to be statistically significant. So this is one of the component. We see in the all 7 components separately, but the leisure, because leisure we had not seen any change. So the study investigated whether the health promotion intervention is effective in changing the healthy lifestyle determinants among the elderly population as assessed on the health profile compared with the control, that is a treatment as usual. The healthy lifestyle behaviors are improved after the health intervention of the elderly population. The results of confirms the effectiveness of the health promotion model on elderly population. This signifies that the healthy lifestyle behaviors of the elderly population are improved post health promotion model intervention. Along with the health total scale, the subscale analysis was also conducted for the 7 lifestyle behavior, as I explained. The result also confirms the effectiveness of the health promotion model on the elderly population India to improve the exercise, social diet, social and the productive activities, ADL, instrumental ADL activities, stress management and the spiritual participation. As I said, except the leisure and the health and promotion of the health risk behaviors. The result does not show effectiveness of the health promotion model on the elderly population to improve leisure and the lifestyle behaviors. Mixed evidence exists for the community-based group interventions and the electronic gaming to support the social participation. Multi-center, even the randomized control trial, leisure therapy and the conventional occupational therapy after the stroke supports. There was one evidence we got, current study, by reporting that. Neither of the additional OT treatment showed a clear beneficial effect on the mood, the leisure activity or the independence in ADL measured at 6 or the 12 months. So what is the implication of this study? Okay, the health promotion model increases the physical activity, that individual health action plan improves the ADL function and participation in the physical activities. Occupational therapy practice in promotion of the health and wellness for all population to optimize population in daily occupations. Incorporating cognitive behavioral principles in physical activity improves the long-term participation of the early population in exercise. Assessment and monitoring of the lifestyle behaviors become the essential roles of the occupational therapist practice working with the older adults. The findings have implication for the future research on the role of spirituality and the religious and the lifestyle behaviors, and the further evaluation also by using the HELP 56 items test. Okay, there are few limitations because this is the hospital-based study. And conclusion that health promotion model intervention is effective in changing the healthy lifestyle determinants among the elderly population. Health promotion model intervention is effective for the older population. Is also effective in all 7 except the leisure. The such research in the low resource settings is crucial in order to inform the policies and the guide appropriate monitoring health-related lifestyles, factors, and establishing intervention plan and goals that aim to improve the healthy lifestyle with the aging. Okay, these are my references. Yeah, thank you.
Thank you, Dr. Vivek. I think we'll take questions now for Dr. Vivek because he has to go for a meeting. So I need 2 questions, Dr. Vivek.
Yeah, okay.
Any questions? No questions? Okay, thank you, Dr. Vivek.
Now I call upon Dr. Nidhi Suchendran from Goa to present her paper.
Good afternoon, everyone. The title of my study is Effectiveness of Exergaming on Balance in Geriatric Population. Now, why exergaming? Because exergaming seemed something fun, interesting, and an interactive video games. And I thought that could be incorporated in a lifestyle and the clients can adhere to the games. Now, geriatrics is a branch of medicine focusing on management of health status and treatment of diseases in the older adult population. The World Health Organization defines old age as any individuals above the age of 65 years and older. We know that older individuals typically face physical impairments and an increased risk of falls and an increased risk of experiencing chronic health problems. The common problems faced by geriatric population include sensory changes, hearing loss, decreased visual acuity, decreased vestibular functions, physical functions such as decreased speed of walking, frailty, and increased risk of falls, muscle strength, and fat changes. Common interventions for balance include Tai Chi, yoga, balance exercises, heel-to-toe walking. Now, occupational therapy interventions for balance include fall prevention and lifestyle modifications and exergame interventions for balance. Now, review of literature. So, Helen et al. In 2023 studied the effects of 2 kinds of exergames, step game and balance game, played at 2 difficulty levels on brain activity and physical activity, which concluded that game characteristics affect physical and cognitive activity. Po Young et al. In 2023 studied the effectiveness of exergaming on physical, psychological, and cognitive outcomes among older adults in long-term care facilities, which revealed that exergames improve the balance ability of older adults in long-term care facilities. Now, the need of the study. Exergaming combines physical activities, cognitive abilities, and the interactive game element, enhances the overall enjoyment, and provides immediate feedback to the client. Now, we also know that the commercial exergame setups are costly and the exergaming studies in Indian context are limited. Hence, there is a need to study the impact of novel exergames to promote balance and prevent risk of falls in older adults in Indian context. Aim and objectives. The aim was to study synthesize the effectiveness of exergaming intervention on improving balance in geriatric population. The objective was to compare the pre-test and post-test scores of balance in control and experimental group, and to compare the pre-test and post-test scores of balance between control and experimental groups. Methodology and ethical clearance was obtained, and the research design was experimental pre- and post-study design. 64 participants were recruited from the community and old age homes in Chennai. Non-probability convenience sampling method was done, and the participants were randomly allocated into experimental and control groups. The inclusion criteria, age 65 years and above, both males and females were included, normal and or corrected vision of and hearing, mini mental status examination score 24 and above, exclusion criteria, person diagnosed with neurological and musculoskeletal disease, person who has blindness and deafness was excluded. The screening tool used was mini mental status examination, and the outcome measures were Berg balance scale, timed up go test, fall efficacy scale international. Now the intervention protocol for experimental groups, so namely 2 exergames were devised, Subway Surfers and Fruit Catcher game. The program was given for 4 weeks, 3 times per week. And for control group, conventional occupational therapy exercises were given, such as standing on one leg, heel to toe walking, and strength interventions. Results and discussion. So demographic distribution of variables, age. So age was categorized as below 70 years, 71 to 80 years, and above 80 years. Demographic distribution of variables, gender, so male and females. And BMI. So BMI was again categorized as underweight, normal, overweight, and obesity. Comparison of pre-test and post-test scores of the outcome measures in experimental groups. So a significant difference was found between the pre and post-test scores in the experimental group, and this has been correlated with a previous study which stated that exergame training affects the prefrontal brain activity by positively influencing the executive functions and within the balance group and gait performance to different extents. I'm not able to change this. Comparison of pre-test and post-test scores of the outcome measures in control group. So there was a slight improvement in the scores, in the post-test scores in the control group, and this has been suggested that balance is a whole brain phenomenon, and brain structures in the balance involved are cerebellar, gray matter, superior cerebellar peduncle, basal ganglia, which again help in improving the overall balance. Comparison of pre-test and post-test scores of the outcome measures in experimental group suggested a significant difference. Sorry. So comparison of pre-test scores between control and experimental groups suggested no significant difference. And again, this can be correlated by a previous study which used 4 measures of assessment for balance before training: Berg balance, Fullerton advanced balance, functional reach, and timed up co-test. And there was no significant change for either of the groups. And comparing the post-test scores between control and experimental groups suggested a significant difference. So it has been suggested that a combination of exergames and physical training is a promising strategy to improve balance control and reduce falls in older adults. Limitations of the study: the sample size was confined to a small geographical area, and the study was conducted for 4 weeks due to time constraints. Implications: exergaming interventions can be used as an adjunct to traditional occupational therapy activities to enhance balance, postural control, stability, and reducing fear of fall in older adults. Again, exergame adds the fun and motivating element which increases the overall adherence rate for the therapy. Conclusion, the study concluded that the exergaming intervention was significantly effective in improving balance and perceived risk of falls in geriatric population. These are my references. Thank you.
The next person, Dr. Rujutha from Manipal.
Good afternoon, everyone. The title of my study is Involvement of Family in Fall Prevention for Older Adults in Indian Context, a Narrative Review. Introduction to the research problems. Falls in older adults are among top 10 non-communicable health issues causing death and disability. Globally, the prevalence of falls among older adults is between 28 to 35%, and in India, it is between 2.4 to 54%. The problem. Falls in older adults result from a complex interaction of intrinsic and extrinsic risk factors. While much attention is given to the intrinsic risk factors such as age-related sensory motor, cognitive, and psychological changes, extrinsic risk factors such as socio-cultural environment and context are often overlooked. Social environment, including family support, cultural attitudes, shared belief, and familial practices can influence fall prevention strategies for older adults. So the current scenario of family in Indian context, family is essential to healthcare processes, helping meet daily needs of the older person and also providing older person with emotional, physical, and social support. In India, there is a lack of social security and there's poor insurance coverage for older adults, which increases their dependency on family members. Moreover, the prevalent collectivist culture encourages family members to stay close to their older adults and take responsibility for the health and daily needs. So this shared living arrangement may result in sharing common spaces in the house, attitudes, beliefs, and practices. So the diverse living arrangements, socio-cultural factors, and role of family members as caregivers suggest that family members play an important role in fall prevention for older adults. Hence, this narrative review aims to understand how family members are involved in fall prevention of older adults in the Indian context. Method. The study is a narrative review. So the articles were selected based on the following inclusion and exclusion criteria. Inclusion criteria includes peer-reviewed original research articles, English language, had a reference material to find them, and involved family members as study participants and were related to fall prevention in older adults at risk of falls. Studies consisting of family member caring for only older adults at risk of fall due to underlying neurological, psychiatric, or other disabling health conditions were excluded, and other reviews, case reports, and animal studies were excluded. Search strategy. So the search was conducted in 4 databases. A total of 4,195 articles were identified, and in the review, 18 articles were included. So the findings from the narrative synthesis suggest that out of the 18 studies, most of them are from foreign countries. We could not find any studies from the Indian context, and most of the studies were qualitative in nature, and only 2 were quantitative and 2 were mixed method studies. So the findings are organized under 3 themes. The first theme describes the impact of falls on family members. Second, describes family members' experiences and perception of falls in older adults. And the third theme describes actions of family members to manage falls in older adults. So coming to the first theme, the impact of falls on family members, 3 qualitative studies were identified. So the summary of these qualitative studies suggests that family members experience physical strains such as injury, tiredness, fatigue. They had very poor social life and isolation. They could not go for family vacations or social events. They discontinued paid work. There was also psychological and emotional distress that they experienced and disruption of routines because of added caregiver responsibilities. And under this theme, there were 2 quantitative studies and a mixed method study which spoke about the caregiver burden. So the mixed method study reported that family members perceive caregiving positively and as a normal part of life, whereas the quantitative studies reported that risk of burden is higher in family members who have history of fall-related caregiving with older adults than families without a history of fall-related caregiving, and caregiving burden intensified after the first fall. Theme 2, which describes the family members' experiences, perception, and falls in older adults. So here, basically, 3 things were highlighted. One is the concerns of family members. They spoke about communication problems among the family member and older adult, also the healthcare professional, and also their perception. So family members were concerned about fall-related injuries, hospitalization, feelings of abandonment by healthcare professionals. They experienced communication problems with healthcare professionals. They felt there is a poor information effort by healthcare professional, lack of attention, and poorly trained healthcare professional. Also, they experienced ageist attitudes by healthcare professional towards fall prevention, and it also affected their post-fall decision making. Family members also perceived falls to be unpredictable and unchangeable. They had better understanding of outdoor fall risk factors. Fall risk perception was directly related to their past experiences of management of falls. Coming to the theme 3, which talks about the actions of family members. So family members were mainly involved in home modifications, that is installing handrails, accessible home, making the homes accessible, removing tripping and slipping hazards. They also provided physical assistance, modeling, and the following adaptations. So also the family members' actions were influenced by 2 main aspects. One is the power sharing between the older person and the family, and the next is the communication pattern between the older person and the family member. So the actions based on these 2, either the family members used controlling actions, negotiating, encouraging the older person, coercive or restrictive action, and also mutual respect action. Coming to the discussion, so family members, family dynamics, communication pattern between dyads, awareness regarding falls, and the perceived fall risk of older adults among family can significantly influence fall prevention. The caregiver burden, which is identified in the findings, could be because of the cultural diversity, because most studies were from independent and individualistic culture settings wherein caregiving may cause negative experiences and burden. Whereas in the Indian context, we see that caregiving burden may be less pronounced due to collective culture and filial practices that are deeply ingrained in our setting. This is also supported by a study by Jagnoor, which suggested that family members felt the need of involving family members in fall prevention. Next, coming to the experiences of family member with respect to lack of support and communication by the healthcare professional. The study from the developed countries suggests that healthcare professionals did not see their role in fall prevention. It was low on priority. They felt lack of resources. Family members were disinterested about hearing fall prevention. In addition to this, in the Indian context, the literature suggests that due to fragmented healthcare system, poor insurance coverage, and limited social security for older adults, even this could further impact fall prevention in India. So these organizational and contextual differences in healthcare processes further strengthens the need to involve family in fall prevention for older adults in India. Lastly, coming to the actions and strategies used by family members, the findings suggest that they were mainly involved in home modifications. This could be the high adoption and for home modifications could be because of the cultural diversity, because most of the older people prefer living independently and in nuclear households compared to the Indian culture where family structure, ownership of house, family dynamics, attitude towards home aesthetics, and cultural practices like Vastu can play an important role in the acceptance of fall adoption strategies. implications. So this gap has several implications for family-based fall prevention programs globally, and especially in collective culture like India. There's a limited understanding of how to integrate and involve family in clinical practice effectively. The findings may help to advance future exploratory studies involving family members in fall prevention for older adults in the Indian context, and this could help development of clinically relevant, family-based and contextually relevant fall prevention program, which meets the needs and the abilities of older adults as well as their family members. Conclusion, the review suggests that family members are important in managing and preventing falls in older adults. Considering the collective culture, fall prevention programs in India may need to involve family members, and family-based fall prevention programs may require development of contextually relevant assessment and intervention to fall prevention in older adults. These are my references. Thank you.
Now we call upon Dr. Bala Abhirami from Chennai.
So, good afternoon, everyone. I'm Bala Abhirami, and I'll be presenting my topic, Effectiveness of Occupational Therapy Multisensory Reminiscence Group, OTMRG, in Improving Happiness and its Impact on Psychological Well-Being of Institutionalized Elderly, a quasi-experimental study. So, with the global rise in the elderly population, institutionalization is becoming more and more common, and this institutionalization rates have been influenced by societal changes like urbanization, migration, and so on. So aging in general leads to reduced happiness because of diminished health, social loss, loneliness, and so on, thus leading to poor psychological well-being. And especially in a culturally deep-rooted country like India, institutionalization is still stigmatized, and the emotional distress of such institutionalized elderly becomes worse. So us as occupational therapists, we are very uniquely equipped to address the multifaceted needs of such elderly, institutionalized elderly, but our role always is very underutilized, especially in India. So this study is driven by the lack of research on occupational therapy-led interventions, such as reminiscence therapy, so that highlighting the greater recognition for working with normally aging adults. So the study design was a quasi-experimental study. So when we look at the selection criteria, the participants were both males and females within the age range of 60 to 80 years. They had to be a resident for a minimum of 6 months, and they had to score less than 4 on the Oxford Happiness Questionnaire, which was the screening tool. They had to be confirmed medically fit by the consulting doctor, and they had to be able to read, write, speak, and understand the language Tamil. The participants who had habits of consuming psychoactive substances like betel nut or betel leaf were excluded. So coming to the screening tools, there was one screening tool which was also used as the outcome measure, the Oxford Happiness Questionnaire, and the other outcome measure was RIF scales of psychological well-being. Coming to the study procedure, after the ethics committee approval, a written informed consent was obtained from both the participants as well as a representative from the institution that they were taken from. And initially, 22 participants were screened, from which 12 participants came into the criteria, and from that, 8 participants were chosen with purposive sampling. So following that, pre-test, OTMRG, 8 sessions of our intervention was given, and then post-test, data analysis and interpretation of results. So our OT-MRG intervention is a semi-structured approach to reminiscence group therapy. So it involved vocal reminiscing and performing a particular meaningful activity. And we also included multisensory stimulation along with these activities. Each session had a theme, and the activity for that particular theme along with the sensory elements were designed accordingly to the theme. So these were the themes. Say, for example, we're talking about session 3, the rainy season. So for the rainy season theme, the participants had to be, the activity that was given for the participants was making paper boats and racing them across a pool of water. So, and we had stimulated the room with this, with dim blue lights, and we had added rain sounds in the background, and on the chairs that they sat on, we sprayed water, so they could feel the moment itself, and they could feel the theme. And even we added bergamot essential oil along with an air diffuser to provide the aroma. So coming to the data analysis, the data was analyzed using IBM SPSS software, and a paired t-test was conducted to compare the pre and post-intervention scores. And demographically, the participants were categorized into gender, age, and duration of stay at the institution. So coming to the results, so as you can see here, there was definitely an improvement from the mean of the pre-OT-MRG sessions as well as the post-OT-MRG scores. So same for happiness as well as psychological well-being. So this improvement percentage, or this improvement, was also seen to be statistically significant because the p-values were less than 0.05 for both the outcomes. So coming to the discussion, both happiness and psychological well-being had shown improvements, but despite the overall improvements in both these outcomes, there was no specific patterns that was observed, and this variability could be attributed to various intrinsic as well as extrinsic factors as mentioned here. So coming to the relationship between these two outcomes, we could relate to Bloch Hergensen's perspective, who said that overall well-being can be defined into two categories: hedonic well-being, which is subjective well-being, under which happiness comes, and eudaimonic well-being, under which your psychological well-being comes. So though these two are similar components, they are different dimensions of well-being as a whole. So coming to the SWOT analysis of this particular study, the uniqueness of this study that I found was that it focuses on normally aging institutionalized elderly. And we targeted overall well-being, which is a very rarely assessed or addressed component by occupational therapists. The weaknesses of this study was that there was no control group, so it couldn't be compared, and the generalization was limited. And talking about the implications in scope, we have to expand occupational therapy-led interventions, especially for normally aging adults, especially for in India, in Indian context. And we have to start integrating such interventions into the routine elderly care as well. So I also added a point where we are talking about the challenges to implementation. So adoption barriers, awareness barriers, resource constraints of trained personnel, as well as place and funding, and sustainability issues for long-term engagement. So, conclusion. This quasi-experimental study demonstrated that OT-MRG, Occupational Therapy Multisensory Reminiscence Group, effectively addresses the unique psychological challenges faced by the institutionalized elderly, and that there is a critical need for more occupational therapy interventions in such institutions, focusing on the mental health of normally aging elderly, especially in India. These are my references. Thank you.
Thank you, Dr. Balaram. Now we'll go to the last presenter, Professor Dr. Naresh Babu Karunakaran.
Next one, next please.
Thank you all. My topic is on effects of tailored activity-based occupational therapy program to improve activities of daily living among people with dementia. So as the introduction says, the common difficulties of daily routine for the people with dementia are remembering, having the memory problems with familiar surroundings and routine to the many conflicting sounds. Too many people can confusing the person, may upset the embarrassed by the clumsiness or changing abilities. So they may not be able to finish task over time, such as arranging the items or order. Will they need then during the dressing process or feeding process or in their bathing process, and having a trouble finishing the everyday task, even the multiple tasks. The study aimed to determine the effects of tailored activity-based occupational therapy program in improving the activities of daily living among people with dementia and also the caregiver's psychological well-being, mainly for the caregiver burden. The purpose is to evaluate the severity of dementia, to assess the cognitive impairments among participants, that determine the effects of tailored activity-based occupational therapy program to improve the cognitive function and quality of life among the patients with dementia and also reduce the caregiver burden. As the review of literature by Jing et al., he has actually given for the neuropsychiatric symptoms, mainly for using the TAP program, which is tailored activity program, and he has shown the improvement in while using this particular TAP program. The tailored activity program done by the occupational therapist, mostly related to the physical abilities, creative abilities, and the social abilities. It has to be tailored according to the individual manner, not based on the group way. There are other sample size, which is given in my study, is about taking a 35 control group and 35 experimental group, where we have taken 70 dementia clients from the center called Arichwadi Mental Health in Puducherry, where we had conducted the camp as well as the inpatients. It's a residential setup. This TAP program can able to work in the residential setup as well. So we have taken the people with dementia from mild to moderate group. And we have taken the screening tool with DSRS, which is Dementia Severity Rating Scale, as well as MOCA, which is Montreal Cognitive Assessment. And for the outcome scale, we have taken WHO 5, which is World Health Organization 5 Wellbeing Index, and Barthel Index. The control group also received both conventional occupational therapy, only the conventional occupational therapy, whereas the experimental group has received both conventional occupational therapy as well as the tailored activity-based program. Whereas in conventional group, we might be giving 45 minutes for the sessions, whereas for the experimental group, we'll be giving 25 minutes of occupational therapy and 20 minutes of tailored activity-based program. This is my sessions. Session 1 actually is, we will be trying to give kind of a study report. We'll be giving the explanation about the study and also get the pre-test done during the session 1. And session 2 will be having developing the interest and also the rapport building with the clients and explaining about the TAP program. And session 3 will be having educating on the tailored activity program as well as the fall prevention strategies and energy conservation and joint protection techniques, and also some of the ADL activities included with them. And session 4, there will be demonstration of the therapist with the clients, both for the control group as well as for the experimental group. And in session 5, we'll be having guided errors. Some of the errors can be rectified and still more tailored activities can be done. And session 6, demonstrating the handling sessions with the clients as well as with the caregivers. And session 7 will be conducting the post-test. And session 8 will be feedback and explaining about the home program. You can see the sessions as a procedure or intervention structure. So session 1 we'll be having with 45 minutes each session for the 2 weeks. So we have a total of 8 sessions for 16 weeks, and for 45 minutes for each 2 weeks. This is my demographic data of the results, whereas actually we can able to see the inclusion and exclusion criteria. The age range is more than 65 years old. Both in control group, we have taken both the genders, like male will be 21 and female will be 14 in the control group. And we had experimental group 18 male and 17 female. The outcome performance done with the psychological well-being index of the caregivers and ADL skills of the participants, and both for the experimental group. And interventions we have done for the control group conventional occupational therapy, and for experimental group it is a combination of both convention as well as a tailored activity occupational therapy program. These are my results. We have a little bit of changes while using with the added advantage of tailored activity program. We have shown both in the groups of psychological well-being as well as with the Barthel index. Both the comparisons being done. The discussion actually results were positive effects on the tailored activity program on the people with dementia as well as with the caregivers. The most of the caregivers or the family members as well as the residential people who are actually caregiving for the clients. So they are being educated every day. So further, the fall prevention strategies and joint protection and energy conservation and work simplification techniques and relaxation exercise and memory enhancing activities were helped to facilitate the basic functions of the activities of daily living among participants and the psychological well-being of the caregivers. The conclusion actually given the significant positive effect on the tailored activity occupational therapy program to improve the basic activities of daily living. We have not measured the activities of daily living like instrumental activities of daily living, but there is a significant improvement in the Barthel index and with persons with dementia and facilitate the psychological well-being of caregivers with the WHO5 well-being index. Future recommendations like we can plan to measure the instrumental activities of daily living and studies can be conducted on that for getting the more in the different societies. These are my references. Thank you.
Thank you, Dr. Naresh.
Yes.
Now we invite all the 4 participants to come on the stage for questions. Dr. Nidhi, Dr. Rujuta, Dr. Balabirami, and Dr. Naresh. From the audience, any questions? 2 questions to Dr. Nidhi. Her topic was effectiveness of X-gaming on balance in geriatric population. I think all of you are good at gaming. Both the games you all know, so you can start.
Hello, good presentation. I just have one question, or maybe just a clarification.
Thank you for the question, ma'am. Yes.
Did you have an aspect of your study where you asked them about their experience of participating?
Ma'am, you're asking me that whether I have asked them about the experience
of using those games?
Yes.
Will they want to continue using it?
Yes, ma'am.
Yeah, but then you haven't presented that. And so in such a study like that, it's very important to have their experience of it. Because gaming is something, you know, older people, we don't know about it. So that would have added strength. You telling me that they enjoyed is different story from they telling that they enjoyed. Are you getting it?
Yes, ma'am.
So,
ma'am,
adding a
used
qualitative...
this, I used fall efficacy
No. I'm not talking about the fall efficacy.
So on that, I realized that after using exergaming intervention, that their perception about risk of fall was lowered as compared to the previous, before doing exergaming.
Good, that's good. But what I'm asking is their experience of playing the game.
Yes, ma'am. Yeah.
Because you mentioned that they enjoyed, but you cannot tell that. They have to say that they enjoyed. I'm suggesting a way to improve the quality by adding a qualitative component. It would have helped you a lot.
Yes, ma'am. That should be
Yeah.
the further recommendation
Yeah.
of the study, ma'am.
And second thing is, whenever, this is for many others also, in general, when you are using quasi-experimental studies, you can't use a strong word like effective. You have to use a little bit lower down word, say suggests that it improves. Because effectiveness is usually a word used for RCTs. You know, gold standard RCT is very well blinded. So it's a suggestion for everybody. I'm just telling you this because you can improve your publication chances then. So you need to use words that are relevant or related to your study design. So using a word like suggests potential use or suggests acceptability may be a better word when you are using something like quasi-experimental. But good effort. It's nice because LLE do like such things nowadays. Thank you.
Thank you, ma'am.
Thank you. Any questions from the chairperson? No? Thank you. Thank you, Dr. Nidhi. Now, from the audience, any questions for Dr. Rujuta? Dr. Rujuta can go to the mic. Any questions? Topic was involvement of family in fall prevention for older adults in the Indian context.
Hello. Hi, Rujuta.
Hello,
It was
sir.
a good presentation, by the way.
Thank
I
you.
just want to ask you, like you mentioned that being being a like nuclear family, like it helps to prevent the falls, right? It helps the fall prevention.
Yeah, not fall prevention, but for example, the installation of grab bars or doing any home modifications.
Okay.
Yeah, so those things, that is what the findings of the other study suggested. Getting home modification is relatively easier in nuclear family because there are not too many people involved in decision making of the changes.
So I want to ask you, in your opinion, why the numbers are high, like a percentage of fallers in India compared to industrialized world where like 33% people fall. They are at the risk of fall actually, yeah. Why, in your opinion, why would be number high in India? Why people are falling more in India?
One would definitely be lack of awareness about falls because falls are considered as a normal part of aging. People consider it to be normal and don't take preventive action towards it. It's only after a fall happens and it ends up in a serious, it has serious consequences, then people take action towards it. So one would be the awareness about it, that it's completely preventable and avoidable. And next would be very less screening and evaluation done in the hospital by healthcare professionals, usually done in an inpatient setting where the patient is at high risk of fall. So there's less assessment and screening done for older persons regularly.
Thank you.
Thank you, sir.
So can I add something to what she said? Because this is something that has been troubling me for many, many years, for the last 5 years, ever since COVID struck Goa in 2020. I've realized that even all these students who are sitting behind, our Indian and Goan, especially Goa, I have not researched much in India, our protein content in our food is hardly 20 grams per day. Any students here? There are so many students here from occupational therapy. Nobody? They hardly have 20 grams of protein per day. And even their parents, they are all carbohydrate based. We have a rich carbohydrate, rich oil, low protein diet. So we are all insulin resistant. We are all pre-diabetic. So we become sarcopenic very early. We become osteopenic very early. And now we become couch potatoes after 2021. And that is why we fall. In 90% of my patients who come to geriatric OPD, my PG students have already started recommending protein supplements. And we're giving them one proteinase or Protein-Medic, whatever the government gives us free of cost. Mind you, Goa Medical College gives every medicine free of cost. So they get one proteinase sachet equal to 20 grams per day, every day. And it is beneficial.
Oh, that's very scientific reason
So
actually.
I think we should go on to elderly nutrition at the age of 60 years, not when they become 80. Because when they become 80, they are muscle wasted. Then the muscle doesn't build up. The people in Canada, because my wife's sister's daughter is a nurse there, you'll get egg white in the market, which you can buy and eat. In Goa, it's not available.
And it's a multidisciplinary approach, actually. We have a geriatric assessment team. I just wanted to add to that, actually. Geriatric assessment team, there would be a geriatrician like you, an OT, PT, nutritionist, dietitian on the team, and they really work together and yeah, so see the best result, actually. Thank you, sir.
Any more questions to Dr. Rujuta? So we are not going to live in the aged homes. We are going to live with our families now when we grow old. And there's another question. Come.
Yeah. Well, I am Dr. Vishal Jain. I am a director neurosurgeon called from Delhi to just see the conference here. I am here for the first time and I am seeing the excellent presentation. Congrats to the Aorta Association. The thing I want to ask is, you have told about the frequent falls. Before going into the proteins and all, I think we should evaluate the patient fully. We have seen patient in Parkinson's, we have seen patient in Alzheimer, we have seen patient of dementia, normal pressure hydrocephalus, lesion in cerebellum, cervical myelopathies. These are all the patients who had frequent falls as the first complaints. Either they have ataxias and all. So before going into anything, evaluation for all these causes should be ruled out before going into occupational therapy. And as I am saying, frankly speaking, when I was doing my MCS from Sri Chitra, Trivandrum, I was not aware of occupational therapy. But slowly, when I start practicing in Women's from last 20 years, I came to know about Advanced Neuro Rehabilitation Center in Women's, New Delhi. And from there, I came across my wife sitting here as an occupational therapist. Shivani is sitting here. They are all students of Dr. R.K. Sharma. And from there, I came across this occupational therapy. Previously, I used to refer all my cases of strokes, head trauma, brain tumor surgeries to PT, because I was not knowing this. But seeing the result of this occupational therapy, I have converted myself and my team to OT. And now in Delhi,
thank you, sir.
And now in Delhi, the awareness is so much that the patients are shifted to OT from PT, and PT are lying here and there, but OTs are performing very well. This is our experience in Delhi, and thanks to all. My message is, please, awareness is the most key, and keep on doing good work. Thank you very much.
Thank you, sir. Thank you so much. Thank you, Rujuta. We go now to Dr. Balabirami. I thought of the novel I read, Being Mortal. It's a nice novel about old people and how they go in homes. And yeah, I said, no, we require legislation by which an occupational therapist is in charge of every home for the aged. You were very excited to do your project. You wanted to explain each and every work you did everywhere. And I'll play with both from tomorrow. Okay. And the paper is open for questions.
I think that was a well-presented paper, but just have a question. You were saying that they were institutionalized, right? So how many institutions did you take?
I just chose one institution, ma'am.
Okay.
Yes.
And I mean, if I can look back, was it an experimental study or a quasi-experimental?
Quasi-experimental. It was a single group quasi-experimental study.
Okay, one group and then you took
Yes.
up an institution. Because I really like the way you put the SWOT analysis there. I'd like to really appreciate that.
Thank you,
I think the first time in our OT conference we are seeing somebody putting it in the form of a SWOT analysis at the end of the things. Kudos to you. That is very good. Because hadn't she put that, one of my questions was that actually, but she's already mentioned as one of the, the strength was this, the weakness was that. That's actually my question. So well presented, take it forward. Little bit refinement is required. Probably we could discuss over a cup of tea or something. Yes, refinement.
Thank you so much.
No more questions. We'll move to Professor Doc. There is one more. Yeah.
Was any sample size estimation done?
No, ma'am.
Okay, fine. Thank you.
Thank you. Thank you, sir.
Okay, we move to Professor Dr. Naresh.
I'm here
Thank you,
again.
ma'am.
So I just wanted to ask Dr. Naresh, because tailored activity program has been there in occupational therapy, right, since inception of OT per se.
Yes, ma'am.
Could you just highlight about the novelty in your research?
Ma'am, in this research, actually tailored activity program in US is little different. We are adding as like little interest, taking a different interest in the residential setup itself. We had an opportunity being with our HOD, so Mr. Ilavalagan sir, so he has given the permissions in this residential setup. So where we can able to get those clients and with their consents, even with their caregivers' consents, and also his own workers who are also having a caregivers. So this actually taking the interest from their group itself, and we can able to plan. I actually planned based on their individual interest, and then selected the activities for them. Like some people might be having a musical, and some people wants to have a writing or a painting or having a poems, reading some poems for short stories to bring up their memories. So this is what actually in that novelty of selecting those individuals.
Okay. It was there because yours was a pre-post control and experimental
yes,
group.
ma'am.
But
It's a quasi-inter.
Yeah, I couldn't find any blinding or anything over there, like because it was, I don't know whether I missed out and.
No, no, ma'am. It's actually like taking a group like from the beginning, and those who had a camps, like we had a camps. So in that residential setups itself, we have selected the groups. So there is no blinded way in that state.
Because the purpose and the final conclusion that didn't match actually with
Okay.
purpose was severity of dementia, because you would have selected them based on that, right?
Yes.
So
ma'am.
yeah.
Yeah.
I had just a query clarification again. You said, did you mention the severity of dementia? Because when I thought I missed it.
No, the first initial, initially to take that dementia severity scale, because to identify the mild to moderate people, as you have, I attended your programs as well. So I try to, I'm not actually going to purpose of that study.
No, that's all right.
Just to collect the people.
Yeah. I just want to know, have you analyzed them separately as mild and moderate?
No, ma'am. There is a psychiatrist available
No.
over there. Yeah.
Have you analyzed it?
Yes.
Your analysis,
Yes, ma'am.
is it talking about how
Yeah.
moderate people performed and how mild?
Yeah, mild people.
Have you done that subgroup analysis?
Yes, ma'am. I have done that and then selected that. But we have actually based on the interest of the caregivers.
No. I'm talking about post. In your result analysis,
No, ma'am.
Have you done subgroup analysis based
no.
on the severity of
No.
dementia?
No.
And
It
one more
might be
question.
the limitations.
Yeah. One more just question out of curiosity. What challenges you faced when doing this with dementia patients? And because they respond best to family members.
Yes, ma'am.
But when it's coming to an
To
old age home,
it's very adamant, and sometimes they have a denial and they doesn't want to take part in the sessions. Then we have to bring them with a lot of rewards or sometimes motivation towards to them, and being with them around for a long time, and then selective that particular group. So it took a lot of challenges within the residential setup itself, but a lot of care and support given by the workers over there itself. Because I used to go every time when I visit the center, so they were used to me and they know what I'm expecting from them.
Okay.
So that's the major challenges I faced there.
yeah. So that would be nice if you could have identified those.
Yes, sure.
Thank you.
Thank you very much.
I have one question.
Yes, sir.
You can use mocha,
Yes, sir.
right? So, how do you think mocha is ideal for?
No, sir, but I know that I came to know that MMC is
Yes,
become,
MMC is
patent.
required.
So I can't able to
Cognitively.
avail it. So that's why I used the mocha, because it was easier and it's visually representing, and I can get the details done with the caregiver's help. So that's why I used the mocha.
Yeah,
Yes.
what's your experiences while handling mocha rather than MMC?
MMC, we can able to do it within some 5 to 10 minutes, but mocha takes time.
So,
Yeah, that's the challenge.
then I'm asking again, what's your challenges in it?
This is the major challenge, because I have to explain about the mocha instructions, and I have to maintain even with the caregivers to explain that they should not give any cue to them. So that was the major challenge I have to face with them.
Okay.
Thank you.
Okay, no more questions. Thank you, participants. You all have done a good job. All the best. Please publish your papers.
We have come to the end of the session. I would like to thank all the respected chairpersons and delegates for embracing the session titled on Advancing Occupational Therapy Strategies for Optimizing Functional and Psychological Well-being in the Elderly. It's time to felicitate our esteemed chairpersons. I would like to welcome Dr. Samantha Shan ma'am to felicitate Dr. Edwin sir with a certificate and memento. Now, I would like to welcome Dr. Vijay Suple sir to felicitate Dr. Sujata Misal ma'am with a certificate and memento. I would like to welcome Dr. Sebastina D'Souza ma'am to felicitate Dr. Anurupa Senapati ma'am with a certificate and memento. Once again, I thank all the esteemed chairpersons and participants for embracing the event. Thank you.
Good evening, delegates. I am privileged to invite respected Dr. Suresh Munuswamy Sir, Dean and Professor, School of Digital Health Sciences and Technology, Mallareddy Vishwavidapida, Hyderabad. Sir is a medical doctor, scientist and a startup entrepreneur. Sir was the first Indian to be selected for the Public Health Leadership Doctorate Program, fully sponsored by the Government of Japan. Previously, he was the Dean of Digital Health at IIHMR, University, Jaipur, the Deputy Director and Additional Professor at Public Health Foundation of India, Director at HI Rapid Lab, PHFIS, first faculty-led startup company, and a coordinator for the India's first integrated MSc and PhD health informative programs at IIPH, Hyderabad. Sir has 6 years of clinical experience, 7 years of public health experience, and over 11 years of experience in the design, development, and comprehensive software and hardware and mobility platform for delivering universal primary healthcare screening and treatment at home. The platform developed by Sir is named as Comprehensive, integrated several designs and technological approaches, including graphic icons and AR for UI, wide spectrum images for automated features identification, artificial intelligence, and language models for decision making, custom configuration growth. Without further ado, I would like to hand over the stage to our esteemed speaker, Dr. Suresh Munuswamy Sir, to deliver his talk on the title, Live Longer, Work Better, Real-Time Research Practice with AI and Industrial Revolution. Welcome, sir.
Well, good afternoon and thank you for the introduction. I'll perhaps start with a question. Please raise your hand if you say yes. How many of you would want to live longer? Well, that seems to be a very small number. We will get to there a bit later, one step at a time. So if you haven't raised your hand, perhaps post-lunch dizziness, or maybe you should consult a psychologist. Either one of them is definitely the reason. So maybe I'll just ask the question again. How many of you would want to live longer? Wow, a few more hands. So this is the fastest way to cure depression. Okay. So there are a lot of challenges, not only in occupational therapy, but literally everywhere in healthcare. And broadly speaking, you can summarize them into the so-called, I think, 5 A's and 6 L's. A lot of people have already mentioned it, and I've also said, let's not talk about challenges, but let's talk about solutions. But I'll just quickly go through them and then set the context. I'm not only going to talk about the challenges, but I'll also perhaps come out with a solution, which I'll again ask a question and say, did I address it or not? And maybe, hopefully, some of you will raise the hand. Awareness is always a challenge. Not just being aware of occupational therapy, but the patients themselves being aware that they are actually sick and wanting to go to any kind of a practitioner is always a challenge. Whenever a patient actually walks into any clinic, he or she is already 70% or 80% sick, and that's when they actually walk into your clinic. The challenge here is always how do you ensure or how do you perhaps make them not getting sick, which broadly we don't actually address at all. But remember that when you are actually seeing a patient, he or she is already sick. The second part is accessibility. Again, healthcare is a complicated service. Any district or any state capital, you see that a lot of hospitals are there in 2 or 3 streets. 5 kilometers away, you won't see anything around. And 50 kilometers away, you won't actually see any healthcare person at all. So accessibility is always a challenge. Even today in our country, there are lots and lots of locations where you have to travel at least half a day, some places even 2-3 days to even access basic healthcare facilities. Third one is the absence of skilled personnel. Again, sometimes it's a problem of plenty, sometimes in most cases, it is actually the problem of lack of services, lack of skilled people. Affordability is also an issue. It always costs money, whether you go to a government hospital where the government pays or you go to a private hospital where you have to pay out of your pocket or insurance. Healthcare is expensive. And lastly, accountability is a serious challenge. As much we blame the patients for coming late, they blame the doctors, they blame the healthcare practitioners and say, I'm not getting good care. I'm perhaps like getting not substandard care or something. So there are a lot of challenges. And for a lot of these issues, the answer today is let's go digital. Whether you look at banking, ticketing, or perhaps ordering food, entertainment, it's all broadly gone to a digital platform, which looks great, but India is the only country in the world with 22 official languages. So whatever you think actually works, usually works only for the English-speaking population, or mostly works for the English-speaking population. A lot of this AI does not work in Hindi. A lot of your, in fact, like even something as basic as facial recognition works only for a small subset of the population. Language is a challenge. The second challenge is digital literacy itself. In our country, we still suffer from regular literacy. Today, or maybe even perhaps like now, you go to any ATM, stand there, there is somebody always coming and giving you their card and say, please log in and then let me take my money. They are just trusting you with their card because they don't even know how to enter those numbers. Well, thankfully, we came out with a solution also, QR codes. And there also you see that a lot of the shopkeepers, when you actually pay them money, they can't read the numbers on their screen. So there is a particularly Indian innovation which is this 1,000 rupee, 2,000 rupee box which actually tells you how much money has been paid. So these are still challenges. Language is a challenge. literacy is still a challenge. Regular literacy is a challenge, and then we add up digital literacy to it, making it even more complicated. Although India is a populated country, it's not populated evenly. So when we start talking about rules, regulations, policies, government does not frame policies for a small group of people, say a policy for a small town or a city. Policies are usually for a country or for an entire state. It becomes extremely challenging to implement policies because maybe Goa is a populated state, Delhi 16,000, 17,000 people per square kilometer, Arunachal Pradesh 16 people per square kilometer. So if I make a policy for the country, it should be implementable not only in Delhi but also in Arunachal Pradesh. So if you go out of cities, you will see that suddenly population actually drops. You say that there should be one PHC per 10,000 people or maybe even 50,000 people, but that 10,000 people could be living in 100 square kilometer, which makes it actually meaningless. So low density is also a challenge. And then we keep talking about healthcare. Healthcare is not one single service. It's almost like 1,000 microservices. There's no one single hospital, one single digital platform which can actually offer all this. But for a patient, he really does not care if I have to go to a cardiologist or perhaps a neurologist or maybe an occupational therapist. For the patient, all he cares for is like, I want to get better and I want to get on with my daily life. That's basically the statement that he actually makes. Diseases, again, does not prevent or present very specifically and say, this is the vertical that I need to be diagnosed and treated. Diseases are always like so-called multifactorial. And even when they actually exhibit themselves, you require a bunch of people to coordinate and then work together. And it is usually left to the patient themselves to understand which specialist should I even go for. Considering that our patients are fairly not very literate, they are in pain, they are sick, it's not something that you can actually expect them to perhaps like identify and then look out and take care of themselves. Also, we keep talking about data. Not necessarily we collect good data. I mean, personally, I think a lot of data in this country, a lot of you have presented the research. A lot of it is very low quality, poor data. And I'll give you 3 reasons on how to make the data better. Number 1 is all your data should have metadata, meaning data should be location stamped, date and time stamped. Otherwise, there is simply no point of validating or verifying the data. So you say that these are the numbers, but if I have to validate and verify, I have to still go back and then do the same thing again. It really does not make actually any sense at all. But if I upload any image on Facebook, I can actually get the geolocation on where it has been uploaded, what time it has been taken, what date it has been done. So even something very flimsy data on Facebook suddenly becomes valuable because it's actually data with metadata. The second characteristic of a data that makes it valuable is it longitudinal? If I'm collecting data about the same person repeatedly, it becomes valuable. If I collect data only once in your lifetime, it really does not make much sense. The third characteristic is triangulation. Multiple data sources coming from about the same idea makes it a lot more valuable. In most cases, our research does not have all these characteristics, which makes it good for publication, but not necessarily good to deliver a service out of it. You look at perhaps any service, you take a Uber or a Ola. Number 1, your trip, who is booking, your payment, everything can be traced back, which is why you are getting all these ads, because they trace back and identify your history, your lifestyle, and then keep sending you relevant to them, but maybe not relevant to you advertisements. That is good data. The data that we collect, even we can't actually find the people. If you have to find the people, you'll have to spend as much time. So these are some of the challenges with the data that we actually collect. And the last one that nobody likes research is because it only helps us. It does not help our patient. Even they know that, or perhaps they will tell you, you collect all the data, go away, and what do I get out of it? And you tell that somewhere I'm going to change the policy, and everybody knows that even if there is a policy in our country, nothing is going to happen to them. So this is called as the so-called Uber problem. How many of you like to share the location that you are? 2, 3 people. For the rest of you, if you don't share the location, Uber won't come to you. So like it or not, you all share the location simply because you are getting a ready service. If I am not getting a Uber, or if I am not getting whatever I want delivered on Amazon, Myntra, or whatever it is, I don't have to share the location. In fact, 10 years, 20 years before, we didn't want to share our location or advertise it. But now, if you are living in a major city, for a week, at least 20 strangers would be visiting your home and then delivering whatever it is. We don't think it is a security issue because 10-minute delivery. We can't hesitate, we can't kind of skip the hesitation here. So on one side, we keep complaining. On the other side, we are actually contributing to a lot of challenges. But bottom line here is, we don't bring that kind of a service into healthcare. Is there anything that anybody can actually get and say, in 10 minutes, I'm going to become better? No, I don't think anything like that. So when you are able to bring in real-time services, when you are actually trying to cut down the gap between data collection and service, your service becomes more valuable. When you do it repeatedly, your service becomes even more valuable. When you do it granularly for each and every small needs, again, you are increasing the value of the service. And that's why a lot of these companies are valued not just in billions, but actually tens of billions or hundreds of billions of dollars, because they are doing it repeatedly. Small things make a lot of difference. So we need to start thinking how to bring all these things into healthcare. And there is also another challenge associated with it, which is the life expectancy. In 1950, which is like only 70, 75 years before, the average life expectancy of an Indian was, I think, 35 years. Now it is 70 years about. So in 70 years, our life expectancy has actually doubled. And in another 30, 35 years, by the time it becomes 2050, the average life expectancy is supposed to go up to 100 or 120 years. The problem with that is, if you see the top bar, it's the working life expectancy that is going to increase. Your 0 to 5 is still going to be the same. Your adolescence is still going to be the same. What is going to actually expand is your adulthood, your working life age, which possibly it is between 25 to maybe 55, 65, 75, depending. And it's going to go to 95, 105. Now we are talking about a huge expansion in an opportunity for occupational therapists. But the challenge is we don't know how to even kind of acknowledge it, or perhaps make sense out of it, or create an opportunity out of it. So these are some of the things that we actually need to start thinking. And again, when we start thinking, we always seem to be thinking in a very reactive way. We expect people to come to us, as I mentioned, after they are already 70%, 80% sick, when they really cannot actually attend to their day-to-day activities, or in a technical term, cannot do their activities of daily living. They are so sick that they can't go to their workplace. They are so sick that they can't even get out of their beds. And that is when they actually come to us. But the challenge is basically not allowing them to get there. We need to start thinking proactively and say, like let's say a disease like maybe hypertension, diabetes. It takes 15 years to develop. No hypertension or diabetes develops in 1 or 2 years. First 5 years, you can't even identify it. Last 5 years, consistently, something will actually show up. But patient thinks like, last 1 year I ate something, so I became hypertension. That's not usually the case. Whether it is joint pain, whether it is a muscle sprain, whether it is even a fall, nothing actually happens in 1 or 2 years. It usually takes 10 years, 20 years, 30 years to get to that position where you are actually suffering from these conditions. And in most cases, our focus is after things have happened, not before. So these are some of the challenges that we face. As I mentioned, I'll also talk about solutions. Now, it's up to you to figure out how to apply it in your situations. So this is one slide that explains the work that we have been doing in the last maybe about 10 or 15 years. Again, the same thing, which is basic idea is when a patient is walking into a clinic, he is sick. So what we thought was, why don't we go to a person's home? Because that's where he or she spends 50% of his life. And why don't we screen him regularly? Now the problem with this approach is, if I go to each and every one of your house and look at your family, there are going to be at least 5 people. That's the average number of people in India, or average number of people in a house. And if I take around 2 to 3 hours to screen each and every person, I'm going to sit in the house for like a whole day, which I don't want to, and I'm sure you also don't like. So there are 2 challenges. One is time, the second is money. So when we started, a lot of you, when you are studying in the 2nd or 3rd year, would usually be told, first examine a patient thoroughly, don't bother about the diagnosis, because when you examine a patient thoroughly, you will at least get to know most of whatever he or she is suffering from. Treatment is basically an afterthought. In fact, there are about 36,000 diseases. When you actually count the number of medicines that you actually have, there are less than 300 of them. So almost like 1:100 ratio you have. If I have to do a head-to-toe general examination, it would take me around 2 to 3 hours. That's what a medical student learns in the 2nd or 3rd year. So what we are trying to do, and I don't need to do such a thorough examination also if I'm doing things repeatedly. So we built an existing questionnaire, and again, bringing in the challenges. India is a country with 22 official languages. So whatever I do, I have to translate into 22 languages. So we identified this existing validated questionnaires. There are lots and lots of tools actually, and I'm sure I don't have to tell. All of you would know that there are lots of tools. People are creating even more tools. We looked at the keywords, and all of them are questions. Identified the keywords, converted them into icons. And we also used a bit of theory to standardize the icons. I'm sure everybody knows about traffic signs. Traffic signs are universal. Throughout the world, more or less, they are the same. Standardized background, very little information that's conveyed, very bold, in your face. Colors are standardized. Size is also standardized. So we took all these principles, applied it to healthcare signs and symptoms, and we created about a couple of thousands of signs and symptoms. All diseases are signs and symptoms. So if I say like tuberculosis is not tuberculosis, it's actually evening rise in temperature, cough for more than 3 weeks, and next comes if I take sputum and then test it. But otherwise, I still have to treat for fever and cough. Okay, that's essentially the treatment for tuberculosis, along with antibiotics. So if I say gastroenteritis, it's again fever, it's perhaps like diarrhea, or maybe cramps. So these are signs and symptoms. All diseases are signs and symptoms, and we have what we call as icons for signs and symptoms. Again, when you are taught in your schools, you are also told that there are only 3 ways you can identify your signs and symptoms. Look, listen, and feel. There is no other way. Okay? You have to look, identify a symptom, or you have to ask a question and then listen to the response, put your finger, and then feel whatever it is. There are only 3 ways you can identify a symptom. And look constitutes 70% of your signs and symptom identification. So we skip the second 2 parts, which is the listen and the feel. We'll come to that a bit later. So we identified these icons, put them as a software algorithm on a phone, and then asked our healthcare workers to go around and then start screening for diseases. Now there are 2 advantages to it. One is language broadly has been addressed. So when I say broadly, all it means like addressing things 70%. Don't take it to the other extreme, which is 90%, 95%. Yes, I know it's not 95%, 99%. 70% is a good start. So we asked our healthcare workers to go on screen, and they, as usual, sat at homes and then filled all the questionnaires. We also realized that smartphone actually has a camera, so we opened up the camera. And as I just mentioned, 70% of signs and symptoms can be screened using imaging or by looking. So we asked them to take photos. Photos got us GPS coordinates, date and timestamp, so our data quality actually improved. And then now we are sitting on about 20-30 million images of 20-30 different parts of the body where we are actually repeatedly screening. And we are personally triaging the information. We are yet to build the AI models. It takes time. So we have trained our healthcare workers. Again, there are lots of ifs, buts, challenges. They are actually identifying what is normal, what is not normal, and then grading what is not normal, which is how we see a disease, not necessarily identify a disease, but look at the signs and symptoms. And we have linked them to interventions, which are all reasonably validated. And all these interventions also, we have converted them into small 30-second, 45-second animations, which does not have language in it. It just tells what are the products that are required and what are the process that you should actually do. Broadly, it works. I'm not saying it works 90%, 95%, but the idea is now with images, we have reduced the time from 2 to 3 hours to about 15 to 20 minutes. So we just screen everything, take a photos, and then identify what is normal, not normal, and then the software automatically populates what are the interventions that need to be told. Interventions are of 3 types. Early stage of disease, you tell people what to do and what not to do. Next stage of disease, maybe you give them over-the-counter medications. Fever, paracetamol does not require a doctor's prescription. You can still give it away. Even basic antibiotics, you can give it away. In our country, you can give it away everything, but on a digital platform, things need to be documented. So we are only giving away things that are classified as over-the-counter medications. The next step is all these medications cannot actually come through a software. So this is where we need to start thinking about a product platform also. India is a very big country, as I mentioned, very populated country. And if I have to go to each and every person in their homes, so this is where we started adding the universal healthcare. Government had this idea of universal healthcare. A lot of people see universal healthcare in different ways. Some people say if I put up facilities, it's the responsibility of people to come, and that's called as universal care. So if that's the description, we are already providing universal care because there are 35,000 PHCs. Nobody is coming to them, that's a different story. The other approach to universal care is like the government announces insurance schemes, which means, again, it's your responsibility to find out where these insurance schemes are even honored, who is actually providing you with care with that kind of money. So government says there are 2 types of universal health care. We don't believe. Our idea of universal health care is if I can go to each and every person's home and then screen them reasonably and provide them with the necessary management, treatment, medications, you can call it whatever you would want. So that's where in 2014 or 15 we said that without drones, universal health care or access is not possible in our country. And government being government banned drones and also sent me a notice on how you can even fly drones. We are the first guys in the country to fly drones. And this is for all the people who want government's response to policy. You should be happy if they don't send police and arrest you when you are suggesting something new, especially in our country. Well, there was a long ban on drones, and then COVID came, and government actually felt that we need to start looking at drones because our very friendly neighbor has gone way beyond a lot of countries, perhaps every other country on this planet, and government actually used healthcare as an excuse to get back into the drones. So we worked with Niti Aayog and also World Economic Forum, and then came out with this list of guidelines on how you should build a healthcare drone so that we can actually reach out to each and every person anywhere in the country. So we suggested that the drone should take off vertically and land, which has been accepted. You will find drones that are taking off and landing vertically. There is also another form of drones which will just fly around, drop, and then go. We said completely no to that kind of service because we think that is inhuman. Still being used in Africa, in India, we said no. The second characteristic of a drone is it should lift at least 30 kgs or 50 kgs. Government couldn't wait that long because our government, most governments these days are camera friendly. They want something today or perhaps even yesterday. So they just pushed and flew drones that can lift 2 kgs, which really is not doing much of a difference. Another 2 or 3 years, you will actually get larger drones. You will also get drones that can lift 4 or 5 people. I think they are coming in the next 1 or 2 years. It will change the face of ambulances also. We are working on rules where you can actually have ambulance access in the next 30 minutes or something. Again, cost, we'll keep that away. That's a discussion for some other day. So broadly speaking, even the access would potentially be solved. So if you combine everything together, at least at a very high level, we are broadly addressing all these issues that we mentioned. You don't have to bother about awareness because we are proactively going to the patients or people, hopefully every year, and if you are not well, maybe a little bit more frequent. You don't have to bother about accessibility because we are trying to empower rural people in and around, and then maybe identify one person per 5,000 people, and then which is already there with ASHA workers and A&Ms. Empower them with artificial intelligence and start screening them. Absence of skilled personnel, again, a person with artificial intelligence may be good enough for primary care. I'm not talking about secondary care or specialized tertiary care. That is still left to the personnel or professionals. I'm talking about primary care, preventive care. Affordability is a cost of not the top number, but the bottom number. If it costs like, let's say, $10 million or 10 million rupees, if it is targeted at one person, then it is very expensive. If it is targeted at 10,000 people, then suddenly the same thing becomes cheap. So we are here looking at universal healthcare, meaning healthcare for 1.4 billion people, which means even if my healthcare costs 10 times more than present healthcare, the fact that it could potentially be available to all 1.4 billion people means it's going to be the cheapest healthcare that anybody can actually perhaps come out with. And finally, accountability. And as I mentioned, anything delivered on a digital platform automatically gets recorded. You are being monitored. Every step of the service gets monitored. And slowly you will be developing algorithms which can tell you, as I mentioned, how long to stand, how long to sit, when to deliver this, are you actually delivering things rightly. So these are things that can potentially be addressed. Language diversity is again being addressed with icons. Now generative AI can actually speak in local language. In English, it is doing a really good job. Local Indian languages, perhaps maybe 3 years, 5 years down the line, a lot of these interventions can actually be spoken to you. Low density locations, still a bit of a challenge. So I'll not go into all these things, but broadly, these are some of the solutions that we are actually working on. We are also trying to add more imaging, not just images, but videos, which can help you to manage or identify gait, identify movements. We are also trying to add spectral imaging, which can actually look at 2-3 millimeters under the skin, which will get you perfusion status. Maybe one single photo can actually tell you what's your mood, not just smiling, not just angry, but also how much perfusion or blood supply is there in the face, which will actually give you much better data points. But the advantage of all these things, excuse me, maybe I missed. The advantage of all these things is the way healthcare is actually changing. Presently, we are looking at episodical service, meaning if a patient is sick, he or she comes to us, we provide the service, he goes back. What we need to do is look at healthcare as a continuous and a dynamic service. We need to be proactively engaging with the person on a regular basis. Presently, healthcare is delivered at a facility. We are planning to shift it to home, but as an occupational therapist, you need to start shifting healthcare to the workplaces. That's essentially the space where you are not going to compete with a physiotherapist or literally any other therapist actually. Healthcare is broadly seen as a single disease. We are not only looking at multiple diseases, we are also imaging the person's home where he or she is living. We are also imaging a locality of the person with a couple of 100 images so that we get the entire ecosystem. We are now creating a digital twin also of the person, the house, and the ecosystem. Again, a little bit of challenges. So these are some of the ways healthcare is actually changing. And you need to start bringing all those things to the occupational areas. And as I mentioned, in this box, you see that occupation or workplace is where a person spends a significant amount of her time. Nobody is competing with you there. So this is the space where you need to start going and then start looking and proactively start telling people, coming out with guidelines, coming out with monetary tools, coming out with IoT devices, and then start looking at them so that they can actually live a longer life. We are also getting into humanoids. This is a render of a lab that we are building in my workplace. So exoskeletons, humanoids, thanks to our very friendly neighbor who has actually gone very far. We are also trying to play a catch-up game here. The rest of the world is trying to play a catch-up game. And artificial intelligence is not a pipe dream anymore. It's there. Reasonably, it is doing a good job. In fact, the last slide, this is one of our outputs where generative AI very clearly tells how the progress of a disease condition will be there with treatment, without treatment. And this actually matches up very well with our own physical data that we have where we are following up with the patient. In fact, it's matching up to almost like 2%, which if I look at it the other way, if I have to come out with a similar graphic or an analysis with a statistician, it would have taken me at least 2 years. 1.5 years breaking my head to even explain to him what I actually want. And another 6 months, he disappearing. And last 1 week, he actually doing something and giving me this. This is happening with the touch of a button. All you need to do is come out with the right prompts, hit a button, and it is giving you with such reasonable clarity. Of course, there are hallucinations, there are challenges with generative AI, but if you ask a very straightforward question, it is actually giving a straightforward reply. So the future of healthcare needs to be comprehensive. It also needs to be continuous. It needs to be customized, and all these things are possible. It also needs to be convergent, contextual. Again, it looks really funny, but all these things are possible. Artificial intelligence, and on the other side, intelligent agents or devices are already there. We just need to start thinking about in our context and hopefully start integrating them. Well, thanks a lot. And if you have any questions, I'll be more than happy to answer.
Thank you, sir. The forum is open for question. Kindly ask one question. After that, you can ask your doubts to the delegate during the break time. Any one question, please.
Only one.
Thank you. Thank you, sir. I'm Dr. Sumit Shinde, and I'm a clinical person. So I have 14 centers and running more than 800 data under me. So you really solved my problem because of creating an interface for when a patient comes to us, and to keep its consultation with us, it takes 4 to 5 days or sometimes a week. So you solved my problem of how early, how fast we can convert that inquiry into a consultation and then start with the treatment. In today's world, the Amazon is the fastest delivery. First of all, I mean, long time they were saying, but now Zepto is coming. So the fastest things are coming, and how medical softwares are there so that occupational therapy or medical fraternity can fast convert the inquiries into a treatment model.
Well, thank you very much, sir. Next time I will put my QR code so that you can pay my consultancy fee. Yeah. Thank you.
Sure, thank you.
Thank you, sir. I would like to extend our gratitude for your insightful session, sir, on the topic Live Longer, Work Better, Real Life Research Practice with AI and Fourth Industrial Revolution. Sir, your talk has been truly enlightening, and it is clear that the convergence of real-time research, AI, and the advancement of Fourth Industrial Revolution is reshaping the landscape of work and life in the profound way. Thank you, sir. I would like to invite respected Dr. Sanjeev M. Padankatti, sir, Professor and HOD of Department of Occupational Therapy, Christian Medical College, Vellore, to felicitate our guest talk, respected Dr. Suresh Munuswamy, sir, Dean and Professor of School of Digital Health Sciences and Technology, Malla Reddy Vishwavidyapith, Hyderabad. Thank you, sir. Thank you, sir. Good evening, everyone. So we are moving to the last faculty talk of this day by respected Dr. Samuel Kamlesh Kumar, sir. Respected Dr. Samuel Kamlesh Kumar, sir, a distinguished occupation therapist with over 20 years of experience in both academic and clinical practice. He is qualified as an occupation therapist in 2001 and earned his master degree in occupation therapy neurorehabilitation in 2005. Sir's primary areas of researches and clinical expertise includes community reintegration, cognitive rehabilitation, and upper limb rehabilitation for stroke patients. As a committee academician, he has supervised over 70 undergraduate research projects and has contributed extensively to occupation therapy lectures with 20 research articles published in leading journals. Beyond academics, Sir is a strong advocate for the profession development. He has been actively involved in conducting workshops, integrative model techniques for hand function recovery, and working towards authoring practical handbooks on occupation therapy management for conditions such as spinal cord injury, traumatic brain injury, and stroke. Without further delay, I would like to hand over the stage to our Sir to present a topic on breaking the ice through an effective translating in occupation therapy neurorehabilitation, as we are heading in right direction. Thank you, sir.
Good afternoon, everyone. My topic is on effective translationality in occupational therapy neurorehabilitation. Are we on the right path? In my presentation, I'll be mainly focusing on three objectives. First, I'll be introducing translationality in neurorehabilitation, then technology-driven motor and cognitive rehabilitation. Then towards my end of my presentation, I'll be talking about the bridging research and practice, transforming clinical care through evidence. Translationality in research, why it matters in neurorehabilitation. Basically, for three reasons. One is bridging the gap between research, practice, and policy, and for practicing evidence-based medicine to improve patient outcomes. And then, as an occupational therapist, we should be like a change agent between the research and practice. The neurorehabilitation current scenario is there is lack of comprehensive care. If you look at the Indian scenario, the comprehensive rehabilitation centers which are providing care for patients are very, very limited. Even if the care is available in some centers, the next major issue what we face is the cost of care. And third is the length of stay. Most of the conditions like the chronic conditions like stroke, spinal cord injury, and brain injury requires prolonged period of in-hospital stay. And fourth one is, even if the patient is willing to stay for a longer time, there is uncertainty of outcomes. Many times patient will ask us, if I stay for 2 months or 3 months, what will be my outcome? So as a neurorehabilitation professional, we always face tough questions to answer. So the biggest challenge what we have now is, we'll have to cut short the inpatient stay and then discharge the patient and ask him to come on outpatient basis and then reintegrate them into their home at the earliest. So there is a lot of pressure on us in achieving outcomes in a short time. So we need a paradigm shift for this to achieve outcomes in a shorter time. There are so many novel therapies that has been proven to be effective over the last decade. Don't mistake me if I say that if I'm presenting about the novel therapies with evidence. All these have to be combined with our regular conventional therapy. First, many of us will be aware of this mirror therapy. It is a form of motor imagery where patient will be asked to see the mirror image of the unaffected arm performing movements, and this therapy has been proven to be very effective in different conditions and especially in stroke. If you see the clinical guidelines for mirror therapy, for upper extremity motor function, there is clear evidence has been established, activities of daily living, and in reducing pain, reducing neglect, and reducing sensory impairment. For all these outcomes, there are clear clinical evidence. When it comes to distal hand function, especially for mirror therapy, there are many articles which has proven the effectiveness. And in terms of spasticity, the results are still inconclusive. Again, the second adjunct therapy that many of us commonly use is constraint-induced movement therapy. This therapy has been introduced to prevent the learned non-use. Here we ask the patient to forcefully use their affected arm. And original CAMT, when it was developed, it was used for 2 to 3 weeks period and 6 to 7 hours per day. But now we follow the modified CAMT protocol, which requires only 30 minutes per day, 3 days per week, and wearing the mitt 5 hours per week for a period of 10-week period. And the indications for using consent-induced movement therapy is that the patient should have limited shoulder movement, that is shoulder abduction to 30 degree, shoulder flexion abduction to 30 degree, and then wrist and finger movements around 10 degree of wrist extension and finger extension. So if the patient has these, we can certainly use the CAMT. And when you look at the clinical guidelines, it is superior to standard rehabilitation, and it has been proven beneficial in acute, subacute, and chronic phases. And again, it has proven to be effective on motor function and improving arm and hand function activities. And even it has been proved that these effects are persisting over 12 months after training. Then another modality is functional electrical stimulation. This has also been used for the last 3 decades. And here you use the small electrical currents to stimulate the nerves. And stimulation parameters have been clearly described in the literature. And FES is also proven to be improving the neural plasticity. When you look at the clinical guidelines for functional electrical stimulation, it is proven to be effective in improving hand function and dexterity. Again, for functional independence, results are inconclusive. And again, improving strength, results are inconclusive. And spasticity, there is limited evidence. And for improving motor function, in the acute stage, the results are mixed. And in subacute stage, there is clear guidelines are there. And for chronic, still researches are needed. Next is the electrical brain stimulation. Again, many centers started using transcranial direct current stimulation and transcranial magnetic stimulation. This picture I have taken it from internet. So this electrical brain stimulation we just started introducing in Christian Medical College, Vellore. And last 10 years, many centers across the globe, they started using this transcranial direct current stimulation and TMCS. And then there is still more researches are needed to prove the effectiveness of electrical brain stimulation. Next is the biofeedback systems. The system which I have shown here is the electrogoniometric biofeedback, that is hand tutor. This computer-based technology provides simulated real-world objects and events, and there are immersive, non-immersive types are there. All these are proven to be effective for improving patient outcomes. The virtual reality techniques are nowadays available. The Oculus, driving simulator, V-game, all these are commercially available. We can use all of these techniques as an adjunct to our therapy purpose. Next, this one is System for Independent Task-Oriented Assessment and Rehabilitation, SITAR. This has been developed with the collaboration between occupational therapists and the bioengineers in CMC Vellore. Now this product is also commercially available as Myro Vision. So that company has taken up, and then they are providing this kind of technology for the patient's improvement. And when it comes to visual reality clinical guidelines for upper extremity motor function, There is clear evidence to say that it improves the upper extremity motor function and for gait and mobility, ADLs and cognitive therapies. So many researchers are coming up and they've proven the effectiveness of these virtual reality based interventions. Next is the robotic assisted therapy. The robotic assisted therapy provides a task specific training, and there are assistive robots which can be used like used for compensation, and there are robots like passive, active assisted and active resisted movements that are provided by the robo. The video what you are showing is a company robotic therapy given by Armio Spring company, and here we can give many task specific training for the stroke patients. This one is called Amadio. This also provides different hand functions. Even if the patients have very limited hand functions, this Amadio robots can be used from the initial stage of stroke. And when it comes to clinical guidelines, again, people have proven that all these robotic devices are effective. Now again, after the COVID period, there is so much of telehealth and home-based rehabilitations are going on, and there are many studies have been conducted and proved the effectiveness of home-based rehabilitation to the telemedicine. So all these evidences, what they suggest is that they suggest only two things. One is the task-specific training. And second is, if the task-specific trainings are given in an enriched environment, that is real-life situations, then the neural plasticity will be much better. These are some of the principles of rehabilitation. Due to time constraint, I don't want to go through each of them. In next few minutes, I would like to talk about how to bridge this research and practice transforming the clinical care through evidence. So I'm going to share some of my research activities which I've done in the last 15 or 20 years time, and then how these researchers, the simple researchers, have helped me and helped our team in CMC to implement in our clinical practice. This study I have published in the year 2010. It was published in Archives of PMR. This study talks about the community reintegration in rehabilitated South Indian persons with spinal cord injury. So when we began this study, our rehabilitation center was started in the year 1966. And this was the first study which documented the effectiveness of our program in terms of improving community reintegration. Through this study, what we found was, we have used a scale called CHART, which is Craig Handicap Assessment and Reporting Technique. In that, it has got 6 domains based on the WHO disability model. And in that, our participants scored well on physical independence, cognitive independence, and social integration. And these 3 areas like occupation, mobility, and economic self-sufficiency, they were struggling. So this research helped us to understand that these 3 areas, return to work, mobility, and then economic self-sufficiency, are the areas of concern. And in second study, this was published in 2012. This is published in Spinal Cord Journal. This study talked about engagement in occupational activities and pressure ulcer development in rehabilitated South Indian persons with spinal cord injury. Before starting this study, our aim was to prove that when the patient is engaging in occupational activities, they will develop less number of pressure ulcers. But when we see the result, it came the other way. Those patients who are involved in occupational activities have developed more pressure ulcers. So the results were very shocking. Then when we did the further sub-analysis, we found that majority of them did not do the pressure relief practices properly. So in our center, we encourage patients to perform push-ups for every 20 minutes. And many of the patients who have gone back to work, they have gone to work like small-scale industries, like tailoring job, beadie making, or cycle repair, toy making. These are some of the jobs that majority of them gone back to, because they're all from the rural background, and majority of them have gone back to those kind of jobs. Those jobs requires them to sit for a prolonged period of time. In turn, that has led to increase in number of pressure ulcers. So this study has helped us to understand this factor, and we revised the protocol. Instead of 20 minutes doing pressure relief practices, we encourage patients to do that in 10 minutes, so that even if they forgot in every 10 minutes, they can do it at next 10 minutes. So this study has helped us in modifying our protocol. This study talks about return to work status in rehabilitated South Indian persons with spinal cord injury. It is also a cross-sectional survey. And in this study, we found that we thought many factors might be contributing for their return to work status, but there are two major factors that are actually contributing for the return to work status. One is the motivation and the social support. If these two factors are properly addressed, many of them could go back to the return to work. That is what we have identified through this research. And this one recently got published in Archives of PMR. This study is about comparative scoping review, robo-assisted upper limb stroke rehabilitation in low and middle income countries versus high income nations. Basically, in this scoping review, we have compared the use of robotic therapy in high income nations and the low income nations. If you look at the graph, we have finally screened around 129 randomized control trials. Out of that, 107 studies are from high income nations, and only 22 studies are from low and middle income countries. Even in the low and middle income countries, the World Bank has classified that as upper middle income countries and lower middle income countries and low income countries. There are three categories. So India comes under the lower middle income country. So in that, out of 22 studies, again, almost 17 to 18 studies were from upper middle income countries, and only one study has come from lower middle income country, that is from India. That study was published from AIIMS, New Delhi. So this study helped us to understand that there is clear research disparity in terms of robotic therapy use globally. Now again, with the help of bioengineers, we have come up with our indigenous robotic therapy device. This is called plug and robotic device. If you Google it, you can find the information about this device. This is called Pluto. And this device has answered many of our questions, because why robotic therapy is not very well practiced elsewhere? The main reason is the cost. And second main reason is the bulkiness of the robotic devices. But this one is a very compact robotic device, and it functions like a mixie concept, like how you use mixie with different blades for using different purposes. Same way in this robotic therapy, with one single motor, you can attach many components, like for example, pronation, supination, wrist flexion extension, finger flexion extension, thumb movements. All these can be added as different attachments, so it is very cost effective. And if you look at if you see the studies which are published using this Pluto also, we have conducted some of the studies in the rural part of Tamil Nadu, and like inpatient, in the acute setting also we could be able to use, because it is a portable device which can be taken to any place. Even we have done this in a remote tribal area also. We have done a study and we have published. And again, this study is very relevant for occupational therapists, like cognitive rehabilitation for adults with traumatic brain injury to improve occupational outcomes. Now, if you look at the literature about cognitive rehabilitation, this is a gray area again. Many of us have struggled, even if you ask us to define what is cognitive rehabilitation, many of us struggle to define cognitive rehabilitation. Now, if you look at the textbooks for classifying the cognitive rehabilitation, cognitive dysfunctions, different textbooks gives different classification systems. To my knowledge, when I was a student, or when I was started teaching my students, we were following Trombley, 4th edition. So that talks about primary cognitive capacities, higher cognitive functions, and metacognitive functions. So a different classification system. So when we did this systematic review, we exactly faced the same problem, because there are numerous studies published, and they also said that there is effectiveness, but the problem is we can't sort out those effectiveness, because there is no proper way of categorizing the results. Similarly, there are numerous assessment tools, and most of the assessment tools are focusing on surrogate outcome measures like improvements in memory, improvement in attention training and all, but they fail to see the functional aspect of it. That is why, as an occupational therapist, we would like to see the effectiveness of cognitive rehabilitation in adults with traumatic brain injury to improve occupational outcomes. So the results of the study says that we got a negative results only, because most of the publishers or most of the people who have done researches, they proved the effectiveness in terms of improving specific cognitive domains, but they fail to show the effectiveness on the functional aspects. That's what we have identified in this systematic review. That helped us to focus on this area and see whether anything can be done in this field. Now, when we started searching about this, we found this classification system from DSM-5. So DSM-5 has classified cognitive disorders under 6 categories. Now, if you look at these categories, all the cognitive domains can be fit under one of these categories. Because many of us will have doubt like whether cognition comes under perception or perception comes under cognition. We always have this dilemma. But if you look at these categories, is very nicely described under 6 domains: perceptual motor function, language, learning and memory, social cognition, complex attention, and executive function. Now, whatever the classification system you follow so far, now if you look at these 6 domains, you'll be able to fit in under these categories. Why this is important? If we use one common classification system, then we can choose assessment tools which are targeting on each specific domains, and then we'll be able to address specific intervention strategies for these domains. So that we have learned from this DSM criteria, which has helped us to develop a care pathway for managing patients with cognitive rehabilitation. Now this picture, if you see, this is a fantastic model. Now we are in the process of coming out with a cognitive rehabilitation model. To my knowledge, this may be the first model that may be coming out from the Indian context. Now if you look at this chart, the left one talks about the domain, which I told you about, the DSM-5, which talks about perceptual motor function, complex attention, all those stuff. So we'll have to use different cognitive assessments, including screening tools and in-depth assessments, to capture where the patient has problem. And second is, there are different stages of delivering cognitive rehabilitation. First one is acquisition stage, application and adaptation. This is from the work of Cicerone. Now if you want to know more about cognitive rehabilitation, if you type Cicerone and see in the Google, you will see lots of information, because he has contributed so much from 1998 to 2020. He has published so many systematic reviews on cognitive rehabilitation. He is the one who has came up with this model, that is acquisition, application, and adaptation. These are the different stages. So when you begin your therapy, that's the acquisition phase. You will try to capture what are the problems the patient has and what are the knowledge he has about his problem. Similarly, the relatives, because for cognitive rehabilitation, even the relatives' involvement is very crucial. And second stage is the application. Once you acquire details about what the problem the patient has, next stage is application. You, along with the client relatives, set appropriate goals, and then you work towards that goal. And third one is the adaptation stage, that is preparing the patient to go back to the community. So you'll teach the strategies to the patient as well as to the relatives, so that they can go and practice the cognitive rehabilitation in the communities. And third column talks about the strategies. Strategies are external and internal strategies. Depends upon the stage, whether it's the acquisition stage or application or the adaptation stage, you can choose which strategy will be applicable. For example, acquisition stage, patient will be unaware of deficits. There you'll have to use external strategy. That means it is more of therapist driven. Therapist role is very crucial. Second, application, slowly you wean off your support, in the sense 50% external support and 50% internal. That is from the patients or the patient relative, depends upon the condition. And third is again external or internal, preparing the patient for the community life. Next one is approaches that all of us are aware of, the remedial and compensatory approaches for dealing with specific cognitive domains, and also the top-down and bottom-up approaches. So I'm not going into the details of that. So the fourth part is like choosing what approach that you are going to use for the patient. And fifth one is activities. There are mental, physical, and social activities. Many times when it comes to cognitive rehabilitation, we always think about one-on-one practice. We make the patient sit and give them many paper and pencil tasks, which many of the patient may not like it. Even we tried some of the technologies also. Some patients have refused. They don't want to use any technology. They don't want to sit in front of the computers because they felt that is very childish. So when we read the literature, we found that cognitive rehabilitation doesn't mean that only sitting with the patient and doing some paper and pencil tasks, but involves mental activities, physical activities, and social activities, because each of them are directly linked with specific neural plasticity. Some of the techniques might improve angiogenesis, neurogenesis, synaptogenesis, and dendritic arborization. These are the different concepts of neural plasticity. So these activities, mental, physical, and social activities, might target any of the neural plasticity. And the last one is gradation, simple to complex, maximal to minimal and no cues, structured and unstructured. These are some of the things, because the slide will be even cluttered, that's why I stopped with this. But there are many gradation techniques also. what I'm trying to say is that not just presenting the screening tools or the standard outcome measures, even the gradation. When you started the therapy, you needed a simple cues, but complex cues, and then with simple cues, the patient is able to perform cognitive activities. Then maximal, minimal, and no cues, and then structured and unstructured activities. Likewise, we will be able to grade, and even in our rounds also we can present it. So this is what the model that we came up. What I'm trying to say is that you look at my research journey so far, it began with one cross-sectional survey on spinal cord injury patients, how they are reintegrating into the community level. But if you look at the stages, slowly we have progressed to developing a model for the cognitive rehabilitation. So what I'm trying to say is that for bridging the research into practice, start doing simple researches, try to connect that with your day-to-day practice. Definitely we'll be able to achieve a good stage when we keep doing those researches. Now the take-home message is, translating research into practice is the key to advancing OT neurorehabilitation. We need to embrace the technology, overcoming implementation barriers, and fostering collaboration will shape the future of evidence-based practice. Thank you so much for your patient listening.
Thank you, sir. The forum is open for the question.
Good afternoon. I'm Sujata from Coimbatore. Sam, great work and excellent presentation.
Thank you.
Still, I have just one question that I would like to ask. When it comes to the initial phases, that is acute phase of any neuro condition in the acute phases, would you suggest the top-down approach or bottom-up approach, or what kind of an approach is better, do you feel? And again, one more thing I would want to ask is, how far do these high-tech devices help in the therapeutic process during the initial phases, acute phases?
Thank you, ma'am. That's a fantastic question. And that is a very debatable thing that is going on around the occupational therapy professionals. Should we follow top-down or a bottom-up approach? Based on my clinical experience, what I realize is that still, if you ask, there is 50-50 percentage. Many of us will be following bottom-up approach. Some of us will be following top-down, and some of us like using mixed approaches. Like when you do bottom-up approach, the major challenge is that it is like we are duplicating the physiotherapy work. For example, when I started in the neuro rehabilitation, when the students or the junior faculty who are working in rehabilitation centers used to come and ask me, sir, physiotherapists are also practicing balance training, and we are also practicing balance training. What is the connect between them? Then I try to explain that, what is the reason for you doing the balance exercises? You have a functional goal in your mind that could be activities of daily living or return to work status. Keeping that in your mind, you are working on these balance activities. So when I say this answer, like the students are able to understand what is the difference between physiotherapy and the occupational therapy, and if you have a clear goal in your mind, the functional goal, you can work towards it. But the real challenge what comes is, top-down approach means always it is about the goal setting. That is what you need to keep in your mind. Your goal is the function. That is, if you see the occupational therapy practice framework, it nicely classifies the occupation into various types, like basic ADL, basic active daily living, instrumental active daily living, work and education, play and leisure, social participation, like that. So these things you keep in your mind, and then you work. So what I'm trying to say is that if you're following top-down approach, the first interview when you have with the patient, you should start asking questions about what are the functional problems that they have. Suppose if I'm interviewing a stroke patient, the first question what I should ask is, what are the functional areas that are impacted on you because of the stroke? Earlier what you were doing, now what are the functional tasks that you are not able to do? When the patient says that answer, from that you try to see why the patient is not able to perform those functional activities. If the patient says, I am dependent on ADL activity, why he is dependent on ADL activities? That could be because of any performance skills or client factors. You could say that it could be because of lack of voluntary control or the muscle power. So if you go this way, patient also will understand that this person is asking question different from a physiotherapist. Otherwise, if the person goes to physiotherapist will have the same questions. He will ask, how is your hand functions, how is your shoulder control, how is your balance and all. If he comes to OT, if you also start with the bottom-up approach, you will also start seeing the patient's tongue control, shoulder control, everything. Finally, patient could not see the difference between OT and PT. So that is why we started encouraging our students and the young staff to address the functional goals first, functional problems first, and then move on to the other body functional, body structure. If you ask me about ICF, I will say start with activity and participation, then move to the body functional structure. That will definitely delineate us from physiotherapists. That is what for the answer for your first question on top-down and bottom-up approach. And second one is related to high-tech devices. Can you rephrase your question, ma'am, again? How can we use high-tech devices?
For example, as you said, robotics or virtual reality in the acute phase.
Yes. Again, see, as I started my presentation, I clearly said that these are all adjunct therapies. This will not definitely replace the role of a therapist. There are adjunct therapists. For example, somebody has presented on exergaming. So exergaming is not going to replace the work of the therapist. Therapist may spend 1 hour time. Remaining time the patient can practice with exergaming. There is more opportunity for the patient to keep on practicing. That is the advantage of these adjuvant modalities. When it comes to acute phase, see, even sometimes we are not able to bring out or able to do anything in the acute stage. For example, if the patient, if you take a stroke patient, if their upper limb is completely flaccid, you can't do anything at that stage. Only the clasp band techniques you can use, definitely. But other than that, if you use like mirror therapy, is proven to be effective even in the acute stage. You need not need the patient's affected arm for therapy purpose. Patient is going to use the movements with the left arm. So mirror therapy can be started from day one. Functional electrical stimulation, with limited movement if they have, you can start with functional electrical stimulation. Robotic therapy, I said, there are active robots, passive robots, and active assisted robots. If you can use them, so all these can be used in the acute stage. So you need not wait for the patient to develop some movement, but you can introduce some of these adjunct therapies from day one onwards. That's the advantage of these technology-based intervention.
Thank you so much. I hope there are a lot of students here, and I hope a lot of things would be clear by his presentation and what he spoke, because I think he spoke right from the basics. He started with the base, and then he went to the high-tech technology also. Thank you.
Thank you, ma'am.
A very good presentation. Thank you for the good presentation. I wanted to know about the Pluto. How is it available and where it is available? How much is the cost and all?
Ma'am, plug and train robotic device. This is developed in CMC, as I said, with the collaboration of occupational therapists and the bioengineers. And now a company has taken up the copyright, and they're going to develop it soon, and it will be available in the market. So right now, I'm not in a position to say the cost of it. Right now, if you see in the Google, you can find the initial researchers on this device. Only thing what we can feel proud is that this is everything is developed in India. Now it has been like for research wise, some of the Pluto component has been given in US, UK, and many other countries. See, because always we borrow these things from other countries. This is the first time robotic device has been developed in India in CMC Vellore, and this has gone to different Western countries. This is the first product which has gone from India to other countries.
Because AMDO and all that are very costly. They are around 4-5 crores.
Yes, ma'am.
So it's not affordable for
That is the main reason for the development of this Pluto device.
Right.
As I said, the robotic, that study scoping review, high income nations have produced 107 articles. I was casually interacting with one of my colleagues here, why they are promoting robotic therapy very essentially in Western countries. There are different reasons for that. One is they have money. But at the same time, they want, suppose NHS, if you take UK system, they have, NHS has to pay for the patient's care. So if the patient is staying inside the hospital for a longer time, there's too much of burden for the NHS. So they are discharging the patient and giving them with the robo. But in Indian context, what I've realized is that we can't say that we don't want robotic device in India or we don't need robotic device in India. I'm saying the scope in other way. What I'm saying is, if you see the therapist-patient ratio in India, how many occupational therapists are there? Some of my colleague was telling me they are from a rural town in India. He was asking me, are there any therapists which I know? I said, I don't know. There are no rehabilitation centers also around that town area. What to do? So in such situations, these are the simple devices might be a great handy in Indian situation. What I will say is more than US context, in our context, still robotic therapy will be good. Only thing is if you can produce cost-effective robots.
Right.
That's the challenge for
That's a
us.
challenge. Thank you so much.
Thank you, sir. There is an announcement to be given to the respected delegates that IOTA GB meeting will be held in this same venue, that is the main auditorium, after the fifth scientific session. After the fifth scientific session, and student interaction with WFOT president by 4:45 p.m. at Black Box. 30. Okay, 4:30 p.m. at Black Box. Like, yeah, you can ask. Four students from each college can ask your questions to our respected WFOT president.
I requested all college heads to instruct your student, at least 4 from each college, to participate the student interaction meeting with our Honorable WFOT President at Black Box at 4:30 p.m. I requested all HOD instruct your student, so at least 4 students from each college for interaction meeting with our WFOT President at 4:30 p.m. Thank you.
Sorry, can I ask one question last? Dr. Sam, thank you so much for your elaborated presentation. In respect of domain of concern, like ADL, leisure, and all you highlighted, and the stages acquisition, application, and adaptation. So, in point of your experience, it can be any interchangeable. I can say it's not in a theoretical aspect. In your practical concern, sometimes applications can be come first, adaptation can be come first. So how it is there? And the task analysis of neurorehabilitations, well, you are talking about OTPF. So in any one of the occupations, we have to do under task analysis. How it will be your experience?
Yeah. Thank you for this question. What I can suggest you is that due to the time constraint, we should look at the work of Cicerone et al., who has done publication on this. He is the one who has proposed these phases of rehabilitation, acquisition, application, and adaptation. First, suppose if a patient comes to you, what do you do first? You need to know about the patient, right? So that is what happens in the acquisition. So application never go first, because you need to know the patient, his strengths and limitations, then only you can proceed further. So that is the acquisition phase. Application phase is once you know the patient, his strengths and limitations, you devise your intervention strategies. So that will always come in the second step. Third step is adaptation. Knowing their family background and from the other economic or whatever social background, you devise specific intervention strategies and then you suggest them. So that comes in the third phase. So to my experience, I don't think that there will be, these are interchangeable stages like acquisition, application, and adaptation. These are linear stages.
Okay, thank you.
Thank you.
Thank you, sir. I would like to extend our gratitude for your insightful session on the topic breaking the ice through an effective translating in occupation therapy neurorehabilitation as we are heading in right direction. Sir highlighted the evolving landscape of neurorehabilitation and stressed the importance of effective communication and collaboration between the research and practice was truly enlightening. Thank you so much, sir. I would now like to request respected Dr. Jyotika Bijlani ma'am, Dean, Accord, to felicitate Our respected Dr. Samuel Kamlesh Kumar Sir, Professor and in charge of OT Services, Department of Physical Medicine and Rehabilitation, Christian Medical College, Vellore.
Love, I would have liked it. She changed it from love to like.
Yes, thank you.
I wanted to just say first, you said I love to invite. I would have preferred that. Love to invite.
For sure. Thank you so much. Thank you, sir. Thank you, ma'am. So we are at the last session of this scientific event of today. That is our 5th scientific oral paper presentation on the title Harnessing Neuroplasticity in Neurorehabilitation, Innovative Occupation Therapy Strategies for Enhancing Motor Recovery. So I would now like to call all the chairpersons, dignitaries onto the dais. Respected Dr. Santa Batkar, Consultant Intervention Neurologist, GMC Goa. Sir has completed his MBBS from GMC and MD Internal Medicine from Government Medical College, Surat. He has also pursued DM Neurology at PGI MER, Chhattisgarh. Welcome, sir. I would like to call upon the next chairperson for the event, Dr. Sebastina Anita De Souza, ma'am, Professor, Department of Occupation Therapy, Coordinator, Center for Studies on Healthy Aging, Manipal College of Health Profession, Manipal. Ma'am has done a BSc and MSc in OT and PhD in OT. Welcome, ma'am. I'd like to call upon the next chairperson, Dr. Vishal Jain, sir, Senior Consultant, Department of Neurosurgery, Sharda Care Health City, New Delhi, NCR. Sir is a distinguished neurosurgeon with an MBBS from King George Medical College, Lucknow, and an MS in General Surgery from SN Medical College, Agra. Welcome, sir. I would like to call upon the next chairperson for the event, Dr. Samuel Kamlesh Kumar Sir, Professor and an in charge, Occupation Therapy Services, Department of Occupation Therapy, CMC Vellore. Sir has done his BOT from Santosh College of Occupation Therapy and the Diploma in Rehabilitation degree at AII PMR, Mumbai, and MOT from Kasturba Medical College, Manipal. Welcome, sir. I would like to hand over the session towards the chairpersons. Thank you.
You're calling it?
In this order. No, this one. Thank you, everyone. We'll call the first speaker, Dr. Harshada Langde from Mumbai, and she will talk about effect of brain gym exercise on fear of fall and balance in patients with Parkinsonism.
Good afternoon, everyone. Good afternoon, everyone. Myself, Harshada Landge. My presentation topic on effect of brain gym exercises on fear of fall and balance in patient with Parkinsonism. It is a quasi-experimental study. Introduction. Parkinsonism is a neurodegenerative condition characterized by the Lewis body, Lewis neuritis, and cell loss in substantial nigra. It is including the symptoms resting tremors, akinesia, bradykinesia, rigidity, aberrant posture, and motor arrest episode. Primary cause of balance difficulties are deficit in a sensory motor integration and cognitive function. One of the common signs is fall. Two-thirds of the patient fall at least once a year, and more than them is a capacity of episodes of fall recurrence. The patient who have a balance frequently have a lower the quality of life and disability and fall. I can't see. Can I? Sorry. Next. Brain gym activities is a fundamental motion that enhance the perception and stimulate the bilateral cerebral hemisphere. Promote whole brain learning through the neural remolding, impacting white matter connection and neural mechanism with a brain activity represent the laterality. Brain gym exercises improve the grade stability, enhance the mobility, reduce the fear of fall, and better posture balance, potentially leading to the better quality of life. Needs of the study. Fear of fall and balance problem is a most primary concern in the patient with Parkinsonism. Many innovative approaches were used to reduce fear of fall and improve the balance like physical exercise, mindfulness, and yoga. There is a scarce evidence which suggests use of brain gym exercise in Parkinsonism. There is a need for the structured program of brain gym activity which help intervene in the Parkinsonism population effectively. Aims of the study. To find out the effect of brain gym exercise on fear of fall and balance in patient with Parkinsonism. Objective, to screen the Parkinsonism patient by using the MOCA and Hoyne and Yard scale. To measure the fear of fall using the Fall Efficacy Scale International and balance using the mini-beast test in pre to post brain gym exercise in patient with Parkinsonism. To find out the correlation between two components. Hypothesis. Null hypothesis 1 and 2, there is no significant difference in fear of fall and balance in patient with Parkinsonism after receiving brain gym exercise. Alternate hypothesis 1 and 2, there is a significant difference in fear of fall and balance in patient with Parkinsonism after receiving brain gym exercise. Methodology. It is a quasi-experimental study conducted in tertiary care municipal hospital. Non-probability convenient method is used for the 10 participants using the MOCA, Hoyne and Yard scale, Fall Efficacy Scale International and mini-based test. Inclusion criteria, both male and female, age between 30 to 17 years, after 6 months of diagnosis, Hoyne and Yard scale, stage 2 to 4, MOCA score greater than 18, Fall Efficacy Scale International less than 16. Exclusion criteria, mini-beast scale score less than 9. Procedure and ethics. Ethical clearance was taken from the institutional ethical committee. Participants were recruited and data was collected between the October to December 2024. Data was analyzed using the statistical analysis using the IBMI Corporation, IBMI Statistical for Windows version 20. Intervention protocol. Screening assess from MOCA, Hoyne and Yard scale, Fall Efficacy Scale International and mini-beast test were conducted before the first week of intervention. It is underwent in a brain gym exercises thrice a week for 45 minutes over the 2 weeks and complete 6 sessions. Fall Efficacy Scale International and mini-beast tests assists were conducted before the first week of the intervention and at the end of the second week of the intervention. Brain gym exercises. Before the performing brain gym exercises, I had given the pace activity for make a patient relax and stress less and give the space for learning the new activity. In brain gym exercises, it given in the 3 component. First is a midline exercise. In midline exercise, I included cross crawl and the rockers and neck rolling. In energy exercises, I included sipping of water, the brain buttons, and the hook up and thinking gap. In learning activity, I included calf pumps, the grounders, and the gravity grinders. Result, demographics, the total participants is 10, 4 female and 6 male, shows the 4:6 ratio. It suggests that the more male patient is affected with Parkinsonism. The statistical significant change was observed in a fall efficacy scale international for pre to post intervention. The pre-mean value is 27.9, standard deviation 4.23, and post-intervention mean value is 27.3, standard deviation 4.30, with t value is 3.67. It is intra-group p value is less than 0.001. Show the reduction in a fear of fall. The significant statistical significant improvement were observed in a mini-BIS test score from pre to post intervention. The pre-intervention mean value 15.70, standard deviation 2.73, and post mean value is 16.8, standard deviation 2.53. T value is 6.09, indicated a intra-group P value is less than 0.02. The correlation between two parameters, the interval line, that is a vertical line, represent a key reference of pre and post intervention. The red line indicated the pre-intervention, which R value is 0.873, indicated a more the fear of fall and less the balance. In green line represented post-intervention, that R value is 0.964, indicated the better the balance and reduce the fear of fall. Discussion. Fear of fall efficacy scale international indicated a statistical significant reduction. The brain gym exercise enhanced the proprioceptive input and neuromuscular system, activated the mechanoreceptors, activated the central pattern generator. The semicircular canal and reticular system also activated and promote the alpha state. Our studies are supported by the Rasika P and Pretzinger. Mini-BIS test result show the statistical significant improvement on balance. Brain gym enhance the sensory motor integration, and the lateral dimension facilitate the coordination between two hemispheres. The repetitive movement and strengthening somatosensory, visual and vestibular function. It improve the balance, midline crossing and movement coordination. Our findings are supported by the Saili Pathak and Rasman Biji. It was a strong negative correlation in pre-intervention and strong positive correlation in post-intervention. Indicate that the improved balance lead to the reduced fear of fall. Brain gym play a crucial role in decision making, effort, stress response and thought process. It is a closely linked to the balance confidence, which has been identified as a strong predictor of the future fall. Individual with a low self-esteem and reduced balance confidence tends to avoid the activity. These fear of falling leads to the self-imposed activity restriction, which is turn result in a decreases physical capacity and increases the risk of fall. Our findings was supported by the Merrill R. Conclusion, there is a, on the basis of the result, the fear of fall is reduces and improve the balance. Conclusion, brain gym exercises and help Parkinsonism disease patient improve the balance and reduce the fall risk. Exercise are simple, affordable, easy to use and have no side effect. Future research of brain gym exercise may enhance the neurological condition for Parkinsonism and related disorder. Advantage, there is put a focus on the fear of fall and balance and consider the brain gym exercise in Parkinsonism patient. Recommendation, there is to be large population and long duration of intervention. Thanks to all my co-author and participated for their cooperation and participation. These are my reference. Thank you.
Check.
We have the next presenter, Dr. Shubham Sharma, on integrating occupational therapy with speech therapy in stroke rehabilitation.
Good evening, one and all. Myself, Shubham Sharma, from Good evening, one and all. Myself, Shubham Sharma, from Department of Occupational Therapy, MGM Medical College and MY Hospital, Indore. Today I am presenting my research, integrating occupational therapy with speech therapy in stroke rehabilitation, addressing communication and functional recovery. Abstract. This study evaluates the effectiveness of integrating occupational therapy with speech therapy in stroke rehabilitation. A randomized controlled trial with 100 patients compared integrated therapy outcomes were assessed using the Barthel Index, Boston Diagnostic Aphasia Examination, and stroke-specific quality of life scale. The experimental group showed significantly greater improvement across all the measures. These findings highlights the efficacy of integrated occupational therapy and speech therapy in enhancing functional recovery, communication skills, and quality of life in stroke patients. My keywords are stroke rehabilitation, occupational therapy, speech therapy, functional recovery, and quality of life. Introduction. Stroke is a major cause of death worldwide with a high number of fatalities, particularly in South Asia country. Stroke rehabilitation requires a collaborative approach with healthcare professions from different fields working together to support an effective recovery process. The paper highlights the rehabilitation process with a particular focus on restoring functional ability and communication skills in a stroke survivor. Aims and objective of the study. This study aims to explore the integration of occupational therapy and speech therapy in stroke rehabilitation, focusing on its impact on communication recovery and functional independence. By assessing the effectiveness of combined therapeutic approaches, the research seeks to identify best practice that enhance both speech and motor recovery. The goal is to provide evidence-based insights that can help healthcare professions to develop more comprehensive and collaborative rehabilitations strategies, improving the quality of life for stroke survivors. To examine the impact of integrating occupational therapy and speech therapy on communication recovery in stroke patients, to assess the role of combined therapy in improving functional independence and daily living activities post-stroke. Methodology. We use a randomized control trial with a sample size of 100 stroke patients divided into two groups, where experimental group have 50 patients receiving integrated occupational therapy and speech therapy, while the control group have 50 patients receiving standalone occupational therapy, either speech therapy. The duration of study was 12 weeks and frequency was 3 sessions per week. Inclusive criteria of our research: adult aged from 18 to 80 years, first-time stroke survivor with motor and communication impairment, medically stable, capable of attending regular therapy sessions. While our exclusive criteria: severe cognitive impairment, MMSE score less than 24, history of multiple strokes or neurodegenerative disorders, patient unwilling to participate. Intervention and assessment tool. While experimental group joined occupational therapy and speech therapy sessions, combining functional activities and communication tasks. While control group separates occupational therapy or speech therapy sessions following a standard protocol without integration. We use assessment tool for functional recovery. We use Barthel Index for communication skills. We use Boston Diagnostic Aphasia Examination. For quality of life, we use stroke-specific quality of life scale. Data collection was conducted through a structured survey with 6 closed-ended questions focusing on patient experience. Pre-intervention and post-intervention measurements were recorded for all the patients. Data analysis was done through statistical softwares IBM SPSS version 26. Hypothesis testing was conducted by paired t-test and independent t-test to compare the pre- and post-intervention scores within the between group. Level of significance was p-value less than 0.05. Here results are shows the participant demographics among 100 individuals were 55% were male, 45% were female. The age criteria was 20% the age criteria was 45% were from 41 to 60 years, 45% were from 61 to 80 years, and 10% were from 18 to 40 years. The time since they have a stroke, 30%, 20% had a stroke duration less than 3 months, 40% were in the category of 3 to 6 months, and 40% had a stroke less than 6 months. 30% had hemorrhagic stroke, while 70% had ischemic stroke. While the education level, the primary education had completed by 35%, secondary level education completed by 30%, higher education 10th level was completed by 20%, and no education was reported 15%. The employment status of the patient, 55% has no job, means unemployment, 25% employed, 20% retired, 50 therapy types. 50% participation receive a combination of experimental therapy, occupational therapy, and speech therapy together, and control group, control therapy, either standalone occupational therapy or speech therapy. Diverse the participants profile. The study includes a varied participants pool representing a wide range of age, stroke duration, education, and employment status, which contribute to the comprehensive understanding of stroke rehabilitation. Comparisons of therapy groups: control group 34.3% in Barthel Index, 22.4% in Boston Diagnostic Aphasia Examination, 20.9% in quality of life for stroke specific. Experimental group, while 73.3% improvement in Barthel Index, 56% in Boston Diagnostic Aphasia Examination, 42.7% specific stroke specific quality of life. When pre and post intervention mean score, the significant improvement for both experimental and control group shows significant improvement for all the measures. Higher improvement in experimental group. The experimental group had greater improvement in the Barthel Index, BDAE score, and quality of life compared to the controlled group. While we talk upon outcomes, the Barthel Index experiment group increased from 45.3 to 78.5, while control group from 46.0 to 61.8. When the hypothesis was testing, the first hypothesis, integrate occupational therapy, speech therapy does not significantly improve functional recovery, that was rejected. The analysis indicates the Barthel Index score for experimental group are significantly improved. Hypothesis 2, integrate occupational therapy does not significantly improve communication skill, but that was also rejected, showing significant improvement in BDAE score. Hypothesis 3, integrated occupational therapy and speech therapy does not significantly improve quality of life, but it was also rejected and indicated significant improvement in stroke survivor quality of life. When we talk about summary table, the findings demonstrate the integrating occupational therapy with speech therapy leads to significantly better outcomes in functional recovery, communication skills, and quality of life for stroke patients compared to standalone therapies. Discussion. This study demonstrates through its result that stroke rehabilitation achieves superior functional recovery along with enhanced communication abilities together with better quality of life when occupational therapy and speech therapy work together. Perform result from a patient who received combined therapy showed superior outcomes for every measured evaluation, unlike the patient those who are treatment involve only the distinguished interventions. The experimental group achieved superior quality of life improvement than the control group, 42.7% versus 20.9%, because integrated rehabilitation strategies that addresses motor functions and communication deficits produce better patient satisfaction with treatment. The statistical findings from the independent t-test supported these initial observations. My limitations are small sample size. The study includes a limited number of participants, reducing in generalization of the findings. Short follow-up period. Outcomes were measured over a relatively short duration, limiting insights into long-term effects. Homogeneous population, single center studies conducted at a single location, potentially influencing result due to local practices or biased. Limited outcomes measure. The study focuses on specific metrics which might not capture other important aspects of the stroke recovery. Conclusion. Enhancing recovery with combined therapy was improvement, functional recovery, communication skills, and quality of life in a stroke patient compared to the standalone therapy. Multidisciplinary approach to study emphasizes the value of a multidisciplinary approach that addresses both motor and communication deficits, leading to more comprehensive rehabilitation outcomes. Experimental group out of performed group, control group, the experimental group consistently show better results than control group across all the measures. Future direction for research, synergetic effects of occupational therapy. Occupational therapy, future research should explore the combination of effective of occupational therapy and speech therapy, technological integration, role of learning principle and new technologies, personalized cost-effective therapies for remote area. Here are our questionnaires. Here are my references. My acknowledgements to my Dean, MGM Medical College and Associate Hospitals, Superintendent MY Hospital Indore, Head of the Departments, Neurology, ENT, Emergency Medicine, Community Medicine, Occupational Therapy for referring patient to us, Principal MGM Allied Health Sciences Institute, Mahasi, Indore, and participants. Thank you.
I would like to call upon next speaker, Dr. Noor Mohammed from New Delhi, to present his presentation.
Good afternoon, everyone.
Dr. Noor Mohammed, your topic is primary dysmenorrhea, I think, right?
Yeah.
How come in between neuro-gynae topic came? Any idea?
Because they have some neuromuscular aspects also.
Carry on. Just asking query. That's it.
Good afternoon, myself Dr. Noor Mohammed, and the title of my study is Efficacy of Core Strength Training on the Primary Dysmenorrhea, a randomized controlled trial. Primary dysmenorrhea is characterized by the recurrent cramp-like pain during the menstruation without any underlying pelvic issues. The pain typically starts with the first few years after the menarche, and it's most severe. It is most severe during the first 2 days. The primary cause of this is release of prostaglandin from the uterine lining, which increases the uterine contraction and reduces the blood flow, leading to the pain and discomfort. Symptoms such as lower abdominal cramping symptoms includes intense spasmodic pain radiating to the lower back and legs, gastrointestinal symptoms such as nausea, vomiting, diarrhea. Some women have experienced fatigue, headache, dizziness, and even anxiety and irritability during this period. The intensity of the severity and the pain affects from person to person. Dysmenorrhea affects 50 to 90% of women with reproductive age, and the traditional treatment available are the NSAIDs and hormonal contraceptives only, and yet the non-pharmacological options are very limited. So basically in this study which we have targeted is the core strength training, and core muscles are the muscles which maintains the body's upright posture and supports the hip, pelvis and spine in unison. It is a muscular box with the diaphragm acting as the roof and the pelvic floor and hip girdle as the bottom, and the abdominal in front, paraspinal and the gluteal muscle in rear. Core strengthening is a training that isolates the strengthens the small intrinsic muscles surrounding the lumbar spine, allowing them to be conditioned in form for increased performance. Strong muscle enables the body to withstand the daily stresses and regular biomechanics even during the menstruation cycle when the body is under stress. There are basically two types of core muscles available in our body, which are first of the stabilizers and another are the movers. Rationale behind the study is to provide evidence on the benefits of the core strength training to promote a non-pharmacological, accessible, sustainable intervention for managing the primary dysmenorrhea. The study aims to study the efficacy of 8-week core strength training program in young women with the primary dysmenorrhea, and the objectives are to assess the impact of core strength training on the pain intensity and discomfort during the menstruation, to evaluate the involvement of health-related quality of life, to measure the change in emotional symptoms such as stress, anxiety, and depression. Study hypothesized that core strength training program can provide a significant relief from the dysmenorrhea symptoms while improving quality of life and emotional well-being. The study design was a randomized controlled trial consisting of 60 participants, and the participants were divided into two groups, experimental group consisting of 30 participants and a control group that were also having 30 participants. The study took place between September 2023 to May 2024, and the participants were included 60 nulliparous non-athletic females age ranging 19 to 25 years with regular menstruation cycle and history of only mild to moderate dysmenorrhea were included. Participants diagnosed with any pelvic pathology, chronic illness, recent use of analgesics or hormonal treatment were excluded. Outcome measures used were EROCOL 5-dimension 5 level for assessing the quality of life, work ability, location, intensity, days of pain, dysmenorrhea. Valid scale was used to assess the symptom severity. Depression, anxiety, stress scale 21, which is DAS 21, was used to assess the emotional symptoms like depression, anxiety, and stress. Following are the procedure of the study. Ethical approval was taken from the Jamia Hamdan Institutional Ethical Committee first of all, and then the participants were enrolled as per the inclusion and exclusion criteria. Informed consent was recorded, after which the baseline scores of the outcome measure were recorded, and the experimental group was administered with the 8-week core strength training program, after which the post-intervention score were also recorded and statistically analyzed. This is the 8-week core strength training intervention which was administered by the participants. It was having 3 phases. Phase 1 was focusing on the flexibility, phase 2 focused on strengthening, and phase 3 focused on the endurance. There were few of the self-administered sessions and there was few supervised sessions. So there was 24 of total self-administered sessions and 8 of the supervised session, and total of 32 sessions was given to the participants. Following are the few of the exercises performed by the participants. Phase 1 was focusing on the flexibility, and the participant can be seen doing lower abdominal stretch and bridging exercise. Phase 2 showing the strengthening. Phase 3 showing the endurance. So all the data was recorded and put it in the master chart using the Excel. Then SPSS software 20 version was used to statistically analyze the data for independent sample t-test to compare the mean with between the experimental group and the control group. Level of significance was kept below the 0.05. This is the table showing the descriptive analysis of the participants with the mean age of 22.05, mean weight 53.72, mean height 160.95 centimeter, and the BMI of 20.82. This graph shows the mean difference between the experimental versus control group with the reduction in the valid score of 11.2 to 5.13 and reduction in the DAS score from 48.2 to 27.3, and there was a significant increase in the score of the EQ5D5L, which is quality of life, from 73.83 to 84. This is the independent sample t-test data, which is showing the significant reduction in the mean with the value less than 0.05. The experimental group showed a significant reduction in the pain intensity in contrast to the control group. There was a significant improvement in the quality of life, and there was similarly there is a reduction in the stress anxiety scores. There is under the discussion heading, we have the significant reduction in the pain intensity, discomfort, and emotional symptoms which are associated with the primary dysmenorrhea. Participants in experimental group showed the marked improvement in quality of life as evidenced by higher EQ5D5L scores and reduced negative emotional symptoms measured by the DAS 21. The finding highlighted the potential of core strength training as an effective non-pharmacological intervention from primary dysmenorrhea. The study also reported the core strengthening. There are previous studies also which are aligning with our results, and studies like previous studies reported the core strength training exercises help alleviate the menstruation pain by improving the pelvic stability and reducing the muscle tension. There was a similar systematic review which emphasized that the targeted physical intervention improves the blood flow to the pelvic region, potentially reducing the ischemia and uterine cramping also. The mean reduction in the pain score aligns with the studies suggesting that the consistent exercise mitigates the prostaglandin-induced contraction, which is primary cause of the dysmenorrhea. Significant improvement in EQ5D5L score in experimental group reflects the enhanced mobility, reduced discomfort, and better emotional well-being. Similar findings were reported which highlighted the exercise improves the various dimensions of health-related quality of life in women with menstrual-related symptoms. Experimental group also demonstrated significant improvement in DAS 21 scores, indicating the reduced depression, anxiety, stress level. Physical activity, including core strength training, is known to stimulate the release of endorphins, which act as a natural mood enhancers. Study has the following limitations. Sample size was limited for the generalizability. Long-term efficacy of adherence to core strength training need further study. Future researchers should be comparing the core strength training with other forms of exercises also. Exploration of the impact of core strength training on secondary dysmenorrhea and other menstrual disorders may be done. Study concluded by providing the evidence of benefits of core strength training as a non-pharmacological intervention for primary dysmenorrhea. Core strength training emerged as a highly effective approach, improving pain intensity, quality of life, and emotional well-being. The findings advocate for the inclusion of targeted physical training in dysmenorrhea management program, offering a holistic and sustainable solution to prevent a prevalent condition. Following are my references. Thank you.
Dr. Noor Mohammed, thanks for reminding us of MBBS days, me and Dr. Sanat. So, would you like to call the next speaker, please?
Thank you. Thank you, sir.
Now, I would like to invite Dr. Vijay Batra, who is going to present his topic on dynamic stabilization strategy for alleviating synkinesis in Bell's palsy. Over to you, sir.
Very good morning to all the dignitaries, both on the dais and off the dais, and my dear students. Today I am to talk about dynamic stabilization strategy for alleviating synkinesis in Bell's palsy. Before we proceed, we should know what the synkinesis is. The synkinesis, it is an abnormal and unintentional co-contraction of the facial muscle, in which the voluntary facial muscle contraction or the movement, it causes the simultaneous involuntary contraction of the other group. It becomes more pronounced during the stress and may result in the functional, cosmetic, and other habitual impairments. The common complaint in the patients could be the involuntary closure or narrowing of the eye during voluntary mouth movement, or could be the involuntary mid-facial muscle contraction during voluntary eye closure. You can see with the voluntary mouth movement, the eye closure is observed. Similarly, the pathophysiology involved in this is the abnormal regrowth or regeneration of the facial nerve fibers. The existing therapeutic intervention include botulinum toxins, facial exercises and massage, meditation, electrical stimulation, etc. But the appropriate strategy to control the synkinesis is still a matter of debate. Hence, the study was conducted. Main objective of the research question of my study was to see the efficacy of function dynamic stabilization strategy to control the extent of synkinesis over conventional strategy, and also to determine the extent of correlation between the synkinesis and the voluntary motor control and synkinesis during functional activity. It was a quasi-experimental control design in which the functional dynamic index and a Houseman and Backman classification was used for grading all the 30 subjects of age range 80 to 40 years, and the subjects with brain SOL and psychiatric illness were excluded from the study. In this, there was one dropout in group A, and the reevaluation was done after 6 months. It was an intention to treat analysis. So the functional dynamic strategy talks about maintaining positioning, alignment, and symmetry, apart from maintaining the functional stability during voluntary motor contraction or control, and facilitating the weak or paralyzed muscle, balancing the abnormal muscle pull, and preventing the overactivity of the normal muscles. In the patient, you can see the stabilization strategy was applied in the FDS group, and the patient recovered both after 6 months. Then for the conventional group, the facial exercises, massage, relaxation training, meditation, and mirror for providing feedback was used. And individualized instructions were given to each and every patient. But in this patient, we observe, you can see the synkinesis is observed. In this patient, post-intervention, the eye closure is there. Yeah. Since the distribution was skewed, for analyzing the correlation, the Spearman correlation coefficient was calculated, And it was observed the rho value was varying from point minus of 0.136 to point of 347 for voluntary movement and composite score. Similarly, on discussion on between group analysis at baseline, no significant differences were observed. While post-intervention, p-value was found to be more significant for voluntary motor or voluntary movement during gentle eye closure, open mouth smile, and functional activity like chewing gum, balloon blowing, and improvement in sync kinesis and composite score. Apart from this, at baseline, the weak non-significant correlation was observed for sync kinesis and voluntary movement score, and sync kinesis and functional activity, and sync kinesis and composite score with the rho as 0.315. And also for facial function deficit, the negative correlation was observed between sync kinesis and this deficit. The post-intervention, the significant differences were observed for voluntary movement and sync kinesis during forehead wrinkle, gentle eye closure, open mouth smile, smirk, lip pucker, and wrinkled nose. And sync kinesis score in the functional activity, again, it was observed as a negative correlation was observed. Apart from this, the significant positive correlation was also observed for facial function deficit and sync kinesis score post-intervention. The positive correlation coefficient indicate that both sync kinesis and the facial functions are directly related. The results so observed indicate the higher the severity of disease, more is the sync kinesis. Post-intervention, the negative correlation coefficient between sync kinesis severity and composite score, as well as the sync kinesis and the voluntary motor score was observed, indicates that there is an inverse correlation between the sync kinesis and the functional restoration. With the improvement of sync kinesis, both voluntary control and composite score also improved. The improvement in sync kinesis and composite score, it was also documented in the study by Parkinson's, who emphasized on neuromuscular education training by enabling the patient to control the sync kinesis or mass movement via functional retaining exercises along with simultaneously inhibition of sync kinesis. Apart from this, Jesse Venthrwin documented the importance of facial neuromuscular education to facilitate the return of intended facial movement pattern and eliminating the unwanted pattern of the facial movement during a patient-centered approach. Following the facial nerve paresis, there is synaptic stripping of the muscle, resulting in imbalance between excitatory and the inhibitory input on facial motor neuron. Further, there would be the polyneural innervation by the axonal sprouting in the motor end plate region, resulting in disorganized repair of the damaged facial axon and pathological coupling of the cortical area during the functional task. As a result, an axon now can cross-excite the adjacent axon, resulting in sync kinesis. So with the dynamic stabilization strategy, the objective was to enhance and restore the sensory motor synchrony of the facial muscle by correcting abnormal pull, preventing asymmetry, overactivity, overpull, and reinforcing the movement in a graded fashion, and maximizing the functional use of the affected muscle, resulting in improvement in sync kinesis. Hence, it can be concluded that facial sync kinesis has a significant bearing on quality of facial muscle responses as demonstrated during the voluntary expression and during facial functional activity. And the therapeutic exercise should incorporate the strategies to incorporate dynamic stabilization to hinder the sync kinesis, to augment the axonal growth, and sensory motor synchrony of the facial muscle throughout the rehab process. Here's a list of my references, my scoring criteria, the Beckman classifications, and the functional activity grading. Thank you.
Thank you, Dr. Vijay Batra, for your presentation. Next, we move on to the presentation by Dr. Shanta Pandian from New Delhi. She will be presenting on effect of synergy-based motor therapy on lower extremity recovery and function in stroke and RCT. Over to you, ma'am.
Shall I start? Respected dignitaries and delegates, very warm good evening. My topic is effect of synergy-based motor therapy on lower extremity recovery and function in stroke. It is a randomized controlled trial. Motor paresis is the leading reason for post-stroke disability. Post-stroke, motor impairment and recovery is multifactorial. Motor recovery appears in form of mass flexion and mass extension pattern among both the limbs. Such motor presentation is referred as abnormal synergies among stroke. Motor recovery, abnormal synergies disappears as the motor recovery or motor control appears. There is a similar pattern of motor recovery in both the limbs with a faster rate in lower extremity. Both flexor and extensor synergies appear in lower limb also. However, extensor synergy needed for the weight bearing is stronger in lower extremity. Involuntary flexion of upper extremity is being observed during lower extremity extension activity and vice versa. Such asynchronous presentation between both the extremities is varied with chronicity. There exists an interlimb linkage between both the limbs, hence the upper extremity influences the recovery of lower extremity. Synergistic linkage has the basis for recovery. Synergistic linkage intervention for lower extremity is partially available in the literature. SBMT upper extremity protocol has integral component of lower extremity. The purpose of this study was to analyze the effect of SBMT on motor and functional recovery of lower limb among stroke. Study is based on the findings of the secondary outcome measures from the PhD thesis work. It is registered under Clinical Trial Registry of India, conducted in a rehabilitation institute, and was being approved from these two ethical committees. The sample size was being calculated based on the findings of upper extremity SBMT study. There were 136 post-stroke hemiparalytic subjects were conveniently selected and randomly allocated, and it is a double-blinded study. The subjects were included with non-traumatic stroke, either ischemic or hemorrhagic, right and left, up to 3 years of the chronicity, and age 20 to 75 years. Subjects were excluded if they had any communication deficits, contracture deformity, cognitive and perceptual deficits, cardiovascular instability, and any uncontrolled medical illness. This is the consort diagram showing 209 subjects were totally screened and 136 were selected. 68 were randomly allocated in each group. There were 5 subjects last observation carried forward in the experimental group and 8 in the control group. The dosage was 48 intervention sessions, 4 per week for the period of 3 months. There were 3 assessment sessions, pre, post, and 1 month follow-up assessment. A dose match control intervention was being provided to the control group. Experimental group of subjects received the stage-wise SBMT protocol, and each one of the upper extremity activity, the trunk and the lower extremity was taken as a reference point in antisynergic and erect posture. SBMT has the basis of principles of neuroplasticity and synergistic muscular linkage. For every upper extremity activities, lower extremity was maintained in antisynergistic pattern and erect posture of trunk and hip and knee. The program has components of trunk control and lower limb for various graded positions of upper extremity activities, and each and every activities are being graded, keeping in mind trunk and the lower limb. Dose match intervention was being provided as conventional occupational therapy. These were the outcome measures used. All are the reliable and valid tools. The brainstorm recovery stages of lower extremity, the recovery is categorized into 6 stages from no movement to near to normal movement. Fugel-Meyer assessment of lower extremity reflects to out of synergy movement. There are 18 items we assess. It is a 3-point ordinal scale from 0, 1 and 2. The total score of FMA lower extremity is 34. Barthel index was taken for the functional independence. It is a 10-item assesses the functional independence. Modified ranking scale for the global disability. The data was analyzed by SPSS 23 and chi-square for the demographic analysis, one-way ANOVA for the inferential analysis. This is the demographic data showing all the enrolled subjects. The mean age was 48.72 for the experimental and 53.41 for the control. There were 43 male in experimental and 46 in the control. They were right hemiparetic 39 in the experimental and all were equal in control. There were 64 right-handed in the experimental and all right-handed in the control group. There were 59 ischemic stroke and 61 in the control group. The duration mean was 12.4 in the experimental group, it is in months, and 13.9 in the control group. The result showing is the BRS was changed to 4 from 3.81, and in the control group it was improved to 2.85 from 2.82, and the result is showing significant improvement in the experimental group. Similarly, in the FMA LE, it was improved to 22 from 18.44. The control group also improved to 16 from 14.77. Again, it is significantly higher in the experimental group. All the subjects have reduced in their disability level as per the modified ranking scale. It was reduced to 2.54 from 3.24, and in the control it was reduced to 3.46 from 3.56. Both the intervention enhanced the lower extremity recovery. The change in the lower extremity recovery was significantly higher in the experimental group. The changes should be attributed to the utilization of various graded positions for achieving the desired movement of upper extremity. For instance, pronation and supination and shoulder external interrotation is being performed, making the patient erect standing, maintaining the trunk and lower extremity in antisynergistic pattern. Similarly, all other movements of arm and hand were also being intervened from non-weight bearing position to weight bearing position with increased difficulty level of erect sitting to erect standing, making the trunk erect in reference to the lower extremity. Cortical reorganization and interhemispheric communication plays varied role for both the limbs. For upper extremity, contralesional activity is more pronounced, and for lower extremity, both the contralesional and ipsilesional fibers play role for the facilitation of recovery. Thus, recovery is interrelated but variably presented at neural level for both the limbs. That was the reason for improvement in this study in the lower extremity. Majority of the subject exhibited change in the functional ambulation category. They were ambulation dependent for supervision pre-intervention, and post-intervention the subjects reached to the level of independent ambulation. Favorable changes and significant change in Barthel index, that is functional independence level, and modified ranking may also be attributed to this SBMT protocol, both for the upper extremity and lower extremity. Acute subjects were less in number. There were unequal proportion of female subjects. Majority of these subjects were ischemic. Lower and higher motor recovery stage patients were not equally distributed. These are the limitations of this study. In future, we can recommend that this protocol, synergy link protocol, may be done for lower extremity, including the lower extremity and trunk. Use of sophisticated tool of EMG and cortical reorganization may be studied. Hence, we can conclude that SBMT enhanced the recovery of lower extremity and functional status in stroke. Program has components of various graded and adapted postures of trunk and lower extremity. Static lower extremity control along with dynamic upper extremity control is crucial for lower extremity and hence influence the change. Motor rehabilitation integrating both the limbs need to be explored in various studies. These are my references, my sincere acknowledgement to all my guidance, and thank you.
Thank you very much, ma'am, for the nice presentation. Next, we call upon the last speaker of the session, Dr. Kamal Narayan Arya from New Delhi, to give his presentation. Dr. Kamal, please.
Can I start? Okay. Good evening to all. So the topic of my presentation is unilateral partial neglect subtypes influences the motor recovery status among the post-stroke subjects, which is a cross-sectional study. Unilateral neglect or unilateral partial neglect, in the short form I'll call it as USN, which is a disorder of spatial awareness in stroke. USN can be defined as a deficit of perception, attention, or action in the space. For instance, in this diagram or in this picture, which is drawn by one of our patients, we had drawn the clock in this way and not writing any number on the left side. USN can reduce the ability to perceive, listen, or make movements toward the half of the environment. For another patient who has eaten the material on the right side of the plate, but not taken the material from the left side of the plate. These are examples of the neglect on the left side. So it may occur in 70% of the cases of the stroke, which may affect motor recovery and functions, and may delay the rehabilitation process and prolong the disability process. So there are many ways to classify USN, but there is one way of classifying the based on the space, and which classify this neglect into three categories: personal, peripersonal, and extrapersonal. In a person, it is as the level of one's body. For instance, in the right hand, the first picture, the person is not able to stay properly on the left side. The second category, the peripersonal, that is within the arm's reach. For instance, in this picture, the same patient, he is unable to write on the left side of the body. And the third category, the extrapersonal, that is at the distance space, where the person is not able to appreciate the object in the distance space. Different USN subtypes affect motor recovery and functional independence in unique ways. Understanding how neglect subtypes impact recovery can improve therapy outcomes, and that formed the rationale for this study. So our main objective of the study was to determine the difference in motor recovery on the basis of neglect subtypes among post-stroke hemiplegic subjects. The study has been ethically approved by the Institutional Ethics Committee and has been registered in the Clinical Trial Registry of India, and the study has been presently funded by ICMR. The design of this study was cross-sectional observation study, which has been conducted in neurorehabilitation laboratory of our institute at New Delhi, and the participants were post-stroke hemiplegic subjects with neglect. The main inclusion criteria were age between the 20 to 80 years, post-stroke duration of 1 month, presence of neglect as assessed by letter cancellation test, more than 2 omission. I'll be talking about this test later, and ability to understand instructions. While the subjects were excluded if they exhibited severe aphasia, severe cognitive deficit, visual impairment, complex regional pain syndrome, and severe depression. The subjects were assessed for the neglect using 3 tests, that is line bisection test, letter cancellation test, Katherine-Barbago scale, while the motor recovery was assessed using Figel-Meyer assessment. In the letter cancellation test, subject has to cross all the O's printed on an A4 sheet of paper, 20 O's printed on the right side and 20 on the left side, and they determines the peripersonal neglect. And for instance, in this clip, the subject is crossing the O's only on the right side, but not crossing the O's on the left side. And omission of more than 2 is considered as a neglect. Line bisection test comprises of 320 centimeters of horizontal lines, and subject must mark the center of each line. Error of more than 1.4 centimeter either on the left or the right was considered as a neglect. It also determined the peripersonal neglect, and in this video also you can appreciate that subject crossing the line primarily on the right side of the sheet. Katherine-Barbago scale is basically a measure of the functional neglect. It comprises of 10 items, which is scored on the 4.023, and the higher the score indicates the higher the severity. It determines the extrapersonal neglect. For instance, in this video, the subject is trying to navigate in the corridor, and he is pushing himself toward the right side. Figel-Meyer assessment was used for the motor recovery, which has a 50-item scale, and its maximum score is 100. It is a 3-point ordinal scale, which is measured from 0 to 2. The FMA score of Figel-Meyer is divided into 2 subsections. There is upper extremity and the lower extremity. The upper extremity section is of 66 score, while the lower extremity is of the 34. The upper extremity subsection is further divided into upper arm and the wrist and hand. For instance, in the first picture is the upper arm item, the second is the wrist and hand item, which are scored from 36 and 30 respectively. There are various items, and the low extremity is scored from the 34. The neglect has been categorized in 3 categories: personal, peripersonal, and extrapersonal, based on these criteria given by this author, which is only on the bodily function tasks such as mouth cleanings for the personal neglect, only on the line bisection or line cancellation as a considered as a peripersonal, and extrapersonal is based on the Katherine-Barbago scale neglect scores. The data was analyzed by SPSS version 23. Independent t-test and Pearson correlation was utilized for the analysis. 0.05 was considered as a less than 0.5 was considered as a p-value significant. 47 participants showed this demographic statistic. Age was 56 years approximately, and there was 60% male. 9 months was the post-stroke duration. 83% was the ischemic stroke. 60% were more than the 60% were left hemiparetic, and 60% were the multiple type of stroke. There is a correlation with the CBS and the FMA, which show there is a relation with the neglect and the motor, which was minus 0.49, with the P was highly significant. Similarly, the neglect with the upper extremity was also found to be 0.42, and minus 0.42 and minus 0.53 for the lower limb. 43 subjects showed the peripersonal neglect, 57% subjects showed the extra-person neglect, and exclusively person neglect was not found in any of the subjects. Other variables such as age, gender, onset duration were not found significantly different between the subgroups. This data show the motor recovery difference between the peripersonal and extra-personal subgroup, which was found to be 60 versus 34, which was highly significant. This is the entire focal motor recovery. Upper extremity was found to be 36 versus 18, which is also highly significant. Upper arm and wrist and hand subscores were 22 versus 12 and 14 versus 5, which were also found to be highly significant. Low extremity was also found to be 23 versus 15, which was also found to be highly significant. Extra-person neglect significantly impairs motor recovery. Interaction in the distance space may be an important factor influencing the motor recovery. Extra-person neglect may lead to severe functional impairment and disability. The CBS scale also involves other type of neglect such as person and peripersonal. Neglect is a common in right brain damage up to 70%. However, 15 to 40% left brain damage may also exhibit USN. Easily discerned in acute, but not uncommon in chronic phase. The method of assessment is an important factor for this neglect. It is a complex and heterogeneous syndrome. No single gold standard assessment exists. Subject may exhibit neglect on one test such as LCT, but not on the other tests such as LBT, or vice versa. Patient with neglect falls 6.5 times more frequently, indicating the importance of low extremity in USN management. So based on this study and other literature, we propose that personal, peripersonal neglect should be taken care by body awareness, interaction with surrounding items, and sensory motor exercises, while extra-personal neglect should be taken care with the navigation, task performance type of activities. So limitations, subjects exclusively with person neglect was not found in this study. Relation between the chronicity and the USN subtype couldn't be established. We recommend to conduct longitudinal studies with a large sample size, development of a comprehensive assessment tools, and intervention strategies based on the neglect subtypes. We conclude, USN or neglect is associated with the motor recovery in stroke. Recovery of the upper limb and the lower limb were poorer among stroke subjects with extra-personal type of neglect. Identification of subtypes can lead to formation of the specific therapeutic program, enhancing substantial recovery. These are some of my references. I acknowledge the study participant, Indian Council of Medical Research, director of my institute at New Delhi. Thank you.
I would now call all the speakers on the stage.
Please, any questions from the audience to the speakers? First, you can ask question from Dr. Harshada Lenge from Mumbai. Her topic was effect of brain gym exercise on fear of fall and balance in a patient with Parkinsonism.
Any questions from the audience? Dr. Harshada, then I would like to ask one question. In your study, what was the duration of the Parkinson's, And did you look at that? How much duration? And did you include your Parkinson Plus also into this?
No, sir. After the 6 month of diagnosis, the Parkinson patient I included, there is no Parkinson plus or a Parkinsonism patient. Only the patient who are in Hoyne and Yard scale, stage 2 to 4, I included in my study after the 6 month of diagnosis.
How much time would you expect to see the effect?
Sorry, sir.
How much time would you expect after your brain gym to see the effect in fall, this fear of fall on balance in Parkinson patients?
Sir, for now, I give the for 2 week of intervention, total 6 session I given. After that, I see the result. And mostly I take a small sample size, that is a 10, to see the initial feedback of my research intervention, because mostly brain gym exercises is not performed on the adult patient or degenerative cases. So that's why I performed the pilot study to see the initial effect of my intervention. And after the getting result, it show the significant, statistical significant. So after that, I will increase my sample size according to the incidence in my clinical setups or academic patient availability.
Do you include neurologists or neurosurgeons in your study?
No, sir.
You are not in touch with them?
No, I discuss with them about my research or thesis. They also discuss about their interpretation about the most of the Parkinson patient take a levodopa. That also show the some side effect in fall and fear of fall. Because in the late stage of Parkinsonism, when levodopa is regularly patient taken, that time some on and off fluctuation they mostly go through. While they are taking medication also, they go through in the off-state episode. That time they can use these brain gym exercises to regulate that off-stage and that time they not even perform the walking or balancing to perform the ADL activities.
Any functional scans or anything was done in your patients? Your dopa, trodad scan, anything?
No, sir. For that is no.
Yeah.
I just done a MOCA scale for their cognitive and that for diagnosis Hoyne and Yard scale, and for outcome measure fall efficacy scale international for fear of fall, and mini-based test for balance evaluation.
Because just to add a point that more for your this, that if patients don't improve in your brain gym, then it's not always that patients are Parkinson's and Parkinson plus. Many of them, they might start with something which appears to be like a Parkinsonism, and later on within a year you might start seeing that they are going into a Parkinson plus, like a multiple system atrophy. So when patients are not responding, then you should always go back and again recheck your diagnosis, whether you are dealing with an MSA or certain variants like a PIGD variant where they might not show that much of improvement. So always keep that in mind.
Okay, sir. If I am increasing my sample size, I will consider that point.
That's why I told you to get in touch with clinicians for this.
Okay, sir. Thank you.
Harsha, I have one question for you.
Yes.
You described about the brain gym exercises.
Yes.
So these are already existing ones, or you have developed it?
No, sir. These are the existing brain gym exercises by Paul Dennison. He invented 26 functional movement that I certified in that. That's why I perform this. And in my parent article also, they give that brain gym exercises protocol. That is similar with the Paul Dennison who provided it. So I follow that same brain gym exercises.
Thanks for the clarification, but you need to add that whenever you are presenting,
Okay.
if you are using existing ones,
Okay.
you should give a credit to them.
Okay, sir.
Very nice presentation. You are doing good work, but this is the topic which is endless discussion. So keep it up to the best. Thank you.
Thank you, sir.
And now we call Dr. Shubham. He spoke on integrating occupational therapy with speech therapy in stroke rehab. Any questions from the audience, please? I would, as a clinician, I would just ask one question. What do you mean by integration? For my own knowledge, what exactly would you integrate occupational and speech therapy? If you could just be a little more clear in that.
Sir, we work together to enhance the practice as well, clinical practice.
For on rounds, what will you do when you see a patient suppose of stroke? How will you go about? What is the integration?
Sir, we go in ENT department as well. For they are taking speech therapy and occupational therapy as well. We work both together at the same place.
No, he is asking about integration. What to integrate between OT and speech therapy means?
You mean to say rather than sending them for two places for two therapies, the therapist both will come together at one time with the patient and discuss. That's what you mean to say?
Yes.
That is what is integration?
Yes.
Any questions?
Yeah, Dr. Shubram, it's nice to know that you are integrating with a speech therapy for delivery of care. Okay, that is interprofessional
Yes.
rehabilitation. That's what you are explaining. Okay, one group of patients you said you have integrated, like you joined with the speech therapy
Yes.
and then provided the interventions. The control group, what has happened to the control group?
Sir, they are taking standalone therapy. Either they are taking occupational therapy or speech therapy.
Is it either therapy or as Dr. Sanath has explained, like they have exclusively attending OT session separately and PT, the speech therapy separately?
Yes, sir.
Is it like that?
Yes.
Is it, they have, that means they had speech and occupational therapy but separately?
Control group were in experimental group. We are doing together in the same place. In control group, there were choices or taking speech therapy or occupational therapy.
So the control group got only one therapy?
Yes, ma'am.
And the experiment group got two therapies
Both
together?
therapy together.
There might be issues with this. Did the speech therapy, these are the students, the patients who got only speech therapy, weren't they referred to OT? I mean, there will be some ethical issues here.
No, ma'am, that's not an issue. But sometimes patient might key doctors are well settled and occupational therapists are lack of awareness.
Okay.
So,
anyway, you have to keep in mind these things.
Sure, ma'am. Sure.
Okay.
No, this is a very sensitive topic. This can be a legal issue, as she is telling correct, actually. If you are not referring the patient of stroke to OT, only doing speech, that can create a problem.
Sure.
It's not, you cannot get excuse that this is awareness, lack of awareness, no. So please keep in mind.
Sure. Thank you, sir.
Can we now move on to the next presenter, Dr. Noor Mohammed? Any questions from the audience for Dr. Noor Mohammed? There is a question, please pass the mic on to her.
With respect to your intervention part, I just want to know what will be your justification be that it is related to occupational therapy?
Because occupational therapy is working in all the domains, motor, sensory, behavior. So as an occupational therapist, I don't want to leave behind the motor aspect, although it is being primarily dominated by the other professionals. But in order to have our domains in our own hand, I want to work on the neuromuscular or the muscular aspects and the motor aspects as well.
Yeah, in a way it is okay, but you had focused only on the exercise alone. What are the occupations did you target on?
Specifically in
Because
this study,
being an occupational therapist, we have to be more occupation focused, right? So that's what, with respect to your intervention and outcome measures, you had done the quality of life and stress scores. So that is fine. But my doubt is only related to your intervention part alone.
see, the intervention part was basically focused on the motor area, but ultimately it was affecting the overall ADL and the quality of life of the person. And the females are showing the absenteeism also at the workplace. Work productivity was also getting down because of the dysmenorrhea complications. So I have not included those areas in this particular presentation, but there are other variables which were there in this study, which was more focused about the quality of life and the workplace productivity and absenteeism and presenteeism related those things.
It would also been good if you had shown the occupation part of it as well, like
Sure.
core strengthening being used during ADL and other stuff like that.
All right. Thank you.
I think she has nicely raised that question. your area of interest is good. Like OT is focusing on menstrual hygiene or menstrual care, which is really good because these are the neglected areas in our practice. So you've chosen a right area. But the medium of therapy was, you said, the core strength. For example, you talked about Kegel's exercises and all. So that is what she's raising that question. Will it be a physiotherapy, will it comes under the physiotherapy boundary or occupational therapy boundary? So you could devise any interventional strategies within our professional boundary. That is what she's trying to say. A good topic, but the medium of therapy alone should be modified.
Thank you, sir, for the suggestion. But this is the one point which I always had in my mind, that why the boundary has to be defined by the OTs only and why not the PTs or other professionals, because they are working in our domain like sensory integration or the pediatric therapist area. They are like intervening in our own domains, which are OT specific. So why to restrict my own profession only? Why not to demarcate their work as well? So that was the mindset with which I introduced myself in this area.
See, this is a negotiable, this is a debatable issue.
Right.
वो ने किया, उन्होंने किया तो मैंने किया तो उन्होंने किया. But tomorrow when it comes to identity, professional identity, these are something that have to be thought about. And what they are trying to tell you is that you could make this better by going top down or at least having a functional aspect in your intervention. Nobody is stopping you from using exercises, but using exercise standalone is the issue.
Got that.
Okay, so I think we should avoid this answer of unhone kiya, they took. I think our professional identity, our professional respect is our responsibility.
Absolutely.
And as we are saying, it's a good area. But we probably need to be more occupation focused about it. That would give us more respect. If they are doing wrong, doesn't mean we also do wrong. You know, so I think that's a valid point.
Absolutely.
And you should think about it in future.
I accept it, and thank you for the suggestions.
Yeah,
Dr. Noor, since you have touched this topic of PT and OT, I am very lucky to have my wife, Dr. Jolie, as an OT. Because before coming after MCH, I have no idea of OT. I just refer our patient to PTs, post-op and all. You understand?
Yes.
When I came to see the result of OT and approaches, I went to the Center of Advanced Neuro Rehabilitation in Women's New Delhi. I saw the real difference of OT and PT and the results and the approach what we want as a neurosurgeon in our post-op recovery patient. And I'll ask Dr. Sanad also will be in my favor. So it's a huge difference in approach and the result. You understand?
Right, I get
So
it.
don't compare OT and PT.
Sure.
And I am sure I will convince my Neurological Society of India, that is a global the society which we have an annual conference yearly. And I'll recommend as a session in OT also to include all neurosurgeons and neurologists to have the OT in their team who have the better results. Don't compare OT. There are far more difference. Nothing comparable. And I'm changing my mindset in New Delhi, in NCR region. So Dr. Shubham was telling in Indore, lack of awareness. No, this is also wrong you are calling off. No lack of awareness. You have to create awareness to show your results. And definitely things will change. Please carry on. Thank you.
Thank you for those words, sir. I am happy that my study contributed this much, that we are having this conversation about our profession.
But you have reminded us of MBBS days. Dysmenorrhea we used to study 30 years back.
But again, what is important is, rather than questioning each other, the teamwork is the most important. That
Absolutely.
it's finally it is one. What is common between occupational and physio is therapy. The therapy is the most important. You all should work as a team. Even in medical college, we are having OTs, PTs, and they both work as a team. Fine. That is the most important thing. You all should don't try to create this. In fact, teach each other and learn from each other and try to develop as a holistic this.
Definitely.
Okay, at least in the government setup, I would advise that.
Thank
Yeah.
And I am thankful to Dr. R.K. Sharma sir sitting here. He is the Dean in Santosh. He has converted most of the students who were pertaining for MBBS to become an OT. And I have seen the results also. So don't go for MBBS. If you are not qualifying, go for OT. And I'll also recommend, we also recommend.
Thank you, sir.
Happy Furre for OTs. Thank you.
Thank you for kind words, sir. Thank you.
Dr. Vijay Batra, he is from my city, New Delhi.
Yeah, thank you.
So please, any questions for Dr. Vijay Batra for regarding Bell's palsy?
Sir.
सर हम लोग तो बस पेशेंट देखते हैं, क्लिनिकली डायग्नोस करते हैं, आपके पास भेज देते हैं, हमारा हेडेक खत्म. It's your yours. I think the results are far more better as you have shown for synergistic exercises.
Definitely,
Thank
this
you.
actually is very useful strategy. What we have observed, initially we started simple with the taping and 2 to 3 months follow-up. Then we realized the synkinesis started developing after 3 to 4 months. Okay, what to do, how to go for that. So this was an issue of concern when we saw many cases suffering and complaining again. So that's why that encouraged me to go for that.
I just have one question. You described the patient characteristics. Now, did these patients receive any other therapy?
Madam, there were two things. Only the conventional therapy and function dynamic stabilization strategy. And other, they were not stopped from taking anything they want to take, but other medication they used to take initially for 1 week, that Vizol and all this, they all taken.
And what about anybody has gone for Botox or EMG kind of therapies? Were they at least documented?
The intervention, during the intervention phase, they did not prefer to go for Botox.
Before that, have they taken
No.
it? None of them
We have
have
not
taken
included, they were excluded from
Okay,
the study.
fine. Yeah, that I think you should specify.
Yeah, that
Yes.
we have already excluded from the study. Brain SOL and all these, botulinum and all this, they were excluded from the study
Okay.
at the baseline itself.
Okay, but in the inclusion criteria, I think it's
Only the 18 to 40 years of population with the diagnosis of facial paralysis, they were included.
yeah. So
And
this aspect should be mentioned.
we mentioned the exclusion criteria.
Ah,
Botox was not mentioned, I think.
Yeah,
sir.
it was not
Botulinum
mentioned.
strategy, etc., was excluded.
Yeah.
Yes.
Brain SOL and what mentioned there.
Better to be clear about that.
Yeah.
Sir, you talked about the taping technique, right?
Yeah.
Does it we need to have any specialized training on that?
Actually, this facial taping strategy that we developed in 2007.
Okay.
So we started, it was accidental research. The chance favors the prepared mind. So during 2005, I was sitting in the OPD, suddenly one child came that was 7-year-old, and how to control to teach him for the facial exercises. Then suddenly I realized simply you close the mouth and inflate air. Then we realized if we stabilize this group of muscles, so definitely the patient will improve. The results were drastic initially, we realized, but the issue arises, especially with the neurophysician, because they believe generally the patient recovers itself.
So my question is like, are there any do's and don'ts? Suppose if somebody who is listening to this presentation, and if they start trying to do the taping on their own,
they can continue. It's
that
a
is one.
specific direction of pull is to be maintained, and the direction of stretch
That
as per
guideline
the
has to come out, one. Second is, are there any adverse effects? See, you said you have taken a large number of
definitely.
patients, you
Yes.
have tried out this technique, but are there any adverse effects that has been reported?
Generally, we did not observe, but the criteria for application of the taping was we have to check for the skin sensitivity, number one, and the skin condition for initially general application of the tape on the skin for initially 3-4 days. Then we can start with the taping. And one more objective for using this taping was during the initial 2 weeks, where the functional electrical stimulation is contraindicated. This we can start within day 3 or 4. We can start with the facial taping strategy immediately.
Thank you, sir. Thank you so much.
Thank you.
Please pass the mic first row. Dr. Sujata.
Good evening. I just wanted to know what technique did you use? Did you use a facilitation, inhibition, or a corrective technique, or what was it that you
Madam,
followed?
the functional dynamic strategy, the taping technique, it involves a positioning, alignment, as well as a muscle re-education during the functional activities.
Mhm. So you have tried to use some corrective technique. Was it a corrective technique?
Definitely it's a corrective. It helps in the prevent the overactivity or the overpull of the muscles. This was the main target in the synkinesis. Does generally happen due to the polyneuronal axonal spotting.
Okay.
Thank you, ma'am.
Yeah, thank you, sir.
Thank you.
Now, we would like to have Dr. Shanta Pandian. Any questions for Dr. Shanta from the audience? Yeah, her topic was on effect of synergy-based motor therapy on lower extremity recovery and function in stroke and RCT. Any questions? Okay, I have one question, madam. Was there any sample size calculation done?
Yes, ma'am.
Okay. And that came to the number that you have shown?
Yes, 68 in each, 136 total.
Okay.
Keeping in mind 5% dropout.
Okay. And how many percent dropout?
5% dropout.
Wow, you all are good. Okay. And another question, did you have any bias mitigation strategies?
Since I have done randomization, so biasism was not there. It was a random number was generated, and the letter was, the envelope was kept with my colleague. So it was very detailed randomization. I couldn't explain due to time constraint. And on the randomization only, I have selected the subjects for the experimental and control. So whole randomization was followed in the study.
Yeah,
during
so that is random allocation. But what about...
No, for selection of subject.
What about assessment bias and intervention bias? Was there any blinding done?
Yes, blinding was at the subject level and assessor level. My colleague has taken the assessment. I have given the intervention. My colleague who has assessed was not knowing about who is getting the experimental protocol and who is getting the control protocol.
So that needs to be told. That was not mentioned, I think.
Okay, that was the time constraint, but I have done double blinded. So it was a subject and the assessor.
It's a very critical part of an RCT and has to be mentioned.
Yes, ma'am, but it was done.
Yeah, thank you.
Thank you, ma'am. If there are no further questions, we'll move on to Dr. Kamal Narayan Arya. Any questions from the audience?
If no, I'll just ask one question, sir. Any difference you noted in hemorrhagic and ischemic strokes as far as this was concerned? Neglect?
No. Actually, we couldn't find any such substantial difference clinically also or the statistically also. Because the number of hemorrhagics were already very less in number. Only 2/3 were the ischemic, other 1/3 was the hemorrhagic. So otherwise, there is no clinical difference we have noted here.
Any difference in pre and post-op hemorrhage? Either we conservative hemorrhage treatment or post-op hemorrhage treatment?
No, so
No.
no. We have hardly any subjects like that, so we couldn't, subgroups like.
So there was no one with any decompression and all these patients were excluded? There was no one?
No, actually, ours is a rehabilitation institute. It's not a medical college. So we get a lot of patients referred in forms of the recovered patients, like 1 month, like post-stroke decision was 9 months. So we have only a few patients with a post-craniotomy who were recovered, but their number is too less in the population. Yeah.
I have just one question. Was any sample size calculation done?
No. Actually, ma'am, as I told you, it's already ongoing 3 years project of ICMR in which it's an interventional studies. We have calculated sample size for that interventional. So in the phase 1, we have assessed these patients, and it was ongoing that we have realized that we have found that the neglect subtypes also affect the recovery.
Okay.
So the sample size is initially calculated for the trial, not for this particular sub-study.
It was not done for this specifically?
For this study, yeah.
So that means the participants are only from that trial?
From that trial, yeah.
Not others?
Not others, yeah.
So thank you all participants for a wonderful presentation and for exhibiting your work, and also we'd like to thank the audience for their active participation. With this, we would like to close the session. Thank you.
Thank you, dignitaries, for chairing the last session of this day. So I would like to request Dr. R.K. Sharma, sir, Dean, Santosh University, to felicitate our chairperson, Dr. Sanat Badkar, sir, Consultant Interventional Neurologist, GMC, Goa. Thank you, sir. I kindly request Dr. Manjusha Vahal, ma'am, HOD Department of OT, Tata Memorial Institute, Mumbai, to felicitate our chairperson, Dr. Sebastina Anita D'Souza, ma'am, Professor, Department of Occupation Therapy, Coordinator, Center for Healthy Aging, Manipal College of Health Profession, Manipal. Thank you, ma'am. I kindly request respected Dr. Joseph Sunny, sir, Honorable Secretary of All Indian Occupation Therapy Association, to felicitate our chairperson, Dr. Vishal Jain, sir, Senior Consultant, Department of Neurosurgery, Shadak Care, Health City, New Delhi, NCR.
Thank you, Ota, for inviting me in this conference. I am attending this conference on behalf as a husband of a occupational therapist, and I am attending for the first time. Thank you, Dr. Vivek and Dr. Chetan, for giving me the opportunity to talk here. And
Thank you, sir. I would like to invite Dr. Vijay Suple, sir, Senior Occupation Therapist, Canada, to felicitate our chairperson, Dr. Samuel Kamlesh Kumar, sir, Professor and in charge of Occupation Therapy Services, Department of Occupation Therapy, CMC Vellore. Thank you, sir. There is a kind information I need to deliver to the respective delegates that our GB meeting will start here, so kindly be seated. Only IOTA members are requested to stay back in the auditorium to attend the GB meeting. I would like to conclude the second day of OTCon 2025. Dear participants and professionals, as we come to end of day 2 of OTCon 2025, I want to thank everyone for their active participation and insightful contribution. Today, under the theme Translating Research into Policies and Clinical Practices, Occupation Therapy, we explore innovative ways to bridge researches and practices, ensuring our work creates meaningful impact. A special thanks to our speakers, panelists, and participants for sharing their expertise and inspiring distributions of knowledge. Let's carry this momentum into day 3 of OTCon 2025, where we will continue to learn, collaborate, and innovate. Thank you, and I look forward to see you all tomorrow. Have a great day. Thank you. For your kind attention, I would like to inform that only students and delegates who are IOTA members kindly stay back in the auditorium for attending your GB meeting. Only delegates. So only IOTA Life members kindly stay back in this auditorium for attending the GB meeting.
Transport is arranged for dinner for student delegate 6:30 onwards from Kala Academy.
For all the student delegates, there is a transport that has been arranged for your dinner. From Kala Academy to the community hall.